All right, we are just at 10 o'clock, so I'm going to kick things off for today. Welcome back to the second day of our pre-rulemaking measure review hospital recommendation group meeting. I hope that everyone had a restful evening and is ready to come back and engage in some great discussions again today. We can move to the next slide. So just like yesterday, we will do a brief roll call. We'll also do a voting test, and then we'll aim to start reviewing measures at around 10:20 with a lunch break at noon. We'll then resume our reviews of measures. We hope to adjourn by 5 p.m. We will have a little bit of time at the end. We hope to collect your thoughts on how things went this cycle, get your feedback on this meeting and the events leading up to it. So please, as we go through today, do keep in mind things that went well, things that maybe could have gone better, and we'll revisit those with you at the end of the day today. We can move to the next slide. And again, just want to thank everyone, CMS, the developers, our committee members, of course, for joining us today. We recognize that this is an intense 2 days of conversations, and we really appreciate your participation and engagement in our process and these discussions. Can move to the next slide. So I'm going to go ahead and turn it over to my colleague, Kate Buchanan, who's going to do a roll call.
Great. Thank you so much, Meredith. And welcome back, everyone. If we move on to the next slide, we should have our list of committee members. So most of you were here tomorrow. We do have a committee member who's able to join us today who is not here tomorrow, so I will ask her to complete her verbal DOIs when I do call on her. But for everyone else, if you just wouldn't mind saying here, that way we can make sure your audio is working. Want to again thank our advisory group members. The reason we are doing roll call for recommendation group is for voting quorum purposes, but I don't want anyone to think that we're not immensely grateful that our advisory group members are on here. This is for our quorum tracking purposes. So we're gonna start with our co-chairs, Darlene. Is Darlene on? I am not seeing her. Julie? Okay. Terry?
I'm here.
Great. Rosie?
I'm here.
Thomas?
Here.
Michelle?
Here.
Wonderful. Jeff?
Here.
Nick? Okay, not seeing Nick yet. Thomas?
Here.
Caitlin?
I'm here.
Marty?
Here.
Sandy?
Here.
Great. And I don't believe that Abby Khan was able to join us today. Mike?
Here.
Stephanie?
Here.
Talithia? Okay, we'll wait for Talithia. Anne-Marie?
Here.
Ben?
Here.
Bridget?
Here.
Vika's not able to attend. Kathy?
I'm here.
Great. And then Jessica Schumacher, could I ask you to introduce yourself and provide any verbal disclosures of interest?
Yes, hi, Jessica Schumacher, University of North Carolina, Chapel Hill, and no disclosures.
Great, thank you. Jeff? Jeffrey on? Okay. And then Christopher Wilson had a clinical conflict that came up. I do see Darlene is on. Is there anyone else on the recommendation group who's joined who didn't get a chance to do a quick audio check by saying here?
Julie Marsnick, I'm here.
Thank you.
Sorry, signed on to the wrong link first.
No worries.
This is Jeff Soberswag.
Thank you.
Good morning, Talithia is here.
Wonderful. Anyone else? Okay, I will turn it over to you, Meredith.
Great. So this is now time for our voting test, just to make sure everyone has their link and can submit their votes. So I'm going to turn it over to our voting lead for today, Elena Hughes.
Thank you, Meredith. Good morning. Hi, everybody. We are just going to be going through a couple of voting reminders this morning and then going through our test just to make sure everything is up and running. So today at around 9:50 this morning, just before our meeting got started this morning, we did go ahead and resend you an email containing the voting link to the members of the recommendation group. So if you could just take a moment to look in your email, that would be coming from pqm@battelle.org, the subject line containing the phrase voting link. So you can find your link there. If you can't find it, let us know via chat and we will send the link to you directly. As a reminder, this link is exclusively for the committee members on the recommendation group, so please don't share the link with anyone else outside of that. I do see a question, is it the same as yesterday's link? Yes, if you have the link from yesterday, you can use that as well, but if you need it at the top of your inbox, we did resend it to you this morning. A couple procedural voting reminders. Throughout today's meeting, just go ahead and keep the voting window open. Once you access the voting link, you will be prompted to enter your name. Please make sure you enter your first and last name and then click continue. After you have entered your name, you will see your full name and initials in the top right corner of the voting screen. And just make sure those initials look familiar to you. If you missed the pop-up, enter your name when you opened the link. You can go ahead and click that little icon that's in the top right corner of the screen to change your name if you were assigned a randomly generated name. If you close the voting window at any point, you will need to click the voting link and add your name again. After entering your name, your screen will display waiting for a PQM presentation to begin. Once voting opens, the multiple choice question and answer options will appear. There will be two tabs. The first tab will display the measure, and the second tab, which has a little pin icon up at the top of the screen, is entering a rationale only if you voted to not recommend a measure. To provide a rationale, if you vote not to recommend, you can go ahead and click the tab with the pin icon, type your explanation, and click submit. You do not need to use the thumb up or thumbs down feature. Another reminder about that rationale is that it will be anonymous to the other voting members. However, all of the voting members, regardless of if they voted yes or no, will be able to see those anonymized rationale in real time. If at any point you encounter challenges with the voting platform, you can send your vote directly to me in the chat. And with that covered, we will go ahead and get our voting test started for the day. So in just a moment, you will see that vote pop up on your screen, and we will also share it on the screen up here for you. I believe we are expecting to see 20 votes, so we will wait for those to come in. Again, if you're having any trouble with your link or anything like that, please do go ahead and let us know in the chat, and we will work with you on that. Our kind of first recommendation, if something doesn't seem to be working, is try refreshing your page. Sometimes that does get things to pop up for you. I think we have a question. Ethan, do you have a question about voting?
I apologize. That was an accidental click. I apologize.
No worries. Thank you. Just want to make sure we're getting all questions addressed. All right. It looks like we have all the votes that we are expecting. So we can go ahead and close our test vote. Okay, so for our voting test question today, which I forgot to read out loud, my apologies. If meetings had a soundtrack, what would it be? We have option A, elevator music with 48%, or option B, silence with occasional dramatic drum rolls at 52%, which is our winner for today. So now that we are all good to go there, again, if you have any issues throughout the day, please message us or me directly in the chat, and I'm going to hand it back to Meredith.
Thank you so much, Elena, and everyone for doing that test vote. I have to share the disappointing news that we do not have drum rolls prepared for today's voting. So if anyone wants to sing or, play a tune during voting for our measures, you're welcome to do so. Before we get into our measure review discussions today, we did want to circle back and share the votes from our last 4 measures from yesterday afternoon. These are the excess days in acute care after hospitalization for a series of diagnoses and conditions. So those results are on this slide. For MUC 2025-053 for diabetes, consensus was not reached, but the majority of the committee expressed some support for use of the measure in the hospital inpatient quality reporting program. For MUC 2025-030 for acute myocardial infarction, the committee reached consensus agreement to recommend the measure for use in the hospital IQR program. For MUC 2025-031, hospitalization for heart failure, the committee reached consensus agreement to recommend the measure for the use in the hospital IQR program. And lastly, for hospitalization for pneumonia, the committee reached consensus agreement to recommend the measure for use in the hospital IQR program. So we just wanted to circle back and make sure we filled everybody in on those voting results. I think we can move along to the next slide. So before we begin our first measure review discussion, I just wanted to remind everyone of kind of the general flow, the structure we're using for today's discussion. After we review a slide with some basic measure characteristics, I will turn to the CMS medical officer to provide some remarks about the rationale for including the measure in the designated program. Then I will summarize what we've heard via public comment and also a brief literature review we've done on closing gaps of care. After that, we will start with our advisory group members. So if you have an AG next to your name, this is the time for you to let us know what the key priority topics are about the measure that you're hoping the recommendation group will discuss further and consider in their vote. Then we will turn to our patient committee members, both advisory group and recommendation group, to provide their perspectives and their input on what the priorities are for this measure. Lastly, we will open it up to all of our recommendation group members, taking into account the input from the advisory group and the patients on both groups. The recommendation group will further discuss the measure, and we will then lead to a vote. And again, we're voting on each measure in each program separately. And we ask that you please provide your rationale if you vote to not recommend in the software, even if your rationale is the same across programs. So I hope that is a helpful reminder. We will also put in the chat sort of that cheat sheet that we shared yesterday, just for everyone's awareness. And we can get started on our first measure today, which is hospital harm, post-operative venous thromboembolism, MUC 2025-067. So we can move on to the next slide. So this measure is the proportion of inpatient encounters for patients age 18 and older who have at least one surgical procedure performed inside the operating room during the encounter and who suffer the harm of a post-operative venous thromboembolism, or VTE, during the encounter or within 30 days after the first surgical procedure. This measure is adjusted by patient-level factors, such as bleeding disorders, cancer, respiratory operations, central venous catheter insertion, vascular surgeries, obesity, stroke, and history of VTE. This is a measure that is stewarded by CMS, and it is being considered for the Hospital Inpatient Quality Reporting Program, Hospital Acquired Condition Reduction Program, the Medicare Promoting Interoperability Program as well. This is a facility level outcome measure, and this measure has been submitted for endorsement in the fall 2025 cycle, but it has not yet been reviewed, so there is not yet an endorsement decision on this measure. So with that brief overview of some measure characteristics, I'm going to turn it over to Dr. Ron Klein at CMS for some remarks about the rationale for this measure.
Gotta remember to take myself off of mute. Good morning, everyone. Thank you for joining us again this morning. My name is Ron Klein. I'm the Chief Medical Officer for the Quality Measurement and Value-Based Incentives Group within CCSQ. My training is as a pediatric hematologist oncologist, so 20 years of practice, full-time practice before I decided to come to the government and work on health policy. So this is a measure that's near and dear to my heart. The CDC reports that up to 70% of healthcare-associated venous thromboembolisms are preventable with anticoagulants or compressor stockings, yet fewer than half of those hospital patients receive these measures. Evidence shows that integrating evidence-based guidelines into local protocols boosts the numbers of at-risk patients getting proper thromboprophylaxis. So this measure can potentially reduce VTEs post-surgery. And I will just say, and I think certainly the clinicians know this, but for the non-clinicians, a venous thromboembolism or venous thrombus, if you will, is a clot that you may have at a surgical site or you may develop because you're immobilized in bed. But the life-threatening part of it is when that clot breaks off and goes to your lungs and you suddenly can't breathe. And that's quite often it's a sudden death kind of scenario. In alignment with current evidence-based guidelines, CMS is evaluating the inclusion of the newly developed postoperative venous thromboembolism measure into the inpatient quality reporting program, the hospital-acquired conditions reporting program, and the promoting interoperability program. As was said before, the measure assesses the proportion of inpatient encounters for patients 18 and older who have at least one surgical procedure performed inside the operating room during the encounter and who suffer the harm of a postoperative VTE during the encounter or within 30 days after the first surgical procedure. The measure is risk adjusted, and the risk adjustment model accounts for patient age and sex, as well as for bleeding disorders. Cancer patients are obviously at greater risk of clots because the cancer process predisposes them to increased coagulation. Respiratory operations, central venous catheter insertions, vascular surgeries, obesity, stroke, and history of VTE. The VTE measure aims to improve patient safety by preventing postoperative VTEs in surgical patients, preventing VTEs, including DVTs, which are deep vein thromboses, and PEs, pulmonary emboli, is crucial as they can lead to poor outcomes like post-thrombotic syndrome, bleeding from anticoagulants, and death. Administering appropriate prophylaxis for at-risk patients can help hospitals reduce VTE occurrences after surgery. This ECQM, it demonstrates high importance, feasibility, and reliability, as well as moderate to high validity and usability. There is a performance gap among hospitals, even after applying risk adjustment, showing that there are opportunities for hospitals to improve their prevention of postoperative VTE. The measure demonstrated excellent reliability with a signal-to-noise reliability score of 0.9. Feasibility findings demonstrate that 100% of the data elements used in the measure scores are captured within structured fields of the electronic health record. CMS acknowledges, and I think this is important for so many of the measures we talk about, that preventing 100% of post-surgical VTEs is unrealistic, but we can do better. The aim of the measure is to reduce the likelihood of post-surgical VTEs. The HHVTE measure is risk adjusted, as I said before, comparing actual VTE events to predicted events based on patient risk profiles. This ensures accurate accounting for these cases. The initial measure takes a data-driven approach to reduce preventable postoperative blood clots and improve patient safety. The goal is to improve this measure with future iterations. The measure has been submitted to the fall 2025 CBE cycle with results pending at this time. With that, I don't know if it's my job to say I'm opening up for discussion, but with that, we're going to open it up for discussion.
You're on mute. We can't hear you.
Oh my goodness, I apologize. I was on mute. Thank you, Dr. Klein. Before we do open it up for discussion, I did want to summarize what we heard on public comments for this measure. We received 14 written public comments on the measure, but we did not receive any spoken public comments during our listening session. Echoing some of the points that Dr. Klein made, public comments highlighted the importance of this measure, noting that the incidence of VTE shows the ongoing need to minimize risk and enhance patient safety. Commenters noted the strong evidence base that supports various preventive strategies, some of which Dr. Klein mentioned for VTE, and voiced support for this measure's potential to incentivize hospitals to adopt those evidence-based strategies to prevent VTE and improve patient outcomes. In terms of concerns, there were some public comments expressing concern about the measures focused on surgical patients, which represent only a fraction of hospital-associated VTE cases. With regard to setting, another comment requested clarification on whether the measure intends to exclude procedures performed in settings such as interventional radiology, cardiac cath labs, endoscopy suites, or post-anesthesia care units. This commenter expressed concern about sufficient guidance to ensure consistent application of the inclusion criteria, given the variability in where invasive procedures can take place across hospitals. Comments also raised questions about the appropriateness of the measure's 30-day window for monitoring post-op VTE outcomes, noting that the evidence base for the selection of 30 days requires clarification, given that hospitals are not responsible for patient care after discharge. Other comments suggested that the measures should incorporate social risk factors in the risk adjustment model to adjust for the variables outside of the hospital control during that 30-day period. Public comments expressed concerns about data capture in the EHR, particularly for those VTEs that occur post-discharge outside the reporting hospital system, and raised concerns about inconsistent patient identification and incomplete numerator capture, which threatens the validity and fairness of the measure. Commenters expressed some concern about the limited validity testing of the measure prior to broad implementation, and noted, as Dr. Klein also noted, even with optimal care, not all VTEs can be prevented, and encouraged the use of measures that assess adherence to guidelines rather than expecting unattainable outcomes. Lastly, comments expressed concern about potential negative consequences, including the potential to incentivize overtreatment to avoid VTE, resulting in bleeding events. So that's a summary of what we've heard from the public on this measure, and we can move to the next slide to just review what the literature review shows about closing gaps of care. I did just want to note again that this measure is risk adjusted by age. The literature shows that patients 55 years and older are at increased risk of developing serious and potentially deadly blood clots in the form of VTE. When we look at differences by geography, we find that the age-adjusted mortality rate from pulmonary embolism deaths is higher among patients from rural settings as compared to metropolitan areas. The literature shows that the total costs related to VTE over 12 months is $33,000 on average, which makes care difficult to afford for the uninsured. And lastly, literature shows that healthcare providers may inadvertently communicate with patients diagnosed with VTE in ways that fail to inform them about the disease process, cause harm by unnecessarily escalating fear and concerns, and lead to ambiguity and uncertainty, causing persistent anxiety. So that's the summary of our literature review. And as we open it up for comment from our advisory group, I do just want to remind folks, if you're using the chat, be sure to select everyone from the dropdown so the public and the others attending can see your chat and see how we're contributing to the conversation. And we'll start with our advisory group member. So Mary, I see you have your hand raised.
I do. Thank you. I recognize the importance of this measure and I fully support the spirit of it. However, after navigating electronic clinical quality measures and navigating abstraction, I see a potential for over-identifying patients in numerators and denominators. just the fact with the anticoagulation ordered, those can be used for other things. Not only prophylaxis, it could be used for AFib. So there would need to be something put in place to identify all of those disorders. I saw the list of all of the data elements, and it's extensive. I don't think I've ever seen a list that large on electronic clinical quality measures. So the resource needed to validate this will also be extensive. And I also agree with the comment on the 30-day metric. Yes, it is important that we provide instructions and also any kind of pharmacological therapy or exercise, et cetera, on patients after they're discharged. But if a patient is, say, discharged to a skilled nursing facility and that skilled nursing facility leaves this patient laying around without it and not provide the appropriate care, that will fall on the hospital. And so the concerning part is the hospital acquired condition penalty. I also see, we have PSI, I think it's 12 that covers postoperative VTE prophylaxis. And I'm wondering why the need to go more extensive on this, because it does capture. Thanks for listening.
Great. Thanks for those comments. So just to reflect back some of your concerns, the concerns about the data capture, given the extensive list of data elements included in this measure, concerns about the 30-day window especially for things that happen outside the hospital. Did I miss anything, Mary?
Comorbidities.
Comorbidities and then the
on
PSI.
Anticoagulations, yeah. And then also one other thing, well, I forgot to say, often we've had measures for a diagnosis pulled from the problem list, and and I'm just talking about a STEMI measure, and this really impacts the quality, because if a problem list is not reconciled at a hospital, then and it should be, but the problem list is a problem. We can't even code from that. But if the VTE was from another encounter, it could bring a false positive if the problem list is used.
Great, thank you. And I'm going to ask Dr. Klein, would you be able to speak to how this measure differs from PSI 12? We received a question about that in the chat.
Yes, I'm sorry, I can't speak to that, but perhaps the measure developer can, if they're on the line.
Hi, yes, this is Ngozi. We did build this measure based on the PSI 12, but there are subtle differences between the measure. And I would like to call on my developer, Ethan, if you can speak to the differences.
Certainly. Good morning, everyone. So let me so I think among the differences are the measures have different exclusions. So for example, the PSI 12 measure excludes HIT, heparin-induced thrombocytopenia. It excludes vena cava interruption procedures. So I think that's one major area where they differ. But I think fundamentally, beyond that, the main difference is that this measure, the postoperative venous thromboembolism measure, is an ECQM, and so it is able to draw on a much richer set of clinical information than PSI 12, which is exclusively pulled from the claims. And the other piece is because this measure is an ECQM, it can pull from a much broader set of patients. It's not limited to patients who are specifically captured in Medicare claims data.
Great, thank you for that. And also wanted to point out some information that's been provided in the chat. one addresses Mary's concern that anticoagulants are identify patients in conjunction with an imaging study, so patients are not identified just based on an anticoagulant order. And then there's also a message about the comparison of exclusions between PSI 12 and this measure. Let's hear from more of our advisory group committee members. Zahid Butt.
Yeah, hi, good morning. Thank you. So this actually brings back some memories for me because there used to be a VTE6 measure at one point, many years ago, which was the incidence of hospital-acquired thromboembolism for patients that were not anticoagulated in the hospital, as in the VTE1 and 2 process measures, right? So it was meant to be a sort of balancing outcome measure to see which patients did not receive thromboembolism prevention measures and then developed a VTE. And as was mentioned yesterday as well, that the devil always in these ECQMs is in the detail many times. And if I may take just one more minute to identify why I think that measure ran into trouble at some point when it became an ECQM as opposed to the abstracted measure that it used to be. Because the measure specifications said that the diagnosis had to be coupled with the procedure, which is the radiology procedure. And the radiologists refused to make a diagnosis, quote unquote, because they said they only did the procedure and provided the result, and the diagnosis is done at the encounter level when the coding is done. And the counting and the measure steward insisted that no, the diagnosis of VTE that was not present on admission had to be coupled with the procedure report. And so that kind of was almost a unbridgeable gap, and it ran into all sorts of problems. My guess is that the current stewards have addressed those type of issues in terms of the diagnosis. The other thing is that typically the surgical record does not have ICD-10 coding in it. And so the procedure ICD-10 codes come from the coding that happens at the encounter level when the coders do the coding. So these are some of the, sort of technical issues, but the measure that was there, the VTE6, was a more broad measure. It was not limited to a subset of procedures that are performed in the operating room, which this measure is. This is very narrow in terms of, as somebody already pointed out in the public comments, that a lot of procedures, very, very significant procedures, are now done in various settings and not specifically in the OR. But this will now have to be linked from the ICD-10 procedure code that is done by the coders to having been performed in the operating room. And so this is sort of some of the inside baseball kind of discussion, which I am sure with the testing that they did, at least in the Cerner and Epic instances, perhaps were resolved. And so those be the sort of comments. It's a very important measure, as you can see, that it's a nice coupling measure with the VTE 1 and 2 because they are process of care measures. And you could potentially even make a case for maybe doing a stratification of those patients that receive anticoagulation and those who don't, and what the incidences of VTE acquired inside the hospital are between those two. But I think, the recommendation group should address the importance of this measure in one form or another. And I think it would be a great addition to the VTE 1 and 2 measures.
Great. Thank you so much, Zahid, for that background, including lessons learned from VTE 6. I did want to let folks know that Ngozi from CMS did provide some background on how this measure interacts with PSI 12. So PSI 12 is a component measure in the PSI composite, and the intent is to see how the new ECQM matures before making a replacement of that measure. So just wanted to bring that out to everyone. Jan, you have your hand up.
I do, thank you. I think I have a little bit of a different concern about this measure as far as content, substance, and the care. Having been a patient who underwent a high-risk procedure and was on these medications for a while, this is so critically important. However, in the process of developing the EQCM, and specifically in Criterion C, it talks about the subsequent encounter within 30 days for after the first surgical procedure. I believe this measure, as currently written, has an inherent bias against healthcare systems that have say, your entire system uses a particular vendor. Hence, you can see the encounter. I'm going to pretend my patient has an procedure in an academic medical center. 20 days later, after the procedure, they are back in their community setting and have an inpatient admission to the community setting. The specifications do not, in this case, a enterprise-based EMR would show more of the VTEs and readmissions than a hospital who uses a single isolated EMR and does not have access. So as I look at this measure, I think, and maybe CMS can clarify this, but I believe that because of this potential bias against hospital systems that use an EMR and all hospitals can see the data, that it needs to clearly define, this is back to the same hospital, or how are you going to deal with this inherent adverse bias for large healthcare systems that use a single EMR. I also wanted just to express, I can see that these hospital harm measures, there's other ones that are already approved, are an attempt to eventually replace the PSIs. I think CMS needs to understand from a hospital perspective that in some of these measures, it's kind of a double penalty. You get it in value-based purchasing and you get it in HAT. And I think a single penalty for a measure should become a standard. So thank you very much.
Thanks so much for those comments, Jan. I did want to note the developer has put some information in the chat about the 30-day window and evidence to support that. Just another reminder for folks, please, if you are making a comment in the chat, please select everyone. If you just send it to hosts and panelists, not everyone can see your chat. So just please be sure that you're selecting that from the drop down. I did want to also call out, Sandy, we haven't yet gotten to the recommendation group, but Sandy Hyde has made a comment about how the hack penalty may be biased against low volume small hospitals, but we can get back to that in a few minutes. And then David, I think you are next.
Thank you. So agree with a lot of what's been said so far by Mary and others. Appreciate the link there to the 30 days, but I still feel that's not a very, robust rationale saying that 30 days, the hospital's on the hook for that afterwards. Also agree for similar reasons that it's duplicative with existing VTE measures. I don't know a single shop that doesn't spend a lot of time already thinking about VTE, and I don't know that there's a big gap here that we need to increase the pressure on that. Every shop, I think, is always thinking about this and always spending a lot of time working on VTEs, and so I don't think that we need to up the ante on that personally. I also agree with the comment about shops that have split EMRs this is going to perform very differently than shops that have a universal EMR across their medical group and hospitals, because the ability to capture that data is going to look very differently in those two instances, and is going to underreport when you've got a split EMR, and so they're going to make those shops look like they're doing wonderfully just because they don't even know that the VTE happened other places. And along with that validation, if I read it right, this was a very Epic-centric validation. There was maybe one other EMR that during the validation stage was looked at, but it was trained in Epic shops and validated mainly in Epic shops. And so this could look very differently in other EMRs, because as Mary said, this is a very complex metric set that they're pulling from, and so that could be pulled very differently in other EMRs. And so this goes back to my other comment. For all of these, very complex technical issues, I would much rather this finish the endorsement process before coming here, so that we could have had some of those technical concerns, somebody smarter than I am, dig into those a little bit deeper, other than just the measure steward. Thank you.
Thanks so much, David. Those were really important comments. And I wanted to turn to another David before I go to David Levine. David Kroll has an unstable internet connection for a verbal comment, but he did just put a note in the chat to push back on the argument that hospitals cannot control what happens after discharge. He is saying that hospitals can influence what happens after discharge by anticipating problems and treatment breakdowns, and by partnering better with institutions and practices in the community. So that push towards better integration leads to better care. And I see some folks agreeing with that comment in the chat as well. David Levine, you are up next.
Great, thank you. David Levine from Vizient. Agree with a lot of what was said, so I'll try not to be redundant. I really, am concerned about the testing on only the one system with Epic, and even the potential of even everyone's on Epic, there's not one instance of Epic, and really making sure that, you're not unfairly looking at systems that are better integrated with an EHR versus those that are not, and capturing this is a very complex measure to collect as an e-measure. So I think it needs much more time and testing. Secondarily, as noted, I worry about the overlap with the PSI measures and other measures there. I think this should be better fully vetted, and then a full plan, if this is the better measure, which hopefully it will be over time, as a replacement instead of an add-on, because then it's a burden where people are chasing measures that are similar but not exactly the same. And there is, as noted by my colleagues, a lot of attention already in VTE. There needs to be continued work, but I'm worried that this will cause more of a scattered approach than a focused approach to taking care of VTE. And I'd really urge, we do have a consensus-based endorsement system set up. I would push, and it's already on schedule for fall of 2025. I don't see the rush in putting this through without putting it through the full cycle. Thank you.
Thank you so much for those comments. I did want to turn it over to our patient participants. So both, if you're on the advisory group or the recommendation group, now we'd love to hear from you. There are some comments already in the chat. I see Kristen indicated that as a patient with bleeding disorders, she is glad that there are adjustments for that within this measure. And then there was a question about if women undergoing C-sections are included in this, and then it was clarified that obstetrics are excluded. Are there other patients who haven't had a chance to chime in and want to talk about their perspectives on this measure? We want to make sure that we hear from you. Rosie, yes.
Well, first of all, because I really care about this kind of people with VTEs and really, this is a hospital harm post-operative VTEs. I I understand your concerns, and I understand the concerns of the other the AG members, but also, when you have a surgery and then you have this kind of complication on top of it, you have a much bigger chance of either having a VTE that passes through your lungs or heart, and that's usually pretty much a death sentence. So, I understand that that this measure is in the cycle right now that's going through the measure submission for endorsement, and maybe that's where we need to leave it. But I also understand that this is really, really important for lots of reasons. And I also understand that, this is, the old measure was, I think, for 65 and older, and this is from age 18 to older. And so I think it's real important that we sometimes let the process, catch up to the system. But, I think it's really important that we look at this measure not only by the consequences that might happen for the hospitals, but also the consequences that might happen for the patient.
Thank you, Rosie, for recentering us on the patient perspective. Marty, I believe you have your hand up.
I do. I appreciate the inside baseball conversation. It helps me learn. I find myself landing where Hamid did with a lot of the considerations that have been raised. I think should be considerations, but the rush to move forward on this is the performance gap. There are already measures out there with penalties, and we still see this performance gap, then the job isn't done. And there's 50,000 of these, according to the rationale from CMS, 50,000 VTEs post-operatively that happen every year. I mean, if anything, I'm concerned about the narrowness of this, not being broader in scope. But I do think there's a compelling reason to move forward just because of that performance gap. I've got sympathy for the 30-day discussion and, discharge to places where hospitals may not have control, but I agree with David that they have influence, if not control. And I'm less sympathetic to the systems issues, Jan, that you raised, because who's going to fix that? The integration of EHRs across systems, that has to be the enterprise responsibility to address those issues. It shouldn't be used as a way to not move forward in a way that can save lives. I mean, the acuteness of the harm that happens here is just compelling to me. So for that reason, I'm gonna recommend, but with the considerations that Hamid, Jan, David, and others raised. Thank you.
Thank you, Marty. I'm going to turn to Ngozi from CMS next, see if there's anything you've heard that you wanted to clarify or respond to.
Yeah, I did want to make sure I understand what's being said. Are we concerned, I shouldn't use the word objecting, are we concerned about this measure going to IQR or going to HACRP? Because, obviously one is pay for performance and one has the penalties and everything that goes with it. So it'll be great to understand if your concerns are towards it going to both programs or just going to a penalty program, just for my note-taking purposes and planning purposes.
I don't see that folks are rushing to answer your question, Ngozi. We do vote on the measure separately, so that should give some data around that issue. Sandy Hyde has put in the chat that she has concerns particularly around the HAC program. Others are echoing that. Julie, did you want to weigh in on that question, or did you have something else?
I think I am hearing a bit of both, that definitely it going into the quality, the pay for performance, having some concerns. But I think what I'm hearing is not being clear what this is offering that is not being functionally already captured by PSI 12. And then just some of the concerns of implementation and all the other things that are being talked about. I also just personally had a question. I'm surprised that like AFib is not being addressed in the exclusion criteria or things like that. That for me, the obvious clinical kind of confounder in all of this is that one of the other very common or more common postoperative complications is AFib. And that would be another very clinically appropriate reason why somebody would be started on new therapeutic anticoagulation. And I'm not seeing a way that those circumstances would be distinguished out in this. I mean, post-op patients get VTE rule-outs all the time. And if you just the fact that they had one done, but there's not a way to distinguish out clinically why was this anticoagulant started, I just feel like you're going to get a lot of noise. Has that showed up anywhere in the testing of this?
Great questions, Julie. Let's see if the measure developer can address that. And then I'm also seeing a question if the measure developer wanted to weigh in on the potential of biasing enterprise health systems with enterprise EMRs and versus others with a split EMR. If they wanted to weigh in on that as well, I think that would be great.
Hi, this is Anita from Mathematica. I'm addressing the AFib question. So for this measure to count, it would need to have had that diagnostic procedure and that medication. So for AFib, it would be handled differently. It would be that different diagnostic procedure. So they would not fall into this. And therefore, the hospital would not be held accountable for that harm.
But what if the diagnostic procedure was negative? I'm not seeing a way that we are capturing, yeah, we scanned them for a clot and it was negative.
If you scan them for a clot and it's negative and they are, I guess I'm trying to understand the circumstance here, because if they have AFib, if the treatment is for the AFib versus ruling out the VTE, why would they have the diagnostic procedure?
Why would they have
the interventional, going down for that ultrasound or other radiology? I'm trying to parse out the.
I would say that probably happens fairly commonly for the myriad of reasons why you might be a little swollen postoperatively, or you're developing AFib, and so you have a little bit of heart failure related to that. It's pretty knee-jerk to just rule out a DVT pretty quickly because it's cheap and we're all so aware of, the risks and the importance of it. And so just clinically, I could see a lot of noise happening there that, I don't know, we do a whole rule out DVTs clinically and a whole lot of them do come back negative.
But that medication has to be started within 24 hours of the imaging study. So it's that cause effect. Wait, you're on mute. Julie, you're on mute.
Oh, I just think there's a whole lot of clinical muddiness that this is at risk of not capturing.
Okay, so thank you for that discussion. And I think we're now shifting to all recommendation group members. Based on what you've heard from the advisory group, from our patients, what are you wanting to get addressed so that you're comfortable kind of with a vote on this measure? Stephanie, you've had your hand up for a while. What are your thoughts?
So my thoughts are probably not, they're probably not the common path. I've been dealing with this measure for quite some time. We study our VTEs every incidence. Typically, the trends are with joint patients and then abdominal surgical patients. It is frustrating to me that this is the measure that we keep hitting over and over again and going way back to VTE 1 and 2 from the skip measures because I'm old, way back that far. Was VTE prophylaxis in place on the day of or day after surgery or the day of or day after ICU admission? What we're getting to is risk assessment of the patients and frequent risk assessment of the patients. And that's the piece that in my hospital we've struggled with. I understand the concept or the idea that hospitals can make the surgeons do A, B, and C. And then I'd love for anybody to come to my community and try it. It doesn't work. It has to be their idea or we get nowhere. And it's very frustrating that there's not a mechanism for risk assessment. And to me, it should come from the American College of Surgeons and AAOS. And this should be a national standard across the United States. Patients coming into the hospital, particularly elective schedule patients for those specifically, and then behind that, any emergent surgery patient as well. But patients need to be told what their risk is for VTE. They don't want to wear the SCDs, even given that. And then chest guidelines say that aspirin and SCDs need to be in place for 18 hours in order to be therapeutic. And that's not great for patients. The SCDs are uncomfortable, they're hot, they're clunky. So, and I mean, COVID made it all worse by people not being able to ambulate. In my mind, there needs to be attention paid to hospitals need to, including mine, have a standardized protocol, but there has to be support from the American College of Surgeons and the AAOS and any other college of whatnot for surgeons where they are held to that standard and they understand they must risk assess their patients. There are pieces of software out there, but they're very expensive and then they don't flow well in the physician's workflow. So we don't have one. The VTE surveillance under Cerner that we've looked at, Oracle now multiple times, is expensive and it required the physician to leave their workflow, which took up more times. Anyway, I think more attention needs to be given to the VTE risk assessment, the establishment of protocols, and then I think it has to be twofold. One, in the hospital direction, and two, it has to come from the leaders of all of the societies or academies or colleges of regarding the physicians.
Thank you, Stephanie. So really emphasizing the importance of establishing protocols for risk assessment for patients on VTE and, calling for guidelines around that, guidelines and protocols around that.
Right. Issa said in the comments, and I commented on it, that the state Senate in Florida recently passed a House bill to address that, but it should be national standard.
Thank you. And thank you, Isis, for posting about that as well. Michelle Dahl.
I just had a question around the timing. So the 30 days was brought up as potentially problematic, and I understand that there's a risk that exists still within the 30 days. But my understanding, granted, I'm infectious disease, not a hematologist, this goes out to like 3 months after surgery. There's technically a risk. My question is, for the makers of the measure, I'm trying to understand the actionable thing that they would like hospitals to do to prevent VTE after that like 2-week mark. So once the patient's out of the hospital, we've done the prophylaxis and they're home. I guess my understanding is I'm not sure what best practice looks like at that point. What is best practice 4 weeks out from a surgery in terms of prevention that the hospital can still have a hold of? And I would agree with the previous comment that it would be great to see the measure makers partner with, for example, the AACS on something like this.
Great questions. So can we turn to the developer for insight into sort of what the strategies are that hospitals can do to improve on the measure sort of after the initial prophylaxis and, the 2-week window?
Sure, and this is Ethan. Dr. Townsend, if you're on the line, would you be able to speak to this?
Do we have Dr. Townsend? Oh, I see you, but you're on mute. Oh, we can't hear you speaking. You may be double muted there. No, we are not able to hear you. I wonder if while you work on that, you could put comments in the chat. We'll continue to take questions, comments from our recommendation group committee members. Nick Fetterman.
Hi, good morning, everyone. So several quick comments regarding this. I share some of the concerns raised about the ECQM reliability, and to the measure developers, can you tell us, was that greater than or equal to a 0.7? Number two, what is the gap? I know that's I'd like to know what the gap is. VTE 1 and 2, there was a narrow gap, though we know if you really look in the charts, it's probably bigger than what is said. Number three, we need to have a countermeasure. So those of you, I'm sure the hematology docs on the line know this. What we've seen happen, the literature has shifted on this, guys. It went from nobody getting prophylaxis to everybody getting prophylaxis. And if you apply a risk stratification model, a risk assessment model, to Stephanie's point, what we found is more people with low risk were getting prophylaxis and having complications like bleeding than should occur if you use a one-size-fits-all. And a great measure would be, did you apply a risk assessment model to decide who's low, who's moderate, who's high, who's very high, so they can be appropriately treated? I'm afraid this measure might try to make this cookie cutter, and we'll see low-risk people getting prophylaxed and leave them at risk for bleeding, potentially catastrophic bleeding. And then fourth, on the exclusion criteria, I believe it said length of stay less than 2 days, which would exclude a very high-risk surgical population, our joint replacement population, which are now in and out in less than 2 days. And then finally, there's something called surveillance bias. And this has been published by the Northwestern Group in JAMA, where the hospitals that have the best adherence rate to VTE prophylaxis actually have the highest number of VTEs. Why? Because it's on their mind. They're looking. So surveillance bias is a concern. So for those reasons, ECQM reliability and validity, surveillance bias, and the fact that we need a countermeasure to prevent unnecessary prophylaxis, for those reasons, I have concerns with this measure.
Great comments, Nick, and questions. Ngozi from CMS has put in the chat that they are developing a potential balancing measure to monitor the overuse of anticoagulants, which I think addresses some of your concerns, though certainly not all. And as we start moving towards a vote here, I want to just ask our recommendation group members. We've heard a lot about potential risks, potential drawbacks of this measure. I do want us to think about how those weigh against the potential benefits. So start thinking about kind of, how these, pros and cons are weighing out for you as we move to a vote. Sandy, you are next.
Hi, thank you. So I agree with the advisory group and patient group members about the importance of this measure. A couple of questions when we're thinking about the hack penalty. Would there be a low volume exclusion for small hospitals? I am concerned about the double ding here on the hack penalty, because we do have so many hospitals that are small, more likely to get the hack penalty for low volume outcomes. And this does seem like a double ding. If one is going to be used, the other one should not be used, in my opinion, concurrently. Regarding the 30-day window, I'm going to put my caregiver hat on. Last year, my mom had hip replacement surgery while undergoing colon cancer treatment. After she was discharged with the appropriate medications and with home health. When she got home, they had detailed exercises for her to do every day. They had home health scheduled for physical therapy. She refused all of it. After she got home, she wasn't moving like she needed to be. And then even in the hospital, and she was in and out of the hospital, I think 8 times in a 90-day period. After her first prophylaxis for VTE shot. They gave it to her in the abdomen. Any other subsequent inpatient encounter, she refused because she said it hurt and she didn't want it. I was very critical of her care while she was being cared for in the hospital, but it was beyond the hospital's control if she had acquired a VTE, especially after discharge. And then again, for small, rural, medically underserved communities, we need at least a year to implement an ECQM as complex as this before the voluntary reporting period would start, because we do want to participate in voluntary reporting, but this one would be very complex for us to get in place. Thank you.
Great. Thank you for your perspective on the HAC-RP. Ngozi did note in the chat that there is a low volume threshold, but thank you also for expanding on your experience as a caregiver and sort of what happens after the hospital discharge for patients at risk. Thomas, you are up next.
Yeah, thank you. Just a couple of quick comments. Again, I think the outcome of VTE is very important. I have a couple of concerns. I think the rationale provided for the metric is really in process. It talks a lot about applying VTE prophylaxis, again, which I think is very important. To Nick's point, also in a risk-adjusted manner, or a risk, or taking in a patient's risk is very important. Even the best VTE prophylaxis, there are still going to be VTEs that occur in 30 to 40% of patients, and that is a well-published fact. So even the best prophylaxis is not going to prevent 100% of VTEs. And if the rationale is truly for that process metric of applying VTE prophylaxis, is that what we should be measuring and not the outcome? So concerns overall about the rationale behind the metric.
Thanks so much for that. Before we turn to others, I did want to get back to Dr. Townsend, who can now speak, I heard. Are you able to come off of mute? Oh, great.
I think you can hear me, is that right?
Yes, we can hear you.
Okay, good. And so why don't we reframe the question again so that everybody's aware of what we're addressing? Yeah, in other words, I don't remember the question exactly, so could you please repeat it?
I actually don't remember who had the question for you. I guess, Ethan, you had turned over to Dr. Townsend for to weigh in on a specific question.
It was for what you can do post discharge.
Oh, thank you, Anita. Yes. So how do you improve on this measure from a hospital perspective if you've given the prophylaxis, prior to discharge, and 2 weeks go by? What is the hospital doing to improve on the measure?
Yeah, I mean, this is in part by design, linkage of the coordination of care from the inpatient to the outpatient setting, so that on the inpatient side, preparations are made when the patient is discharged to have adequate home visits, PT, ambulatory time, goals like that are targeted and hit, as opposed to discharging someone to home without any of those supports. So it continues the journey for the patient to make sure that their prophylaxis and appropriate treatment strategies, increasing mobility, continue during those periods of time, to the extent possible. Not all surgeries will allow that mobility, but if you can move, good to move.
Thank you. And Michelle, I do believe this was your question, so thank you for putting that back in the chat. So, the actions that hospitals would take to prevent it week 3 or 4. So thank you for weighing in on that, Dr. Townsend.
You're welcome.
Jeff, I believe you are up next, and let's again start thinking about how the pros and cons sort of might balance out on this measure. We will be moving to a vote very shortly. Yes, Jeff.
I just wanted to make sure that we had a chance to hear from the measure developer about the issue of bias against systems with multiple hospitals on the same EHR. And just, I think I've seen some comments that make me think that maybe folks aren't quite understanding the importance of this issue. So really briefly, if you think about a hospital catchment area where there is one system that owns all 10 hospitals, and have an integrated EHR, they're going to basically capture all of the VTE treatment events that are in the denominator. Whereas if you think about a catchment area that has 10 hospitals that are all on separate EHRs, there's going to be a very different capture rate for the VTEs that come up. And so it's really going to result in higher rates that are biased for the folks that have an integrated EHR across facilities. So I'm curious to hear whether there was something that was done to address that.
Great. Thank you for summarizing that concern. And let's turn to the developer to see if they had any perspectives they wanted to share on that.
All right. Certainly, and I can start on this. So I should note, just to confirm, yes, that third criteria for the measure, just to make sure everyone understands. So the way it works is that if a patient is discharged and then they are admitted to another hospital and they experience a VTE, then that would also be included as a numerator hit. And that is correct that, ultimately, the patient would need to be captured in the same EHR in order to be treated as a numerator hit for that definition. I think I just note that the goal of including that criteria C is really just to try and capture post-discharge events, post-discharge VTEs as best as possible, given what is available within ECQM data. And so, I think just to confirm, yes, the way that that the measure works is that you would need to be on the same EHR. I think it's also possible potentially that larger health systems might also potentially have better capture of things like exclusion data. So it's possible there could be biases in other directions as well. But I do want to confirm, and again, also potentially better capture of data around some of the risk adjustment data elements. So there may be differences between smaller and hospital or individual hospitals and larger systems, but I guess I just do want to confirm that yes, the patient would need to be on the same EHR to be captured as a numerator hit on criteria C.
Thank you, Ethan. And Marty.
As I listen to this discussion, it's like a crucible for how hard it is to accomplish safe care in a healthcare system as complex and as fractured as ours. I mean, we've heard, some really moving frustration around a number of issues, EHR integration issues, uncooperative patients, where are specialist societies in developing national guidelines, state legislation, a number of things that are all kind of playing out here. And I'm wondering, for a measure like this that hasn't gone through the endorsement process or is somewhere, it looks like at the beginning of that process, how do we capture this conversation and does it get captured and get considered in the endorsement process? And then does it slow the endorsement process down if we're having a measure that's up for a recommendation like this, or does it actually speed it up? I guess that's kind of my question to probably you, Battelle, or CMS, because I'd hate to lose all these considerations that are going into our evaluation of this measure.
Yep. So our teams do, this is Brenna. Hi, everybody. Our teams do talk to one another. So anytime a measure goes up for endorsement, after it's been considered via primer, the endorsement team absolutely looks at the meeting summaries, absolutely looks at the outcomes, and includes that in sort of their equivalent of like the PAs that you guys would get for these measures. And if they have questions, our team, I mean, we're all here, right? So we can also give them some additional context. So that's absolutely considered, just as in the reverse, it's considered. When a measure is endorsed, we see those results as well and include them in our descriptions of the measures. So we do our best to the extent possible to make sure that we don't lose the robustness of these discussions, so that, everyone who's reviewing these measures at either part of the process is as informed as possible. And it doesn't slow the process down. The processes operate independently, so there's no impact on timeline.
Brennan, does it change who gets involved in the endorsement process? So, for example, we've had a call to action for the American College of Surgeons to get involved in this issue. Does this, would you take that and reach out to the American College of Surgeons and tell them that this discussion came up and it's important that they be part of the endorsement process? Does it go that, can you be that proactive in doing that kind of reach out?
It hasn't come up yet, but it could. What we would probably do is first talk with the developer, right? We would talk with Mathematica, we would talk with CMS, and see their thoughts. They may even be interested in getting those entities involved on their own end, prior to endorsement, right? Just to make sure that they're as prepared as they can be. But if we needed to add a voice onto our endorsement committees based on sort of that committee's composition and what we think needs to be spoken to, then yeah, we do have it written into our guidebook that we can do that.
And I don't mean to pick on the College of Surgeons, although, they are leaders in this space. But, Nick's point about the Northwestern group on surveillance bias, I mean, just reaching out to some of the expertise, that has come up in this discussion, I think would be a good thing to do.
Great considerations, Marty. Thank you.
Welcome. Thank you, everybody, for a really rich discussion.
Yeah, thank you, Marty. And thank you, Brenna, for weighing in as well on the collaboration and how pre-rulemaking relates to endorsement and vice versa. Rosie, I think you're probably going to have our last word.
Well, and this is a positive word, I guess. I've been involved in 58 hospital surgeries, and more than I want to even talk about ambulatory centers surgeries. But I have never had a VTE after any of the surgeries, but I always adhered to, at discharge, I adhered to following all the rules and regulations that they sent me home with, other than the stockings, because they drove me crazy. So I understand that, but I did the prophylactics, I did the moving around as much as I could. I probably started me on an exercise program that I still do today, every day, because of the fact in my wheelchair, because I knew that I didn't want to have a VTE. And so basically, there is ways in where you can post-discharge influence patients. Not all patients, but some patients. And I think that we can also look at, why we might not been able to influence patients. But I just think that it's really important that we know that hospitals do influence us, and we do follow discharge that is truly recommended at the end of the day.
Thank you so much, Rosie, for that reminder that patients do listen to discharge instructions, and that they're important to get out there. So I'm going to ask Julie and Darlene, I'm going to do my best to summarize what has been a very robust discussion. Please let me know what I have left out. So we've heard pretty extensively about the risks associated with VTE, which are very serious and demonstrate the need and importance of this measure. There have been questions, a lot of questions and discussion about the extent to which hospitals can improve upon this measure. There's been some concern about the 30-day window and what's in control of the hospital. And then we just heard from Rosie as in closing that, there is, the hospitals do have responsibility for encouraging patients to take actions that are, preventative of VTEs. There have also been some documentation considerations. So particularly, we talked a lot about enterprise or integrated EHR versus not in systems and how that might affect data capture. And Julie, you noted sort of some clinical muddiness that may be sort of embedded in the measure that you were concerned about as well. And we've also heard about unintended consequences, potentially incentivizing overtreatment, leading to bleeding. Julie and Darlene, what have I left out?
I think you did a good job summarizing a robust and wily conversation. So,
yes, I think you did a good job.
Okay, so let us, if Darlene and Julie, if you agree, we can move to a vote.
Yes, please.
Yeah,
I think so.
okay, great. So Elena, I'm going to turn it to you.
Okay, thank you, Meredith. As a reminder, everyone, you may need to refresh your screen, as well as if you vote for do not recommend, we are voting on this measure in 3 different programs. So if you vote do not recommend, please include your rationale in the rationale tab each time that you vote for do not recommend. Okay, in just a moment, you will see the first question pop up, which is for MUC 2025-67, hospital harm, postoperative venous thromboembolism. Do you recommend including this measure in the hospital inpatient quality reporting program? Your options are A, recommend, or B, do not recommend. Again, if you're voting do not recommend, at the very top of your screen, you'll see that little pin icon, and that is where you can go ahead and put your rationale if you choose to not recommend. I think we are looking for 20 votes here, so waiting on a couple more.
Yeah, I got kicked out and I can't get back in.
Okay, we can go ahead and resend you that voting link, and we will have you vote that way. Okay, we are resending you that link. So if you can go ahead and check your Zoom messages for that link.
Got it.
Thank you. Again, we are looking for 20 votes. We have 18 so far, 19 so far. So if you are having any trouble, go ahead and try refreshing your page, or you can direct message me your vote here in the Zoom chat. We are still waiting on our last vote before we move on to the next program. Let's see. I think we're missing from Jessica Schumacher. If you're on and having any trouble voting, if you could go ahead and direct message me your vote in the chat or try refreshing your page. Waiting for our last vote here.
I don't see Jessica Shoemaker on. She may have had to step away. Do we have
Okay.
quorum?
We do not. We are one short. We are at 19 votes.
Okay.
So we do need that last one, but we can we might need to move on to the next vote just for time.
Okay.
All right. In just a moment, you will see.
Can I interrupt a second? Wasn't it Jessica that put in the chat that she had to, someone had to step away for 15 minutes? Wasn't that Jessica?
Let me review
I'm trying to
Darlene,
look
that was
back.
me later this
Oh.
afternoon. Yeah.
No, someone posted, I need to step away
It was Jeffrey Seal something.
Okay.
Yeah.
Okay, I'm wrong. Sorry.
No
That's okay. It was
worries.
at 9:59.
So we will follow up to capture the votes for folks who had to step away, and we'll press forward.
All right, in just a moment, we will see the next vote pop up, which is for MUC 2025-67 for the Promoting Interoperability Program. So you should see that on your screen now. Again, if you're voting do not recommend, please go ahead and put your rationale in that next tab. I see votes coming in. Okay, we are at 10 votes, so still looking for a few more committee members to submit their votes to us.
Okay, I'm having an issue. Both of my tabs are showing the rationale window, and I haven't even been allowed to vote.
Same here, Darlene.
Same.
Same here.
That is interesting.
Yeah, we're all getting the same thing.
Do you
Yeah,
want
well,
to?
no, that happened to me. I had to re-log in, but now I can.
I actually did that. I closed out and then reopened the link, and it is still giving me.
Uh-oh.
We'll see what we can troubleshoot on our
Okay,
end.
I closed out. I'm
Our
going to try to
apologies.
re-log in.
You might, I'm sure you've tried to refresh your page, but you may just need to refresh your page.
Oh, I refreshed my page like 8 times.
I know. Okay. Let's see.
I actually had to go out and re-log back in. I know you did
Yeah,
that.
I closed. I've re-logged back in. Now I can vote. Okay.
Yep, I'm in.
Okay.
All right, looks like we have a few more votes coming in. If anybody is still having trouble with that, you can go ahead and let us know your vote in the chat, but it looks like we have people getting that resolved. We're still waiting on just a couple of more votes for this one. Right.
Can this is Nick Fitterman. Can you resend me the link so I got logged out of everything to try to get back in and I can't find the link again.
Yeah, absolutely. We will direct message that to you in the Zoom chat.
Thank you.
Thanks for sticking with us. Just waiting on a couple more votes for this one. All right. Looks like we are at 19. Let's see. Stephanie, if you're having any issues with the voting, if you could go ahead and let us know or try refreshing your page. Otherwise, we are almost ready to go.
Me? I voted.
My apologies. Let me see.
I voted early, but it's prompting me to vote again. If you want me to vote again, I'll be happy to.
Yeah, if you see the option to submit your vote for the Promoting Interoperability Program here, that would be appreciated. Thank you. We don't see your vote on the back end. Oh, perfect. We see you now. Thank you so much.
All right, we are good to go there. Again, in just a moment, you're going to see that question change, and we will vote on our last program there. So just bear with us while we get everything set up for the next vote. All right, voting is now open for MUC 2025-67 for the Hospital Acquired Condition Reduction Program. Again, your options are recommend, A, or B, do not recommend. If you're voting for do not recommend, please tab over to that rationale tab and put your rationale in there. Again, if you're voting for do not recommend. All right, we have our votes coming in. We're just waiting on a couple more. All right, looks like we have all of our votes there. So I will go ahead and hand it back over to Meredith. Thank you, everybody.
Thank you, Elena, and thank you, everybody, for participating in the vote for that measure. It's a very robust discussion. Everyone just take a minute to stretch because we're going to go right into our next measure. We'll do our best to get through this discussion and vote before we break for lunch, though we may extend the discussion, after the noon hour or after 12 o'clock. We'll see how things pan out. So our next measure is emergency care access and timeliness, or ECAT. It is MUC 2025-072, and we can move to the next slide. And I'm just going to advance to my notes here as we transition. Great. So this measure captures the proportion of emergency department or ED visits where patients of all ages, all payers, experienced any one of 4 quality gaps in access. Those 4 are enumerated in the measure description here. So the first one is the patient waited longer than 60 minutes after arrival to the ED to be placed in a treatment room or dedicated treatment area that allows for audiovisual privacy during history taking and physical examination. Or 2, the patient left the ED without being evaluated. Or 3, patient boarded time, which is the time from decision to admit order to ED departure for admitted patients in the ED for longer than 240 minutes or 4 hours. Or the patient had an ED length of stay, which is time from ED arrival to ED departure as defined by the ED departure timestamp, indicating when the patient physically left the ED, of longer than 480 minutes or 8 hours. So this is an intermediate outcome at the facility level. This measure was endorsed with conditions in 2024. And we can move to the next slide. This measure is being considered for the Hospital Inpatient Quality Reporting Program, the Hospital Value-Based Purchasing Program, and the Medicare Promoting Interoperability Program. So with that brief overview of the measure, I will turn it over again to Dr. Ron Klein. Oh, I'm sorry. Is this Dr. Stephanie Clark to give us an overview of this measure?
Thank you so
Apologies
much,
if
Meredith.
I got the wrong person. Thank you, Stephanie.
That's okay. Good morning, everyone. My name is Stephanie Clark, and I'm a medical officer in the Quality Measures and Value-Based Incentive Group. I am a pediatric nephrologist, and I came to CMS from full-time clinical care. I still see patients at the Children's Hospital of Philadelphia. I also just want to note I'm joined today by my colleague, Dr. Sean Michael, who is a regional chief medical officer at CMS and a practicing emergency medicine physician. And we're really, really grateful for his time, his support, and the additional perspective that he brings. The ECAT ECQM is being considered for all 3 of the programs that you just mentioned. It captures variation in the accessibility and timeliness of emergency care. And the goal of this measure is really to reduce patient harm and improve outcomes for patients requiring emergency care in an ED, many of whom may be admitted for inpatient care during their stay or transferred to a higher level of care. As such, this measure addresses important aspects related to inpatient quality of care. Quality gaps in the ED access and timeliness often reflect inpatient boarding delays, bed management inefficiencies, or discharge bottlenecks, all of which reflect system-level inpatient operations under the hospital's influence. Limitations in access and timeliness of emergency care, including long wait times and ED boarding and crowding, have been shown to be associated with increases in mortality, delays in care, preventable errors, poor patient experience, and staff burnout. Emergency departments' efficiency and patient throughput are closely tied to inpatient capacity, care coordination, and hospital-wide operational processes. Considering this measure in the proposed quality programs promotes broader accountability for hospital-wide performance rather than viewing ED processes in isolation. This is not a new measure to the hospital quality reporting programs, as the ECAP measure was finalized for the hospital OQR and REHQR programs during the 2026 OPPS final rule. Also of note, this measure is CDE endorsed, and we look forward to the discussion. I'll pass it back to you.
Great. Thank you so much, Stephanie. So before we open up for discussion, I did want to summarize what we've heard from public comments on this measure. We received 11 written public comments on our website for this measure, and we've received 2 spoken public comments at our listening session. Public comments on this measure lauded the intent of the measure to address important and relevant topics of overcrowding and poor ED throughput. Commenters noted that tracking information about wait times and length of stay in the ED is important for health system planning, and that this measure goes beyond typical timeliness measures for ED care and will encourage providers to find creative and innovative ways to improve quality and patient experience. Commenters stated that measurement on these issues will drive improvements. Commenters also supported the use of an ECQM to reduce prior reliance on chart abstracted measures on throughput and their associated reporting burden. Commenters also indicated support for expansion of this measure in more hospital programs. And one commenter noted that this measure is particularly important for patients with existing rare or chronic conditions. Public comments did also highlight several concerns about the measure. On the topic of measurement limitations and data accuracy, commenters noted that implementation challenges exist in accurately capturing the time to place a patient in a private treatment space, and asked for clear definitions for the measure because dedicated treatment area and boarding could be interpreted differently. Commenters noted a lack of evidence base for determining the time frame cutoffs, for example, the 1 hour or 4 hour thresholds, lack of evidence that suggests that those thresholds actually influence patient outcomes in the measure, and further noted that the field lacks evidence-based guidelines for how to improve performance on the measure. Commenters noted that wait times reflected in the measure do not account for patient acuity, severity, or other clinical factors that can influence ED operations and patient outcomes. Without stratification for acuity or severity, the measure risks misleading comparisons between EDs serving fundamentally different patient populations. Commenters also expressed concern about the level of attribution for the measure, noting that ED throughput is influenced by factors outside the control of the ED and the hospital, and that measure does not sufficiently capture the complexity of ED operations and the hospital care continuum. Commenters suggested that the measure concept assumes that other parts of the hospital can always accommodate any ED volume, making ED operations appear as the lone drivers for delay, whereas drivers of ED wait time variation are often outside the control of the ED and the hospital as a whole. Related to this comment, some suggested that this measure should be framed as a system-wide or inpatient metric rather than solely as an ED performance measure. Commenters also raised concerns about measure fairness, requesting risk adjustment for regional bed availability, EMS surgery, phased implementation with confidential reporting before public display, and benchmarking by peer cohort to ensure fairness. One commenter noted that mental health stratification used with this measure does not include a primary diagnosis of substance use disorder, and that this is a limitation. Some commenters noted potential unintended consequences associated with the measure, including incentivizing unsafe workarounds that compromise patient safety and staff well-being. And one commenter recommends that CMS work closely with stakeholders to better understand experiences for those who are voluntarily reporting this measure under the hospital OQR, and that this information would be critical to consider should this measure evolve or be included in other programs. Related to recommendations, some commenters urged CMS to consider the costs and resources associated with measure adoption, particularly for critical access hospitals and rural emergency hospitals, and also encouraged a voluntary reporting period to build and test the measure, to allow for sufficient time for technical specifications, attribution logic, and EHR mappings to be finalized. So that's the summary of what we heard from the public. I'll now move to the closing gaps of care literature review. Thank you. So our literature review found that older patients waiting overnight in the emergency department for admission experience an increased risk of in-hospital mortality and morbidity. With regard to geography, our review found that urban EDs often experience higher patient volumes, leading to overcrowding, longer wait times, and increased risk of patients leaving without being seen or experiencing prolonged boarding and length of stay. In contrast, rural EDs face staffing shortages, limited specialty coverage, and fewer treatment rooms. And lastly, our literature review found that patients with a non-English language preference experience longer wait times to see a provider in the ED. So with that summary of public comment and the closing gaps of care literature review, we can now turn to our advisory group members to see what their thoughts are in terms of what the priority should be on our discussion today. Zahid.
Yeah, hi, thank you. So there are really aspects of this measure that I think are good because at least 3 of these components, or maybe even all of them, have existed in some form as individual measures. And even the sort of the median time from arrival to discharge, for example, was a continuous measure. And it's always hard to interpret those continuous measures. And so that it kind of converts that into a binary threshold type measure. So I think it does bring together all of the various aspects of ED care. Certainly, especially during COVID, we all understood the EDs were having a lot of trouble with meeting some of those individual measures that were in play. But I think that this is sort of a good way to bring various components of these things together into a singular measure. But the only one concern is that it's sort of an all or none measure, right? So it's an inverse measure, and it's you fail one component, you fail the whole thing. So I think that's always a tricky thing for providers. But I think overall, everybody recognizes the problems with ED wait times and the experience that people have there. So I think anything that tries to measure some of those in a way that's a little bit more sort of definitive as opposed to just a elusive median time in minutes is always harder to interpret. And the other thing is that as an ECQM, I'm always concerned about, and that has been expressed especially by smaller hospitals, about the volumes and so forth. And this is stratified 4 different ways, and you always get into small number issues when you have more stratification. But I think with the ED as an ECQM, because the old ED measures that were abstracted were always heavily sampled. But the ECQMs, the good thing is you'll have a fair number of ED encounters that are basically discharged and not admitted patients. So that's why it's in the OQR, the outpatient program, because I think in most hospitals, there should be sufficient volume, but I think there was some comment about adjusting for volume as well, which has been done in some of these matters. Just a couple of 2 cents on this.
Thank you for the 2 cents. I think it was more than 2 cents. It was at least a quarter. So thank you for weighing in and getting us started, Zahid. I did want to turn to CMS to see if someone could sort of clarify kind of the current status of this measure. Where is it being used? And sort of the trajectory of voluntary and required reporting, and address the question of the IQR versus the OQR program.
Thanks so much, Meredith. I'm going to turn it to our program leads. And if for some reason they are not able to get off mute, we will put that in the chat for you all.
Thanks so much.
No problem.
Hi, this is Grace Snyder. I can speak to it. So I think it's already in the chat. It's correct. The measure has recently been adopted into the hospital outpatient and the rural emergency hospital programs. Specifically for the rural emergency hospital program, the REHs can choose between reporting on this ECQM or the chart abstracted emergency department throughput measures to provide a little bit more of a glide path, moving from chart abstracted measures to ECQMs, while for hospital outpatient departments, we are removing the chart abstracted measures when the ECQM becomes after the voluntary period and it becomes mandatory, because we trying to avoid some of the duplication in the measures between the ECQM and the chart versions. But also, I think, to the point that Terry made in the chat, we understand, the access and the wait times and the boarding issues in terms of accountability is not purely within the ED. So that's why we're considering this measure for the inpatient setting. So, potential use in the inpatient quality reporting program and the Medicare promoting interoperability program. And that's where we are really very much interested in your feedback, because, and not to say that using one measure in 2 or 3 quality programs is going to solve a very complex problem, right? But we need to, we think it's very important to measure these various aspects of care and access, and because we need data to be able to inform policymakers of other aspects of this very complicated issue. So hopefully that helps. And again, thank you for all of the great feedback.
Thank you so much, Grace. So let's see. I saw some hand raises. Mary.
Hi, thank you. I would love to see this measure help hospitals rather than penalize them. I see that it could be part of value-based purchasing. I work at one of the busiest emergency or healthcare systems with the busiest emergency room in the country, and probably in like the top 10. We have patients nonstop coming through the ED when we are at capacity and nowhere for the patients to go, meaning the skilled nursing facilities are filled, or we're having difficulty getting beds or difficulty navigating with the patient's payer. We have mental health patients, and any one day we could have about 80 patients in our system awaiting mental health beds because our state has not provided the adequate capacity. We are a certificate of need state, so we are limited on how many beds that we can put in the hospital, and we have to fight amongst other regional hospitals just for beds. So it is a problem with, and as others have said in the chat and in the comments, it is a problem with unable to get patients that are filling beds out of the hospital. We can't turn patients away. Sometimes we will be on diversion, so EMS will have to go to another facility, but EMTALA rules mean we can't turn people away. We've gotten real creative. During COVID, we turned one of our lobbies into an emergency room. We put tents up outside. Hospitals are trying their best. ED boarding is not fun. We've had patients boarded several days. They get discharged from the emergency room. We have inpatient nurses coming down to take care of these patients, but it is not a private area. It's not meant to be an inpatient area. We've opened up, we've taken an inpatient unit and converted it over to more of a ED, a waiting bed unit. So we are trying our best. We're being very, very creative. I would love to see this measure out there. I don't think it's a bad measure. I would love to see it give our administration and CMS incentive to help the hospitals with this, not punish them, especially take away more money, which could be used for helping enhance patient care.
Thank you, Mary. So I think sort of recognizing the importance of tracking this, but perhaps not using that information as a penalty, instead to garner additional resources and support. Sarah, I believe you are up next.
Hi, so I'm in support of this measure too, but I guess I'm concerned with, because as far as ED staff in rural places, because I live in a rural place, they don't usually have enough staff. So then even if the waiting room isn't full, you end up waiting hours, and then they get you in a bed and you end up waiting more hours, and it's usually half a day to a day before you get to go home. And the ER staff is so overworked that they're going between numerous patients trying to see everyone, and the patients are frustrated and the staff is frustrated. And I mean, I work at a hospital. I mean, I'm as a cook, but when I go on break, I hear all the hospital staff and all the attendings, and they all just talk about, how they're always short-staffed and they're working long hours, and they never seem to be able to keep people at our hospital. They always go somewhere else, and then they have to hire traveling nurses and doctors. And it's just, how would this how would this measure help make sure that the rural areas would have shorter waiting times and help the patients better be seen and heard when there's so much turnover?
Great comment, Sarah. Thank you for that perspective on kind of staff turnover and the patient experience with waiting. Thank you for bringing that to the center here. I'm going to go to my co-chair, Darlene.
Okay. I hope this is the right time frame, but anyway, we're all discussing. I have a lot of very personal feelings about this, also from a professional standpoint in the role that I play in supporting emergency services personnel and having many, many discussions with them regarding the specialized care of individuals with rare and chronic conditions. EDs, I'll just say, overall, many EDs are a mess. I can tell you from the patient perspective, patients are afraid to go. They will do almost anything in their power not to go to the ED because across the board, everyone just already just knows that there is going to be multiple hours of wait time, that then the level of being disregarded, or you did get into a room, but now you only just got into a room. And they feel like that they're a box being checked, like, okay, we got you in a room. We have patients that honestly will sit in a room for 2 hours from the time that the first admission nurse came in and did like the basic eval before anyone else ever comes back in. We have patients that completely go without food that are diabetics, and no one's coming in to say, hey, do you need a package of crackers or whatever, something to drink? So there's so many issues that happen. Also, in this measure, there's no measure for wall time. And that is a major issue across the United States. And if you don't know what that means you've been brought by the ambulance and you sit in the ambulance is taken up waiting for the ED to put you in a bed. So this doesn't even measure wall time, which really exacerbates the wait time for patients. And we're talking about so many patients that have time critical issues. And I know it's absolutely impossible, but I would love to see how long those patients waited before they left. Because in my experience, I would say the average is 4 hours before they actually give up and just leave or try to go to another ED hoping it will be better. So I do also have compassion for the fact that I know staffing issues happen. And I know that the people who work in the EDs are stressed. I also do know that hospitals overall, the ROI is very important to them. I spend a lot of time with emergency physicians that are the head of their emergency departments, and I hear their frustration in the evenings at these conferences. And they'll have CFOs that disregard their EDs and don't want to put money in their EDs because that's not where the ROI is. So when we say that this is a hospital issue, I agree it's a hospital issue, but the EDs are owned by the hospitals. So if this measure is put into place, in my opinion, it will cause those hospitals to wake up and to look at those EDs and look that these measures are happening, and hopefully, let go of some of that money, get the staff they need in those areas, maybe expand those areas where they're needed. So that's my 2 cents worth.
Thank you. Again, 2 cents doesn't capture it. That was a good quarter. Thank you for those thoughts and for educating us all on wall time and how important that is to measure as well. Before I go to Samaya, who's had her hand up for a bit, I'm going to check in with Cheng Lin from Acumen to see if you had any clarifications you wanted to make from the developer perspective.
Yeah, thank you so much. Thank you all for the feedback. This is a measure that I held dear to my heart. Every one of us has an emergency room story to tell. And we have heard from this group that this is closely tied to hospital-wide and inpatient process, supporting that it's relevant to the inpatient program. I've noticed some common theme that I would like to clarify. One theme is risk adjustment, or the special circumstances that the high volume and rural hospitals face. I want to emphasize that this measure is volume standardized. That is, we put the EDs into different volume bands by how many patients visit the ED in a year. And our numbers have shown that this volume bands has effectively basically grouped high volume together and rural together. This is a simple approach to adjust for the provider characteristics, such as the trauma designation, teaching status, urban-rural status. So in that aspect, providers or EDs face similar challenges are likely going to be grouped together. The other theme I've noticed in the chat and in the discussion is the special challenge of the mental health population. And I want to emphasize that from a patient risk perspective, we do offer risk stratification by age because we recognize that pediatric ED has special operations, and by mental health status. We are very aware that there's unique challenges associated with waiting for a psych bed, and the mental health population, the rate will be reported separately so that both the providers and the public CMS can see where the challenge lies and might be discussed had there been no volume standardization and no patient risk stratification. And I see a chat that substance use disorder is not included in the mental health stratum. Yes, that is the case for the current specification because what we're thinking is to the psych bed specifically, but that's definitely something we can consider to see to monitor what is the wait time associated with the SOD patients, whether further stratification is warranted.
Thank you for your clarifications on sort of adjustment for some of these factors. Appreciate all of those clarifications. I think that was really helpful. I'm going to turn to Somaya, who's been waiting patiently with her hand up.
Thank you. So I think this is an important measure. Premier supports this measure, especially when we are entering an era where uninsurance is likely going to increase, and which means people will be delaying care until they're forced to go into the ED rooms. And so I think it's important to track and monitor this. However, Premier does have concerns that there are greater forces at play that go beyond the hospital itself, that are external to the hospital, and have to do with the resources within a community and lack thereof. Your rural hospitals, your urban safety net hospitals don't have the same resources as suburban hospitals to address throughput. And so for those reasons, we are encouraging the folks who are voting to consider, whether this measure needs to be implemented in the hospital value-based purchasing program, or perhaps it should be delayed a little bit longer so that you're not creating this vicious cycle where hospitals that are already resource strapped are further penalized for being resource strapped. Thanks.
Thank you, Samaya. I did want to just call out for the developer, there are a couple of questions in the chat about how discharge is defined and some questions about the stratification by volume. So please weigh in on the chat if you are able to answer those questions. Jeff, I believe you are next.
Thanks. So just a couple of comments. Maryland has some of the worst ED length of stay problems in the nation. And so as a state regulator, I've spent a tremendous amount of time working on this issue. And I think it's really important, and this is a valuable measure. I guess, first of all, when these conversations come up, the question of the name of the measure and who the target is always a hot topic. And I would just encourage us to think about this from a more patient-centered perspective, that the folks that are seeing the downside of this issue are the folks who are seeking emergency care. And that's not to place the blame on the folks that are running the ED. I think everybody realizes it's a hospital-wide and sometimes a community-wide issue, but the place where the rubber meets the road is in the ED. So I hope we can not get hung up on that. I guess there's really good literature on patient harm from extended ED length of stay. And so I think it is important to try to address this for patient outcomes. We've done a lot of research on the causality of this issue as to whether it's more of a community or more of a hospital or more of an ED thing. And we've done that using national claims data and AHA hospital characteristic data. And the key things that we found were that variation in ED length of stay within hospitals is actually greater than across hospital catchment areas and regions, which suggests really that a lot of this is in fact under the control of the hospital. And so I think this policy is, or this measure is well situated in that regard. There's a lot of evidence on interventions that can be used to try to address this problem. Some of the things that we found in the data have suggested that managing elective surgery volume can be really important. Managing inpatient length of stay can be really important. Creating connections and collaboration with post-acute discharge destinations can also be really important. And I guess the final point is, our state EMS director is an EM physician who has practiced in a couple of different states, and has reflected to us that when he sees hospitals that have really challenging situations with ED length of stay versus those that are doing a good job of moving the patients through, the main differentiator between those facilities is the degree to which the hospital CEO has made this a key priority and is regularly in the ED inquiring as to how patient throughput is going. So to me, that really suggests that this is a problem that in some ways just needs to be elevated within the hospital structure to the people who can really force change. And I think this measure is pretty well situated to do that.
Great points, Jeff, and a counterpoint to what we've been hearing about sort of what's in the hospital's control. Rosie, I'm going to call on you in a minute, but I wanted to turn to Dr. Sean Michael at CMS to see if there was anything you wanted to clarify or weigh in on.
Thank you all for the thoughtful discussion. And I think two sort of points from CMS's standpoint. One is that quality measurement is not the only tool CMS has to positively influence this really challenging sort of complex healthcare system-wide issue. We don't expect that an inpatient measure alone is going to solve system-wide flow. But CMS also can't do the other things that we need to do without measurement also. So it works in concert. These sort of advance each other in buttressing against unintended consequences in other areas. And so there's no expectation that measurement alone fixes this, but it is critical to the fix. And the second point is that our fundamental mindset here is that even the measure's most ardent critics generally admit that for their own family member presenting for emergency care, all four of these numerators would define an unacceptable access failure for them personally, right? And so I think that means that we're on the right track, because emergency care, as many of you have said, right, emergency care is hospital care, and emergency care is also whole community care. So it's hard to draw clean lines around who owns what. And I think we recognize that. And hopefully CMS has never said that this is an ED measure, right? It's an emergency care measure. And as has been said, right, that is a sort of patient-centric lens on things that does not fit very well into the paradigm of, is it inpatient, is it outpatient? Because that's not prospectively knowable by most people when somebody arrives at an ED, whether they're going to need inpatient or outpatient care. That's sort of the whole point of being in the ED. And so the idea here is not that hospitals will immediately be able to achieve 100% access and never have a fallout on this measure. All the system factors are very real. But it's also simultaneously true that every one of us expects that our family members are going to be in a room quickly, whether they arrive by EMS or not. They're going to be evaluated by appropriate personnel. They're not going to have prolonged boarding. They're going to have a reasonably short length of stay. And so I think our approach to this measure generally is that it's an important tool in our armamentarium at CMS to drive sort of health system advancement in the correct direction, even if it's not easy on day one, and even if it goes beyond just hospitals as the only player and just quality measurement as the only tool. Again, thanks for the thoughtful discussion.
Thank you so much for that. And Rosie, thank you for your patience. We're over to you.
Well, first of all, Sean made some good points, and Jeff did also, because I believe this is, first of all, a patient safety issue. It's not an issue that is going to be solved by one measure, but it's a patient safety issue that needs this measure in a conjunction with other measures to solve this problem. Also, it is an upstream measure. You can't solve this problem downstream. You can't solve it in the ED. You have to solve it in upstream. You know, how do you free up more bed space? How do you streamline discharge? How do you connect with the community so that you have access to beds outside? You know, how do you build those relationships in your community? So, you know, I'm working with an enterprise right now who is looking at how do they move scheduled surgeries to one of their lower moving, you know, lower hospitals that have lower emergency room visits, so that they know how, you know, so that when that emergency room has unscheduled 30 to 40 unscheduled beds needs a day, they know how to fill, where they're going to fill them and how they're going to fill them. I am literally meeting daily with that hospital as a patient's voice in that hospital. And that is the way that this gets solved, by the patient's voice being and co-designing and co-producing, and sometimes going to the facility and looking at where can we create space.
Thank you, Rosie.
Thank you.
Thank you for your advocacy. Let's see. We have, I think, Terry, I think you are up next.
Yes, great. Thank you. I figure I ought to speak up since I've been an ER physician for 28 years, an ED director in hospital leadership. And I don't want to repeat the excellent comments from Sean and Jeff and Rosie. But I do want to say this really is a patient safety issue. And from a day-to-day operation standpoint, it is a hospital within the hospital's control with regard to boarding and patient flow through the emergency department. I've worked in, you know, some of the largest level 1 trauma centers, and so I understand that there's often a staffing issue, especially on the floors, that doesn't receive as much attention in the ED. So, for example, some of the busiest ERs see the sickest patients. There's not a lot of ambulatory type patients. Most of them are really sick. And the patient safety issue comes in when you can't get patients, not only inpatient, but to the ICU. So you have a good number of ICU patients being observed by ED nurses that are not one-on-one like they would be in the ICU. And I've seen bad things happen. So I think one of the things that we should pay attention to is that on the comments, ASAP agrees with this measure and agrees with it in the program. So I think that's pretty powerful. I think comments from them. So anyway, I agree with this measure, and I think it should be in the inpatient programs. Thank you.
Thank you. So we are going to have to wrap up soon. I'm going to go to Caitlin and then Kristen, and then we're going to try to summarize what we've discussed. So Caitlin, I know you have to run shortly, so go ahead.
Thanks so much. So I'm Caitlin Galuli. I'm with the American Hospital Association, and we have a lot of concerns around this measure. And first of all, I want to acknowledge that we are quite aware that there's a boarding crisis, and it's not going well for hospitals either. This is not, hospitals don't enjoy boarding their patients, and we agree that it's a patient safety issue. Agree on all of those points. However, I think it's inappropriate to use this measure in a value-based purchasing program where you do have relative competition, where you are deciding payment incentives. And we've all acknowledged that there are a myriad of items, of factors that are influencing some of these wait times. So it's really the use of the measure in that context that I think is really difficult for us to get behind. I also think that I think Zahid mentioned it very early on in this conversation, that this, we've kind of shifted from a continuous variable to a binary variable. And I have a lot of issues with that as well, considering that, we've got the patient waited longer than 60 minutes after arrival to the ED. Now, so we're now saying that we're going to adjust your payment incentives based on if your average was 60 minutes or 61 minutes. And we're making a judgment call on a binary basis of whether that constitutes better care or worse care, or better value or worse value. And so I also agree that the longer you stay in the ED, the worse your outcomes are going to be. That's proven. However, this measure institute some pretty arbitrary time windows on that. So we are saying and moving dollars based on, whether we're meeting these 4 hours, 1 hour time windows. So, obviously you kind of have to do that in a quality measure, but, as we also heard from CMS, this is not the measurement in a value-based purchasing program. It's not the only way that we can affect this. I put a lot in the chat too, and I'll stand by all of those, but I think we need to really think about, yes, it's an important concept, but important concept does not make a measure that's going to lead to improved patient outcomes. And that's all of our goal at the end of the day. So I'll leave it at that.
Thank you, Caitlin, and thank you for contributing in the chat all along. I'm going to ask Cheng Lin from Acumen if you wouldn't mind putting any response you have in the chat, because I'm going to go to Kristen and then we'll summarize the discussion. So Kristen, please go ahead.
So from a patient standpoint, I also want people to realize that there are situations within the rare disease space where you want to avoid the ER, but you can't. So I have had situations in the last 3 years where a child had a suspected bleed and our hemophilia treatment center required us to go to the children's emergency room, which was a minimum of 12 hours between the time we were admitted, despite our hemophilia treatment center calling the ER ahead of time and actually being released. And all they had to do was imaging to prove that there was bleeding into the joint space. A secondary time, we went to an urgent care for our daughter for just a suspected appendicitis. And the urgent care wouldn't even image her because of the bleeding disorder. They said they wouldn't do any triage or anything. They just sent us on. So we had no option but to go to the ER, despite trying to avoid the ER because of those long delays. So this really is a safety issue even for rare disease patients, because a lot of us don't have an option. We can't just go to a walk-in ortho. We can't just go to an urgent care because they will not treat us. They send us directly to the ER because they are scared to deal with anything regarding the rare disease. So I think it's important that these wait times are addressed, because for us, we're not rural and we have never, ever been in the ER less than 12 hours. And that's with children. So that is just unacceptable to me that, and I understand that there are staffing issues and beds available types of problems, but they're not going to be addressed if you don't actually have standardized data to look at to see that these wait times are a problem.
Thank you, Kirsten, for sharing that. Kristen, excuse me, for sharing that experience, and recentering us on the patient experience there. So I think Julie and Darlene, we've had a lengthy discussion and hit along many important points here. I'm going to do my best to summarize, but please let me know if I've missed anything. So I think almost unanimously, perhaps unanimously here, there is no question that ED care access and timeliness are major challenges and put patient safety at risk. And that's been well documented and supported by the comments we heard today, as well as the public comments that I summarized earlier. This is a facility level measure that puts accountability on the hospital, and we heard lots of folks think that this is appropriate, including patients, although there were some of our committee members who felt that community level factors, especially in rural resource poor settings, play a key role that's outside of the control of the hospital. We did hear in general, certainly not unanimous, general support for the specifications in terms of calculating the scores, though we did hear some concern about, splitting the continuous variable into a binary and the loss of information there. folks that have been supportive of the measure feel that it's most appropriate for the quality reporting program or incentive programs, and there have been some concerns about its use in value-based purchasing programs and potential penalizing hospitals rather than doing more to support reductions in these wait times. Julie and Darlene, what have I missed?
I think you got it.
Okay.
Yeah, I think so.
Are we good with voting? Yeah. Okay.
So.
Elena, please take it away.
All right, everybody, you will see this first question pop up for you in just a moment. If we could, there we go, go to the next slide. Perfect. So voting is now open for MUC 2025-72, Emergency Care Access and Timeliness, for the hospital inpatient quality reporting program. Again, your options are A, recommend, and B, do not recommend. If you are voting do not recommend, please tab over to that little pin icon at the top and go ahead and put in your rationale. I see we have votes coming in. I believe we are expecting to see 20 votes. So just waiting on everybody's votes to come in. Again, you might need to refresh your page if you've kind of tabbed over from there. But if you are having any additional difficulties, please do let us know in the chat. We are almost there. Just waiting on a couple more votes to come in. All right, we have 18. Again, we're waiting to see 20, so just a couple more votes here. All right, we are just waiting to see our last vote come through for this one before we can go ahead and move on. If anybody is having any trouble with the voting platform, go ahead and let us know, and we will work with you on that. Again, we're just waiting to see our last vote here. Thank you for bearing with us, everyone. All right, looks like we are good to go for this one. So in just a moment, we will move on to the next one. Just got to do my background stuff here. Thank you, everybody, for your patience. All right, in just a moment, if you refresh your page, you should see voting open for MUC 2025-72 at the Hospital Value-Based Purchasing Program. Again, your options are A, to recommend, or B, do not recommend. If you're voting do not recommend, go ahead and include your rationale in that next tab. And we're expecting to see 20 votes. So I see them coming in. We are at 18, so just waiting for those last couple to come in before we move on. All right. We have all of our votes for that one. So we will go ahead and move on to our last program here in just a moment. Okay. Okay, voting is now open for MUC 2025-72 at the Medicare Promoting Interoperability Program. Again, you can vote A, recommend, or B, do not recommend. Yes, this is the appropriate time for the Jeopardy music. If we had any or dramatic drum rolls, yes, that would be exactly where we would put that in here in these meetings. So appreciate everyone's patience as we collect these votes and appreciate your participation today. I'm just waiting on those last couple to come in before we move on here. Right. Just waiting to see our last vote come in. And just waiting on that last one. If you're having any trouble with your page, go ahead and let us know. Thank you for your patience here. We're just waiting to confirm that last vote. Looks like that might be, I think, Caitlin, if you're having any trouble with your vote, go ahead and let us know, or you can DM it to me in the Zoom chat if you're having any trouble with it, or you might try refreshing your page.
I think Caitlin may have stepped away.
All right, then in that case, oh, I see it come through. Looks like we are good to go there. And I will hand it back to you, Meredith. Thank you, everybody, for your patience and participation.
Thank you, Elena. Thank you for those of you that were projecting Jeopardy music and drum rolls. We are going to take a break. So that was a great morning, lots of robust discussion, great engagement. Thank you for your energy. Please take until 12:50 ET, and we will resume our measure discussions then. Thank you so much, everybody. Enjoy your break.
Okay, we have discussion forum, so we are going to start now. We're about to do 3 very different but related measures, all centered around sepsis. So we're going to start with the hospital 30-day all-cause risk standardized readmission rate, or the RSRR, following sepsis hospitalization measure. This is MUC 2025-055. Let's go to the next slide. So this measure estimates a hospital level 30-day all-cause risk standardized readmission rate for patients 65 and older, discharged from the hospital with a principal diagnosis of sepsis, including post-procedural sepsis. Readmission is defined as unplanned readmission for any cause within 30 days of the discharge date for the index admission. Readmissions are classified as planned and unplanned by applying the planned readmission algorithm. CMS will report the measure for patients who are 65 years and older and enrolled in fee-for-service Medicare or Medicare Advantage and are hospitalized in non-federal short-term acute care hospitals. This is an outcome measure analyzed at the facility level, and it is currently under endorsement review. And it's being considered for 2 different programs. So keep that in mind as you do your reviews today. It's going to be considered for the hospital inpatient quality reporting program and the hospital readmissions reduction program. So with that, let me turn it over to CMS. I think Dr. Ron Klein, are you going to be the one that does the rationale for this one?
Yeah, good afternoon, everyone. We'll be talking about 3 different sepsis measures this afternoon. I think all of which are important, all of which are different. And I think that speaks to the importance of sepsis as a cause of both morbidity and mortality in the United States, which is why CMS is focusing on these trio of measures as much as it is. So things that you may already know is CDC reports that over 1.7 million US adults develop sepsis, and at least 350,000 people die every year from sepsis. There have been some very, very heartwarming stories, I don't know if that's the right word, sad stories, I guess maybe a better term, of people who had missed sepsis and passed away, including some young children. Research shows that the 30-day readmission rates after sepsis hospitalization range from 17 to 26%, leading to significant costs. Therefore, CMS is considering the inclusion of the hospital 30-day all-cause risk standardized readmission rate, RSRR, following sepsis hospitalization claims measured into the hospital readmission reduction program, as well as a hospital and patient quality reporting program, as we stated. Readmissions negatively impact patient health and add financial strain on patients and the healthcare system. Preventable readmissions stem from iatrogenic infections, medication errors, muscle weakening, and pressure ulcers, such as decubitus ulcers. For sepsis survivors, avoidable readmissions heighten the risk of reinfection, ICU stays, mortality, and long-term issues such as cognitive impairment, functional disability, psychiatric conditions, and increased healthcare use, all contributing to a lower quality of life. This measure estimates a hospital level 30-day all-cause risk standardized readmission rate for patients aged 65 and older discharged alive with a primary diagnosis of sepsis, including post-procedural sepsis, from non-federal short-term acute care hospitals. Readmission is any unplanned return within 30 days of discharge for the initial admission. The planned readmission algorithm classifies readmissions as planned or unplanned. It will be reported for patients 65 and older enrolled in fee-for-service Medicare or Medicare Advantage hospitalized in a non-federal short-term acute care hospital. The measure is risk adjusted for age, comorbidities, severity, illness, and functional status. And for those of you who are deep into the sepsis world, as I have become over the last couple of years, the sepsis readmission measure, like the SEP1 measure, uses the SEP2 definition, which defines sepsis as patients with suspected or documented infection and greater than or equal to 2 systemic inflammatory response syndrome SIRS criteria. SIRS is defined by the satisfaction of any 2 of the criteria below: temperature greater than 38 centigrade or less than 36 centigrade, heart rate greater than 90, respiratory rate greater than 20, or PaCO2 of less than 32, white blood cell count greater than 12,000 or less than 4,000, or greater than 10% immature bands. While both measures address sepsis, the 2 measures reflect distinct aspects of care. SEP1 assesses early and timely sepsis treatment, while the sepsis readmission measure focuses on discharge planning and coordination of post-discharge ambulatory care. This claims-based measure demonstrates importance, feasibility, and validity. It also demonstrates reliability with a signal-to-noise ratio of 0.6. It aims to reduce preventable adverse events, lower unplanned readmissions, enhance patient engagement, ensure continuity of care, and improve resource utilization. It is claims-based, and the score is calculated automatically, so there's no measurement burden here. There are no measures for sepsis. Currently, there are no measures for sepsis readmission, leading to gaps in tracking and reporting hospital sepsis readmissions. Preventable readmissions among sepsis survivors highlight the need for targeted interventions to reduce morbidity and improve post-discharge outcomes. Hospital-specific readmission rates vary due to different care processes, suggesting that better strategies can improve these rates. The sepsis readmission measure identifies institutions performing better or worse than expected based on a patient case mix. The sepsis readmission measure will encourage hospitals to create structured care processes acute and post-acute settings, and this includes investing in transitional care models and implementing targeted post-discharge interventions. I apologize for nobody ever calls me except now. Apologize for that. The sepsis readmission measure will encourage hospitals to create structured care processes across acute and post-acute settings, and this includes investing in transitional care models and implementing targeted post-discharge interventions, such as coordinating with primary care providers, home visits, follow-up calls, patient education, medication reconciliation, discharge planning, and telemonitoring. These strategies aim to reduce hospital readmissions and improve patient outcomes. This measure has been submitted to the fall 2025 CBE cycle with results pending at this time. And on to you, on to others.
Okay, so now I'm just going to summarize some public comments that we received on this measure. I believe there were about 24 written public comments, 2 that were spoken aloud, and we did see, some pretty wide at all, or just
Brenna,
I'm quiet?
I can hear you.
Brenna, we can hear you.
Bridget, I can
Rosie,
hear.
I can hear you fine.
Okay. Okay, thanks all. Can somebody just work with Rosie on her?
I can hear you now. Okay.
Oh, good. Okay. Okay, so I was just summarizing some of the key themes that came out of public comment. A really strong theme that we heard in support of the measure is how important the topic of sepsis is, and this measure filling a gap alongside other outcome, process, and structural measures, that this really gets at the responsibility of leadership of an organization to empower its frontline and middle managers to do the things that they need to be doing. We also heard from many, many people I'm not sure what to do about that.
oh, Brenna, I don't have you cutting out. So I think folks may be experiencing maybe volume control issues on their speakers.
This is Bridget. My connection's been steady.
Yeah, I haven't had any drop-offs.
Odd. Yeah, we're getting a lot of folks saying that it's cutting out though. So there's probably something going on with the Zoom itself. If some people are hearing and some are not. Can people hear me now? Okay.
Yes.
All right, I'll try to breeze through then. So again, this measure was viewed as being some of high quality alongside SEP1 and not replacing it. People felt that this measure will support hospital efforts to optimize quality of care for sepsis patients and provide comprehensive assessments of post-discharge events. We heard from the American College of Emergency Physicians and a few other related organizations that the measure appropriately recognizes sepsis as a condition associated with substantial post-discharge vulnerability and reinforces the importance of care transitions, recovery, and longitudinal management as integral components of high-quality sepsis care. We also heard from the Infectious Diseases Society of America and their partners, also strongly in support of CMS's efforts to advance national sepsis quality measurement. And although acknowledging that the measure is not perfect, they felt that this proposed measure represented an important and necessary step toward improving sepsis care and outcomes, and supports moving forward with it while continuing to engage stakeholders to address the implications related to implementation challenges, unintended incentives, and things like that. On the other side, the concerns that we heard via public comment, again, related to that 30-day window that we talked about quite a bit yesterday. Same in terms of ongoing concerns about the addition of Medicare Advantage data and unintended consequences. So very similar themes to what we heard on the EDAC measures yesterday. Some folks expressed concern about whether this measure aligns with SEP1, that strong performance on one doesn't seem to align with strong performance on the other, and question the administrative burden of requiring facilities to report on both. So this committee should probably work out how that balances against the other feedback that we got, that they are complementary. And then a key consideration for this measure is its exclusive reliance on claims-based data for both sepsis identification and risk adjustment, which, unlike the adult sepsis event-based mortality measure, may variably identify sepsis hospitalizations and incompletely capture key aspects of illness severity and clinical complexity. So folks felt like this measure may be more susceptible to residual confounding and unintended incentives, whereby documentation or coding practices may influence measure performance without corresponding improvements in patient outcomes. So really just saying that it warrants careful interpretation and ongoing evaluation for the measure. And then others just ask that we consider equity implications of readmission-focused measures. Readmissions following sepsis are strongly influenced by access to post-discharge resources, outpatient follow-up, rehab services, and also social determinants of health that vary widely across patient populations and communities. And without carefully evaluating that, such measures may disproportionately penalize hospitals that are serving socioeconomically disadvantaged populations. So that commenter recommended stratified analyses and ongoing monitoring. So kind of a, I think, largely supportive public comment with a few key topics that are worth drilling down into in our discussion today. But before we open it up, let's just go to the next slide really quickly so we can go through closing care gaps. This applies to all of the sepsis measures today, so I'm just going to read through this once. So for the next two measures, I won't repeat this. So in terms of what we understand about gaps of care related to sepsis, we know that age is important, and all of these measures are risk adjusted by age. We know that as people age, immune function declines, which increases folks' susceptibility to sepsis. Again, in terms of geography, patients readmitted to a different hospital within 30 days after hospitalization for sepsis, which is more common in rural facilities, may experience higher in-hospital mortality, a longer length of stay, and higher hospitalization costs. And when compared to urban patients, rural patients have higher odds of in-hospital sepsis death. In terms of insurance status, we know that sepsis survivors incur high health costs that can persist for years after discharge from their initial hospitalization, imposing greater financial burdens on uninsured patients. And patients who are on Medicaid have the highest odds of sepsis mortality. And for patients hospitalized with sepsis, limited English proficiency increase the odds of sepsis mortality. So lots to consider there. So let's go ahead and go back to the description slide. And I just want to open it starting off to our advisory group members. Folks, if there's any particular topic you'd like to make sure that we prioritize in this discussion, now would be the time to raise it. Yeah, Jen.
So I'm just going to reiterate something I talked about yesterday. There's 2 points from my organization they'd like to point out. One is, again, the Medicare Advantage plan issues. When you put this in an HRRP program, this measure becomes, we have a Medicare Advantage lack of payment for the readmission and then a potential federal penalty. So our recommendation that CMS work with MA plans to make sure that they align consistently for readmission payment would be most helpful. We were comforted by the fact that the measure is using the hospital file instead of the MA plan file. So that was helpful. The second comment I had from our chair of our 32 hospital organization is that sepsis definition is not consistently defined between SEP 1, SEP 2, SEP 3. And the recommendation for this measure is that professionally that's not well aligned, and possibly to hold or consider the national organization's alignment before this measure is implemented. Thank you.
And Samaya, go ahead.
Premier had similar concerns over the measure specification. We think that, if the same population is being measured, then that should be reflected in the definitions. And again, that would help to decrease burden for hospitals. And also, we strongly recommend that this measure not be considered for the hospital readmission reductions program, at least until it has been reported for several years in the hospital IQR program, to allow hospitals time to understand the measure as well as work on improvements and making the necessary changes to their organizations.
Thanks, Samaya. And for those that are maybe less familiar with how these programs are structured, can you just give a quick reason for why you'd like to see it being used in HIQR before the readmissions program?
Was that a question for CMS?
It was a question for Samaya. Just if you could just
it's so that when it's first rolled out in the IQR program, then hospitals can assess where their performance is, what they need to do to impact their performance results, especially if it's not, if they're not doing well. And those process improvement changes, they just take time. And so staggering the rollout would allow hospitals to be well positioned to perform well in when the measure is moved to the HRRP program. Does that make sense?
It does. I'm trying to get at for folks to understand why HIQR is the better starting ground for the measure than readmissions.
I think it's because there's no money tied to the IQR program.
Okay, thank you. Sandy, go ahead.
Thank you. I agree with both Jan and Samaya, and in regards to the I support the addition to IQR. I agree not to include it just yet in the readmissions reduction program. We have 60 hospitals. Most of them are rural, so we don't employ our providers. And every time we change provider groups or every time we rotate providers, we're constantly in that struggle between our abstractors as far as the definition of SEP1 and then the providers coming in and their reliance or desire to use SEP2, and it just creates a lot of struggle. And so until we have that single definition, especially with the different payers where the payers want SEP2 and CMS wants SEP1, it could lead to a double penalty for our hospitals, and it will increase confusion, especially if we're being penalized. And I think having time to work through that with the IQR would be beneficial.
Thank you all. Okay, so I'm hearing that. I'm hearing strong recommend for this measure being used in IQR for a few years, giving hospitals an opportunity to work out their processes before it gets used in sort of a payment program. And then I also heard quite a few comments about the inconsistent sepsis definitions. Zahid, do you want to add to that, or should I turn first to CMS to clarify the definition for sepsis?
Either way is fine. I just wanted to make a general comment.
Yeah, go ahead. Let's add that now.
Okay, so I think that we've sort of had a lot of different conversations, pro and con on the sepsis bundle. There's a lot of people take very emotional positions on either side of it for a few years now. And so it is a process of care measure. And obviously sepsis is a very important condition. Everybody recognizes that, similar to the ED being wait time being a problem. So I think that there's an opportunity to now have sort of a measure set around sepsis with that process measure and the readmission measure as a claims measure. And the next two measures, I believe, one is a structural type of measure and the other one is a outcome measure. So the readmission and the mortality are outcome measures. So I think these all somehow, if CMS can sort of correlate in the outcomes and how they are related to the process bundle and stratify in some fashion, do some more analysis so that we can get a more comprehensive picture of sepsis care and its outcomes.
Zahid. All right, let me pause there quickly. Ron, I saw that you had your hand up earlier. I assume it was to clarify the sepsis definition question. Forgive me if I'm wrong, but I think that would be helpful.
I'm a very poor fourth choice for getting into these. I didn't see Dr. Townsend on the meeting anymore. I don't know if there are other folks who can speak to that, but basically there are various different definitions of sepsis. And as you can imagine, as you change the definitions, where you increase the sensitivity, you decrease the specificity, and you increase the specificity, you lose the sensitivity. It basically has to do with the fact that inflammatory responses like high heart rate and tachypnea, various things are not terribly specific. So that, and different people for different reasons use different measures. And I would love to have a uniform definition, if only the infectious disease world could give us a uniform definition. But again, I'm a poor choice to speak to that. I don't know if there are others on the call who can speak this better than I can.
Yes. From Yale, maybe. Oh, sorry. Go ahead.
No worries. Hi, everyone. Good afternoon. Yeah, so let me just talk a little bit about the sepsis definition. I think as Dr. Klein had mentioned earlier when he was going through presenting the measure, CMS does use the sepsis 2 definition for their sepsis measures, and that includes SEP1 as well as the sepsis readmission measure. The cohort for this measure is identified by diagnosis codes in claims. Sepsis is defined using the sepsis coding guidelines, both sepsis, severe sepsis, as well as septic shock. And as mentioned, SEP2, the sepsis 2 definition is what is being used to measure, and all the other measures that CMS kind of is kind of own for in the program. And then in talking about the SEP1 and the sepsis readmission measure, I want to clarify here that SEP1 and the sepsis readmission measure are 2 different measures. SEP1 is a process measure. This sepsis readmission measure is an outcome measure. Also, there is no overlap between those 2. SEP1 focuses on early detection and timely intervention when a patient presents to the hospital with sepsis, while the sepsis readmission measure focuses on post-discharge care and utilization. Similarly, we have 2 different patient populations with those 2 measures. SEP1 is focused on sepsis in patients 18 and above. The readmission measure focuses on Medicare patients and Medicare Advantage patients 65 years and above. Similarly, their exclusion criteria are very different, so there really isn't any overlap between those 2 measures. In addition to that, there's no burden as well associated with the sepsis readmission measure. SEP1 is a chart abstracted measure. However, the sepsis readmission measure is solely a claims-based measure. So hospitals really don't have to do anything. It's kind of all taken care of in the background. Yeah. So I can pause here.
I'll summarize maybe and see if folks have follow-up, but it sounds like essentially what we're hearing is that there are absolutely a lot of different clinical definitions that can be used to define sepsis, but that the measure developers for this measure are doing their best to mitigate that burden by harmonizing it with SEP2 as it's the most clinically appropriate for this measure. Okay. Lisa, did you have something to add?
Yes, and Brenna, thank you. That was a great summary. I just wanted to, first of all, I wanted to call attention. There are some responses in the chat around the 30-day readmission period. I also just want to reinforce Dr. Klein's, we talked about yesterday how measures have trade-offs, and with Dr. Klein, he elegantly discuss the trade-off between sensitivity and specificity, whether you're collecting more patients or fewer patients. And there is some conversation in the chat around the denominator potentially being too expansive. Our investigations aren't consistent with it being too expansive, and the calibration and performance of the risk model are excellent, and the C statistic is consistent with other readmission measures in use, suggesting that even if this, coding for sepsis is somewhat more expansive, it's still a population of unmeasured patients who are at risk for readmission, as evidenced by the emergency department professional society flagging the importance of this. So I just wanted to reinforce that. I think we talked a lot about Medicare Advantage data yesterday, but happy to revisit that if anyone in the committees would like that.
Thanks, Lisa. Super helpful, and appreciate you bringing up the nuances of the conversation happening in the chat for the rest of the group. Okay, at this time, let's open it up to our patients. I think as folks have already, I think Zahid sort of correctly pointed out, this is an issue that affects lots and lots of people and sometimes very gravely. And so I just want to make sure that we're setting aside space for our patient participants to weigh in. And Rosie, I see your hand is raised.
Well, I'm a patient who survived sepsis multiple times, and also have survived septic shock. And I probably hold the record for readmissions after sepsis hospitalization in the country. But I had a sepsis 1 or a sepsis 2 bundle long before anybody even was talking about this, because my infectious disease doctor realized early on what triggered my sepsis and how important it was that the hospital and they did the right things day one of being admitted for sepsis. And so that's why I survived septic shock. It was exactly why I survived. I survived septic shock 15 times. I was intubated. I was in a coma 15 times, and yet I survived. And so, this is probably one of the most, you don't understand that when somebody has an infection and it's a long-term infection, like MRSA, and I had multiple amputations. I'm amputated all the way to my waist on my right side. And, this was from a knee replacement. It's gone wrong. And yet I have survived this because I had good physicians, infectious disease docs, who really, really made sepsis and understood sepsis. And I had a husband at that point, at least when I survived septic shock and sepsis so multiple times, that understood sepsis and was educated about sepsis. So that's another whole piece that we haven't even touched on yet.
First, Rosie, thank you so much, as always, for your candor and for sharing. And I do want to point you to the chat where there are some very, very supportive comments from your joint committee members and also from CMS. But it's so important. I think you're raising really important points about the patient experience and what it really is like when this goes wrong and when it goes right, and that the consequences are grave in both cases for many people. So thank you. Any other patients want to weigh in before I open the floor to the recommendation group? I should say the rest of the recommendation group, since Rosie's on it. Okay, all right. Then I think we've got quite a lot based on those initial inputs to talk about here. So I'm going to open the floor to the recommendation group, asking that although there's been a lot of chat and a lot of agreement that these definitions matter a lot in terms of getting the measure right, I think what we need to discuss as a group here is what this measure, as specified, can and can't accomplish, and whether that makes it appropriate for use in one or both of these programs. And Marty, I saw that your hand was raised and then went back down, so apologies.
I'm listening to this. I mean, my understanding is we do not have a sepsis readmissions measure at this time. Is that right?
Yes, correct.
It's just shocking to me that we don't. And I'm in the space of, if we can't be perfect, at least we can make some good progress by having a sepsis readmission. So that's where I am now. Thanks. And I'm listening.
Thanks, Marty. Yeah, Jeff.
First of all, Rosie, thanks for being here. That was really, really moving to hear what you've been through. Just a little bit of measurement nerd detail. Obviously, sensitivity and specificity on these measures are important. But generally, if a measure in either the numerator or denominator has specificity or sensitivity over 50%, which I suspect this one does, then as long as the sensitivity is constant across hospitals, hospitals will be rank ordered appropriately in terms of performance. So I'll leave it to folks more up on the coding as to whether we think that that's likely to vary across hospitals. But generally speaking, you can have a pretty effective measure, even if there are some small concerns about sensitivity.
Thanks for that, Jeff. And I'll ask Yale just flag that one to comment on in a second. And Ben, over to you.
I'd be remiss if I didn't make a statement here. My father almost passed away 2 years ago due to sepsis, due to kidney stones. This was something that was unfortunate, and he was readmitted to a hospital facility within 3 times within a 45-day period of time. It was something that should have been caught immediately through the ER, but with some complications with the antibiotics that they did not prescribe him immediately, and also the culture testing, it just progressed, and his cognitive decline has increased due to that. He's in his late 60s, and he's like a 78-year-old now. With this, I mean, as far as measures go, I think this is one that needs to be pushed forward with some additional measures, around sepsis.
Thanks very much for sharing that as well, Ben, and I'm glad that your father is well. Okay, I'm not seeing hands right now, so let me just do a quick kind of summary of what we've heard so far. Because again, we have 2 more sepsis measures after this one, where I'm sure some of these comments will come up again.
Brenna?
Yeah.
Sorry, is it okay that we speak up about the coding variation?
Sure.
Okay, thanks. All right, so just wanted to touch on the sepsis coding variation because that was something that actually came up during measure developments. It also came up in our while we were working with our TEP to develop this measure, and just wanted to point out that we did assess hospital level variation in the use of sepsis code, and we did not find that there was any association between that there was any differences across hospitals in terms of how they were coding for sepsis. So we looked at the sepsis coding by hospital level volume of sepsis cases. We also looked at the association between the frequency of sepsis code and the outcomes. So we looked at the unadjusted 30-day readmission rate as well as the mortality rates. And with those analyses, we did not find that there was any, there was no association with the use of the codes for either of the outcomes, readmission or mortality. When we stratified by hospital volume, we also didn't see any differences in terms of across hospitals, also stratified by volume in how sepsis is coded. So wanted to just mention that to the group to let them know that it was something that we did take a look at and we considered, and we didn't find that there was variation across hospitals.
Thanks, that's really helpful. And I saw that Jeff replied in the chat. He said that it's awesome, and others have said that it's helpful. So thank you. I'm glad that you interjected. That's helpful. Okay, let me summarize what I think I've heard so far, and then if folks want to make sure that any other points get raised, we can add that. So what I have heard is that this measure is filling an important gap because there is currently no sepsis readmissions measure yet. We have heard across the board that sepsis is of critical importance, and it's an area where there is an enormous performance gap that can be improved. We have heard that despite some and maybe many challenges, that this measure represents an important step in measuring and advancing sepsis care. And then we also heard early on and then echoed again some concerns about this going immediately into the readmissions program, and that this measure may be better suited to doing a few years first in the hospital inpatient quality reporting program, where it's not tied to financial incentives to give hospitals an opportunity to get their workflows in order before being put into a financial incentive program like the hospital readmissions program. Are there any major points that I've missed or things that folks would like to add for consideration before we vote for these 2 programs?
I just put one more comment in the chat, just how I like this
approach to a sepsis measure compared to some of the others that had promoted overuse of antibiotics and unnecessary antibiotics. I feel like this is pushing us kind of in the right direction when it comes to thinking about serious infections.
Thank you. Okay, I will turn to my co-chairs. Any concerns about taking this one to a vote?
I think we're ready.
I agree.
Okay, then Elena, take us away.
One hand
Oh,
raised,
Nick,
Brenner.
sorry.
I'm not sure if you want to address that.
Yeah, Nick, I saw your hand was raised.
All right.
Did you have a comment?
Yeah, sorry, I'm sorry to come in last second here. I just wanted to, I put it in the chat box, but we have to I don't always sound like the negative Nancy, but if the most brilliant minds in sepsis have changed the definition, and we're now going to implement a performance measure that does not use that definition, we got to rethink this. Like it just doesn't. I'm not sure that that's what the whole role of performance measurement is, right? I mean, we heard the lack of specificity with SEP 1 and SEP 2. So if I could have a little old lady who's confused and a little hypothermic and nothing else, right? That could be sepsis, and I could call it such. That would not be picked up here. So, at the risk of once again sounding negative, I think we got to rethink what's the intention here, and shouldn't we be using best evidence when we're promoting a performance measure that has high stakes? It has public reporting, it could have dollars. We should be using what the best minds say sepsis is.
Dr. Klein.
Yeah, thank you. I would just add that the best minds don't agree on what sepsis is and haven't for at least 20 or 30 years. So if there, as I said before, it's because there are varying degrees of sensitivity to specificity, depending on which way you choose. And you saw something in the chat that depending on hospital, depending on what insurance companies pay for and don't pay for, there are also coding variations. So I've been working on the sepsis issue for about 3 years now. And again, I'm the fourth best person, maybe the 10th best person on this call to be talking about this issue, but there is no best minds. There's vigorous disagreement as to that. So I'm not sure how we do that until we get to some other technology where we all, some biomarker or something that all says, yes, we all agree this is sepsis.
Yeah, but Ron, there is a consensus.
I don't know that that's true. I mean, I talked to sepsis people.
I'll put the reference in the chat.
Yeah, I may have missed a little bit of it, but I mean, I know there's SEP 2, there's SEP 3, there's SOFA, there's SEERS, and again, they all vary on that. So I personally am not aware that there is a consensus on what is the best definition of sepsis. But again, others, please defer to others who know more than I do.
Yeah, if I could just just to keep the conversation sort of moving, I think what we want, our goal today is to make a recommendation about this measure as it currently stands and whether or not it could be used in the programs that it's being proposed for to improve care. There, I think Nick has pointed out what others have been pointing out in the chat, that there are some definitions that are maybe up for debate, and we have absolutely been capturing all of those comments that are going to get into our recommendations report, things that we're going to be able to recommend that CMS continue to evaluate one way or the other, whether the measure is implemented or not. And so I would just ask that the committee take all of this feedback into consideration. So all of the discussion in the chat that you've seen related to the coding, the responses that you heard from Yale, things that you've heard related to the sepsis definition, and what the benefits and downsides are with using the current definition. And I want you to also consider the patient feedback that we've heard, both from Rosie and Ben and others, about their experiences with sepsis, and weigh all of that together and then make a determination about whether or not this measure, as it's currently specified, should be used in the two programs that it's being proposed for. Okay, so with that, Elena, go ahead.
Thank you so much, Brenna. All right, everybody, in just a second here, you will see that first vote come up. So if we could just go on to the next slide here. There we go. All right, you might need to refresh your screen, but voting is now open for MUC 2025-55 hospital 30-day all-cause risk standardized readmission rate following sepsis hospitalization. Do you recommend including this measure in the hospital inpatient quality reporting program? Again, your options are to A, recommend, or B, do not recommend. If you are voting to do not recommend, please include your rationale over on that other tab. I believe we are expecting to see 20 votes. So I see votes coming in here. Just waiting on a couple more votes. Again, if you did vote to not recommend, please include your rationale in that secondary tab. Just waiting on our last couple of votes here. If you're having any issues with the voting, go ahead and let us know either by speaking up or letting us know in the chat. Or you might just need to refresh your page to see that new question pop up. All right, we are hovering at 18 here, so just waiting on those last couple of votes. Again, if you are having any issues with the voting, please do let us know. All right. 19, just waiting for our last vote here. Thank you for your patience. Looks like Stephanie, we are waiting on your vote. If you are, oh no, Stephanie, I see your vote. Thank you. Still waiting on one more. Apologies. All right, we are still waiting on our last vote, so we might need to move on and follow up with that person. I'll defer to you, Brenna, on that.
Yeah, let's go ahead and keep moving so that we stay on time.
Okay, we will follow up with that last person. You will see your vote change here in just a second. I'm going to go ahead and change a couple of things over. All right, activating that next vote. So if you refresh your screen, you should be able to see the next vote pop up. Again, this is for MUC 2025-55, but this time for use in the hospital readmissions reduction program. Again, your options are A, recommend, or B, do not recommend. If you are voting to not recommend, go ahead and include your rationale in that next tab. You see some votes coming in. Again, I believe we're looking for 20. We are at 17, so I see our votes coming in. Again, if you are having any trouble with the voting, go ahead and let us know via the chat or speak up if you're having an issue.
All right, why don't we move to the next measure because we'll stay on sepsis and then our team, can we just chase down those last few votes. And then hopefully by the time we finish the other sepsis measures, we can report out on the scores or on the outcomes for this one.
Yep, absolutely.
Thanks, Alina. All right, thanks all. That was a great conversation. Let's jump to sepsis measure number 2 here. Okay, so now we are turning our attention to the Hospital Sepsis Program Core Elements Score. This is MUC 2025-047. Let's go to the next slide here. So this measure is an annual non-weighted score that assesses acute care hospitals on their leadership support, personnel resources, and implementation of quality improvement tools and practices to improve the recognition and care of patients with sepsis. So the measure score is the sum of hospital sepsis program priority examples in use by hospital. So this is a structure measure at the facility level of analysis. It has not been endorsed, and it's stewarded by the CDC. And it's being considered just for the hospital inpatient quality reporting program. Now, Dr. Klein, I know that your overall description for the last measure kind of covered all the sepsis measures, but was there anything additional you wanted to say about this one? Oh, and you're muted.
Apologies. Yes. Yeah, so I will not reiterate what you've heard about sepsis, nor will I reiterate it when we talk about this, the third sepsis measure. I think just for those of you who are new to quality measurement, I'm guessing that's relatively few. There's sort of 3 levels of sepsis measure, 3 levels of quality measurement from Dunn-Beatty, which is structural measures, process measures, and outcome measures. And this is a structure measure, which is basically just asking the question, within your hospital or within your facility, are you putting in place all the structural things you need to do to take the best care of your patients? And that's the only thing I would probably add to this. And there are, hopefully you got that in your work. There are 28 different there are 28 different hospital sepsis program priority examples from the CDC that they identify as being linked with better sepsis care. And I would just say, I said before, there are some unfortunately terribly heartbreaking examples of some of people passing with sepsis. And I think a lot of this work is coming from a young man who I think was 10 or 12 years old, who, in New York State, who went back to the hospital several times. Parents did everything possible, and he still wound up dying of sepsis. And as the father had said, he meant to be, he should have been buying a pizza for his son that Thursday, but instead he was shopping for a casket. So there are these terribly sad stories, which is what drives a lot of our passion in sepsis. And with that, I'll stop and leave it on for discussion.
Thanks, Dr. Klein. So as I said, for the last measure, the closing care gaps information is the same across all the sepsis measures, so I won't rehash that, but I do want to give a little bit of the feedback that we heard specific to this measure via public comment. The first was overall support for a structure measure, indicating that it really gets to the leadership at hospitals who have the ability to influence what frontline workers do. And again, strong support for this measure to be implemented as a supplement to SEP 1. We also heard someone say that this represents a vital component in the provision of excellent sepsis care, and that we saw strong expressions of support for its implementation. On the concern side, there were some folks that felt like this could have been specified a little bit more clearly, and that folks had a little bit of a difficult time interpreting the metrics for this outside of the NHSN survey responses. So, wanting to see more information about the survey itself, the level of compliance, any psychometric testing that had been done, and so on. So just looking for a little bit more information on how this measure was tested and specified. And then there were others that just felt that this measure requires hospitals to establish and maintain sepsis capabilities without providing a payment pathway for the diagnostic capability required to make those systems effective. So again, something else to consider. And that's pretty much what we heard that was specific to the core element score. So with that, let me open the floor to our advisory group members. Yeah, Jen, go ahead.
I'm always first because it's easier just to be quiet afterwards. I work in an organization with 32 healthcare facilities, and we have 6 critical access and probably another 6 that are small community hospitals. We are in our sepsis chair for our enterprise is highly supportive of this measure, but we are asking if you would consider that in some cases where we're talking about these small facilities, we have one small facility that is near a university where they have lots of births, and that facility is 98% delivery is their acute inpatient population, and maybe 4 or 5 medical patients, let alone sepsis patients, during a course of a month, if we're lucky. We would like CMS to consider that maybe volume based on your number of cases that you could, if your enterprise was meeting the needs of some of the roles, sepsis lead, by the time you take these small hospitals and ask an MD and a coordinator and an RN to work in those smaller hospitals, that becomes a profound volume. But if, like in the maternal measure, we could piggyback off the concept of enterprise-led, possibly volume related, then that would decrease the burden for the rural hospitals. Thank you.
Oops, sorry, I was muted. Mary, go ahead.
Thank you. And I agree with Jan about the volume-based. And let me just say, I love this measure. I'm at a 3-hospital system, and for the last 5 or 6 years, we have been begging for a sepsis coordinator, and it's just not sexy enough for the organization, I think. So, we have coordinators for stroke, we have coordinators for our total joints, not sepsis. So, I have one lone abstractor that has the burden of the entire system, leading all the meetings and creating all the data and doing the abstraction. So I absolutely love this measure, and I hope it gets all of the hospitals, and more importantly, our patients, what is needed. Thank you.
Thank you very much, Mary. Really quickly, before I turn to Samaya, folks from the CDC, some people on our team are trying to promote you to be panelists so that you'll be able to chime in and comment on the measure. So if you get a request, please accept it, just so that you can respond to the comments. In the meantime, Samaya, go ahead.
So absolutely agree that sepsis is a very important topic to address and to improve quality around. I think the only question I want to pose is if a structural measure is really the best way to achieve and affect the outcomes that we're seeking.
Thank you for that. Beth, go ahead.
Thank you. And so what I'm hearing around sepsis in general, I agree with. And personal, story, while I've worked in the ICU for years, I've also lost my mom last year to sepsis. So I understand the emotion related to having those events happen in your life. I do like the idea of a sepsis structural measure, but working in a system with community hospitals, what we're finding with the structural measures is that the burden is in developing new structure with those highly important people in your organizations, like physician experts and subject matter experts. And so my ask would be, as we're looking at how we phrase the sepsis structural measure, can we look at not just new roles, but also being able to support the tasks maybe within the current structure of the organization? So I appreciate it, and thank you for your time.
I'm sorry for your loss, and thank you for sharing. And and noted in terms of the potential additions or considerations to the measure. Okay, and I'm also seeing quite a lot of back and forth in the chat. So let me, before I get to that, because I'm also seeing some of that is recommendation group members, let me just open the floor quickly to our patient participants to see if there are any additional thoughts there. Rosie, go ahead.
I put one in the chat, but you know, over the years, over the last 16 years, I have heard many. Every time I speak on sepsis somewhere in the country or in the world, I've heard multiple stories, especially about young people dying of sepsis. And even the reason I share my sepsis stories is because of a young person dying and her mother coming to me and saying, "Can you talk about sepsis?" And I tell her story always. But yet, you know, change hasn't happened. And today, I hope today is a change day and that we can get across, you know, move beyond our differences and our opinions, but really make sure that their change happens, because we don't tell these stories, these stories because we want somebody to feel sorry for us or have sympathy, but we tell these stories to create change. And that's why patients share their stories, is to create change. And we don't always know all the logistics behind that change, what that change might cost to a system or to a healthcare enterprise, but yet, you know, change is important, and change is what keeps us keeping patients safe.
Thank you, Rosie, as always. Marty.
I'm going to reinforce Rosie's comments by feeling sort of taking a different take on it, and that is change is important in a reasonable time frame. One of the things that is the hardest for patient safety advocates like me to understand, and I think patients in the public in general, is why we have so much variation in best practices for such long periods of time once we identify best practices in this country from place to place. It's one of the main things that causes the distrust in the healthcare system. And I think this use of CMS's transparency level, public reporting, to say this is the expectation of CMS for what best practices look like based on solid work out of CDC. I just think it's a brilliant use of public reporting to send a signal that this is really to leadership and governance, that this is really what you have to support in your organization. And I think it has the potential to, by sending that signal, to change standards of care. And you know, I know it's a limited strategy. I know it can be gamed. I still think it's a valuable complement to the other ways in which we approach measurement. So I'm a huge fan of the structural measure strategy that CMS is rolling out, and I think this is a very appropriate use of it. I also just want to commend the sort of agency partnership work that went into kind of developing this set of best practices and then bringing them forward into this program where they can be implemented. Thank you.
All right. That is helpful. I think we've heard from our AG, and we've heard from our patient and patient advocates. So let me just open the floor now to the recommendation group. And Julie, go ahead.
Excuse me. I like this measure, and in general have a love-hate, but more love relationship with, again, this idea of a sepsis readmission and this core program elements, because somewhat in answer to Marty's question of why there's so much variability, we talk about sepsis like it's a single entity, but it's not. Different than pneumonia or COPD or heart failure that are kind of these singular pathophysiologic states. Sepsis is a symptom. You know, it's a broad category of your body's just not handling fill in the blank infection well. And so for me, approaching sepsis measures is more about addressing, these are multi-morbid, complex care management, high social determinants of health patients. And that once you get to the core of those issues, you're probably going to address the variability in sepsis outcomes more so than just, did you get them antibiotics fast enough? And so for me, sepsis measures, when we're thinking about them in our own value-based care plans and programming, we think about them more as much a care management approach as it is just, again, antibiotics and fluids and the pure treatment of the sepsis state.
Thanks very much for that. That's helpful clinical context. Okay, I am seeing loads of questions in the chat. So Caitlin, if you don't mind, I just want to ask a question that I saw from Jeff in the chat that I think echoes some of the questions that we heard via public comment. So Jeff said that he agrees this is important and that structural measures are valuable, but he's asking about the number of items in the survey that ask the respondent to determine whether sufficient resources are provided, and felt that that seemed to be open to interpretation and possible gaming. And so I'm wondering, Ray from CDC, could you talk a little bit about any consideration given to the framing of these questions and how you think that'll be fielded?
Thanks, Brenna. So we did take those considerations into account. We had to devise a survey here, right, and questions that can apply across all hospitals, a very wide range of hospitals, from your largest 1,000-bed hospitals, to your rural and underserved population hospitals with 20 to 50 beds, for example. And sufficient resources, for example, in some of these questions, does your hospital have sufficient resources or a lot of time for its leaders? Does it have enough information technology support? That is going to be up to the interpretation of the folks on the ground. So for example, you could be working at a 500-bed hospital and have 2 dedicated sepsis coordinators and still be under-resourced, if the burden is too high. Yet you could be at a small 50-bed hospital and have a single kind of quality improvement person that handles sepsis and stroke and STEMI, but with enough IT support, feel well-resourced in that role. And so we didn't want to prejudge about what is appropriate or not, or enough support for each hospital. We want the hospitals to be able to report that honestly. And I think that's part of the reason why we applied, we submitted this measure for IQR and not other programs. So we do value, and are want to encourage, honest reporting, because we see this measure as more of the how you get to better outcomes, like better performance in sepsis outcome measures, like the mortality measure that we're going to talk about next, the readmission measure. It's also how you get better performance in process measures like SEP1. And so we want hospitals to use this information to get better outcomes, for their patients. I think I also want to emphasize, that we will have an audit tool available on the CDC side. Should this be incorporated into CMS programs, there are existing audit mechanisms that CDC and CMS work on for our other measures that already exist and could be folded into a similar process, for example. Thank you.
Thanks, Ray. And I also wanted to note there is on this slide an update. So it says on the right here that this measure has never been submitted for endorsement. This actually has recently been submitted and is going to be undergoing endorsement review in I think it's the spring or fall cycle of this coming year. So just wanted to make sure that folks realize that this has been submitted for that. Caitlin, go ahead. I think you were next.
Thank you. Sorry for being off camera and for any weird sounds. I've got a feeding baby in my lap. So AHA, the American Hospital Association, is very supportive of the core elements. We have been the whole time, and I think this measure is a really interesting way to approach the topic. I will also say that structural measures tend to be a low bar, and for such an important topic like sepsis, considering that we are looking to other sepsis related measures, my recommendation to CMS as it goes forward is to, explicitly lay out in future rulemaking or other communications what it is, what the idea is here. What are we looking at in terms of addressing sepsis rates going forward? And I think, looking at the experience from the other structural measures like the obstetrics measure and the age-friendly health system measure or age-friendly hospital measure, we're not done just with the structural measure. There are plans to continue to develop, and we're going to talk about the mortality measure next, which is, still under additional testing and development. So, let's just make sure that we don't say we've got a structural measure about sepsis, so we're done addressing sepsis. There's a lot more to do. The other thing that I will mention is that again, with the experience with the structural measures, particularly the age-friendly hospital measure, we're going to need some really and Dr. Nates, you mentioned the audit tool, but some substantial attestation guidance. There's a lot of concern, maybe not concern, but just our members really want to report these measures accurately as much as possible. Even though there might not be validation in the same way that we validate other types of measures, there is a lot of concern about reporting accurately. What does it take to attest positively? What specifically do we have to be doing? And I know that we appreciate the flexibility that you mentioned, because not every hospital is in the same place in its journey. But at the same time, you are going to get a lot of questions, and so are we, about, am I allowed to say yes to this? Can I attest positively to this if this is what I'm doing? So that's just throwing that out there way ahead of time. And also just a larger question about structural measures in general, just knowing that part of the Universal Foundation and meaningful measures back in the day, we're looking for a streamlined and meaningful measure set. So I do think it's important to think about the makeup of that measure set being taken up by an increasing number of structural measures, and what the future of the measure sets that CMS is using in their programs is going to look like. And looking forward, I think it's going to be important. So just general considerations, but I think overall we're generally supportive of this measure as long as it's not the only thing we're doing about sepsis, which obviously it's not.
Thank you very much. Julie, I see that your hand is up, but I think it might just be an artifact from earlier. Is that right? Or did you have another comment?
Nope, I'm good.
Okay. All right, then Nick, go ahead.
Thanks. So, look, we support anything that's going to improve the care of the sepsis patient. And I want to give some context here. So our health system in New York, we were the leaders. Rory Stanton's parents are part of our sepsis campaign. I've met his mom and dad. That's the little kid that Ron referred to. And I was one of the 3 leaders of our sepsis campaign that drove down mortality, that led to the New York State adopting this, and I think had a hand in CMS looking into it. So we are 100% behind this. But I do want to let, in all due respect to our patient members, every time we say yes to something here, you got to remember that's taking resources away from something else. There's not an infinite pot of money or people to do all this, to aggregate data, to report data. And thus, we need to be very deliberate and specific in what we ask for, that it has to be feasible and meaningful, the criteria here. The clinical inertia that Marty spoke to earlier, the frustration with how long it takes things to be implemented, will only be worsened when we do things that are not current state in the scientific community. So if there's a SEP3 definition and we're working off a SEP1 definition, there's going to be more challenges. And I know this because we did it here in our system. And the effort was Sisyphusian, but we did it. And it did have an impact. So love that there are attestations here holding hospital and system leaders accountable to put their nickel down and say, yeah, this is important. We have to do something about it. I will stop opining there.
Thank you. Okay, well, I'm seeing no additional hands up. So let me do a quick summary here. And as we've done for the last few, if folks have things that they'd like to add to the discussion, we can do that. Otherwise, we'll take it to a vote. So what I heard from the committee and from the public comment is that this measure addresses a very important aspect of sepsis recognition and care by targeting hospital administrators and leadership in making sure that resources are put towards the right things to prevent and diagnose sepsis. I heard that although it may be a relatively low bar measure, it can be an important component of a broader measure set related to sepsis. And then we also heard some criticism about the measure's wording for being vague and potentially gameable that might limit its overall effectiveness. But what I did not hear were any comments about any like dangerous unintended consequences. So potentially a low bar, but not necessarily something that could do harm. Did I miss anything, or are there any other major points that might affect somebody's decision that they want to make sure we raise before we take this to a vote? Okay, hearing none. Julie, Darlene, are you guys comfortable with us voting now?
Yes, I am.
Let's do it.
All right, Elena, over to you.
All right, thank you, Brenna. Okay, everybody, voting is now open for MUC 2025-47 Hospital Sepsis Program Core Elements Score. Do you recommend including this measure in the Hospital Inpatient Quality Reporting Program? Your options are A, recommend, or B, do not recommend. I see some votes coming in. Again, you may need to refresh your screen if it doesn't seem to be popping up automatically for you. But looks like we have a good number of votes coming in. Again, if you voted do not recommend, if you could go ahead and include your rationale as well on that secondary tab. All right, looks like we're waiting for just one more vote.
Yeah, bear with me. I'm trying to find the link again in the chat. For some reason, my computer throws me out after a certain period of time.
No worries, and we can message that link to you again if you need us to.
Yeah, I'm scrolling back. I'm at 1250. If you could just throw it in there real quick again for me.
Yeah, absolutely.
There we go.
All right, that is everybody. So Brenna, I'm going to go ahead and hand it back to you.
Fantastic. All right, let's jump to the next measure. And like I said, at the end of all the sepsis measures, we'll go through the voting results. I think that's probably the most efficient. All right, this is our third and final sepsis measure of the day. And we're getting very close to being back on schedule, although we might be running about 15 minutes behind at this point. So this is the adult community onset sepsis standardized mortality ratio, or SMR measure. It's MUC 2025-045. Let's go to the next slide. All right, so this measure is the annual risk-adjusted standardized mortality ratio, or SMR, of adult inpatients with community onset sepsis who died during their hospitalization or were discharged to hospice. SMR is reported annually and is calculated by dividing the number of observed community onset sepsis deaths by the number of predicted community onset sepsis deaths. It's stewarded by the CDC, just like the last measure. It is considered an outcome measure at the facility level of analysis, and it's being considered for two programs, both for hospital inpatient quality reporting and then the hospital value-based purchasing program. Ron, did you have any specific comments about this measure? Did we lose Ron?
Always got to remember to take yourself off of mute. The only thing I left out, which is the most important thing, which I should have said way back when we were talking about venous thromboembolism, is that we as the medical officers, have the privilege of presenting these measures to the group. But behind the eloquent talking points that we have are some very, very hardworking CMS folks and some very hardworking contractors who make us look very smart. And I would be remiss if I did not call them all out and say thank you for all the hard work that they have done. So now that I've said the most important thing, I will get to the sepsis outcome measure. We're going to go from one end of the Donabedian continuum to the other and talk about an outcome measure. And with the trepidation that I'm not here to relitigate the SEP1 process measure, which I've spent way too much time discussing in all of my 3 years in Quinvig so far, is the request from interested parties on this was that rather than having a process measure, which has pluses and minuses, we create an outcome measure, because I always call it the cranky doctor statement, which is don't look at what I do, look at how my patients do. And so we've been working with CDC to create this outcome measure. It's been a little more delayed than we hoped it would have been for various different reasons that I won't get into, but we are now ready to present this. And so this is a risk adjusted outcome measure that will look at patients who come in with sepsis. And again, without relitigating all the different sepsis definitions, this is done by CDC in conjunction with the Brigham. And they've looked very, very closely at trying to risk adjust for all the different reasons that a person would come in with sepsis. And it has tested very well. And it has, let's see if I can find it. Well, I'm trying to find the exact numbers, but it has a very, very high reliability and feasibility rate. And again, this is really a response to interested party statements, which is ask us about how our patients do. And we haven't quite gotten to how SEP1 and this one, about how this measure will balance out, whether they'll overlap in time or not. There's a lot of complexity there, but this is basically the sepsis outcome measure that we have been promising for a couple of years, and here it is.
For that context, Ron. So this measure, in terms of public comment, there were many comments that were sort of across the board related to all the sepsis measures that apply to this one as well. Again, same sort of general support for this measure as part of a larger collection of sepsis measures in addition to SEP1 specifically. But none of the concerns or other support comments were specific to this one. So everything that I already said related to the other measures applies to this one, and same goes for the closing care gaps. So with that, let's just dive right in, and I will ask our AG members to chime in first. Yeah, go ahead, Mary.
Thank you. I fully support this measure. However, I would recommend that patients who are transferred from an emergency room, urgent care, et cetera, transferred from another healthcare facility to be excluded from the denominator on this, because they could be there for hours and hours and hours, have their antibiotic delayed, and by the time they would reach the acute care hospital that's being measured, too much time has passed. We look at our mortality every single month. We look at it according to how fast we're given the antibiotics. We're trying to get it within 16 minutes. We do find that the mortality is higher if the antibiotic is delayed. So that using information from or not penalizing a hospital if another hospital has not performed rapid antibiotic administration after evaluation would not be, in essence, fair to the hospital.
Can I just jump in real quickly to clarify? I know I'm cutting ahead of other folks. There is this, so CMS feels very strongly that we need to include transfer patients, but there is a separate risk adjustment, or there will be either a separate risk adjustment or stratification for transfer patients. So we do recognize that there is that difference.
Zahid, go ahead.
Yeah, hi, thank you. At the risk of repeating myself, I think this sort of is what I was stating at the first comment that I made in these three measures. And I know Dr. Klein invoked the Donabadian framework, and the Sepsis Alliance mentioned that in their commentary on the public comment side. And there's all this conversation that always comes up, which happened today when the structural measure was being discussed, whether it's too much of a low bar measure, whether it's easy to gamify it, et cetera, et cetera. And so I think that sort of, if you follow the Donabadian framework, the best way to show whether someone is being effective with their process measures or with their structural measures is to show whether the outcome is correlating with the rates that they're achieving, as in the two outcome measures that we've just discussed, the readmission measure and the mortality measure. And so I think the hard part is to correlate these in some fashion, which requires a certain harmonization of the core concepts within the various measures. But I think even if we can be informed that in large scale data sets, perhaps the bundle does not have the effectiveness that some people have sort of raised as a question. And the only way to answer it is to have large scale field data that would either prove that hypothesis or negate it. Otherwise, we'll constantly have these type of conversations. I'm not suggesting at all that this will be an easy endeavor, but I think it's something to think about so that these things really inform us as to what the best way to treat sepsis and to get the best outcomes.
Indeed. Nicholas.
Yeah, I just wanted to say that, I've been working with IPRO for the last 5 years on the Sepsis Improvement Initiative. The state of New York has come up, Dr. Klein mentioned, the
Can't hear you very well.
Yeah, and there's already 10 years of experience in the state of New York, with collecting mortality data on sepsis. And Dr. Klein already mentioned that, and I just wanted to applaud, CMS and CDC to now, going and supporting the collection of mortality data for sepsis, which is so important nationwide.
Thank you. Jan, go ahead.
Thank you. My organization really supports this measure. We just had one clarifying question/comment. The measure is not a 30-day mortality, and it's an in-hospital mortality and a discharge to hospice, which is a new concept in the CMS mortality measures. When SEP, and I see that, if they come from hospice, that's an exclusion, which is appropriate. But oftentimes, and I'll use a personal example with this, my mother-in-law died of COVID. She was COVID positive, but her COVID was a tipping point for other chronic conditions. So when we talk about discharging to hospice, is there any way or methodology to be evaluated if the hospice is now sepsis as a tipping point of other significant chronic disease, or will it just be anybody who goes to hospice? So we were just curious about that as a clarifying point in the specifications of the measure. Thank you.
Yeah. Ron, do you want that, or should I direct it to CDC?
I'll defer to Ray.
Go ahead, Ray.
Thanks, Jan. I can take that question. I think that, unfortunately, when disease processes are very complicated, sometimes it can be a combination of sepsis and other disease processes that can lead to a patient's decompensation. I think it's very difficult to be able to discern, even on a patient-by-patient basis, is it 40% the sepsis, or is it 60% the heart failure that's causing this patient's decline. And so I don't think we can create those kinds of judgments, from these types of outcome measures more broadly. And so we are looking at it as just a broad outcome of death or discharge to hospice at that point of discharge. I will post a link here. We did study because of course many existing measures look at 30-day mortality. We studied this because we understand that this looks at things slightly differently, but we found a very high correlation both on the patient level and on the hospital level between whether you look at the outcome of 30-day mortality as opposed to death during the hospitalization or discharge to hospice. They correlated very well. And so we thought this would be provide an equivalent measure specifically for sepsis. I'll post that link here.
Thanks very much. And Ron, is your hand up because you had something to add?
Yeah, just to add, so I agree 100% with what Ray said. It's incredibly difficult to try to quantify how much of it was a tipping point, how much of it wasn't. I'll just sort of state the obvious, and forgive me for being direct, but and we all know this, right? A very easy way to quantify a mortality measure for a hospital is to transfer that patient to hospice the day before they die. And then all of a sudden that mortality doesn't count against you. And we all know that occurs. There was a recent health affairs review of CMS quality measures, and one of the things that called us out on was that it's just too easy to game those mortality measures. So I think that having discharging somebody to hospice for all intents and purposes to us is mortality. And I think that if we don't have that there, I think the measure loses a lot of value.
All right, really quickly, because I'm seeing lots of different hands up here. Let's go, Jeff, I'm going to hold on you because you're a recommendation group, but David, did you want to say something as the advisory group before I turn to our patients?
Yeah, thanks. I just want to really push on, I agree, including the transfer patients is an important group to look at. I just want to very much urge, and I'd love to see the statistics and whatnot of when you try to determine if you're going to stratify them or risk adjust. I appreciate, Ron, that you're going to do at least one, but that's going to be really key in making this meaningful. I agree that still the receiving hospital for those transfer patients who are really vulnerable, we need to look at them, but we also really truly need to account for that acuity and the part of their care that, if they were sitting at another facility for, 12, 14 hours without fluids and antibiotics and whatnot, it's very different, but there's still, onus on those patients. So I didn't see in the stuff I was able to review the impact on the transfer patients. So I just urge, I'm supportive of the measure overall, but just really, strongly look at that, or at least be able to stratify that, especially if there's, payment penalties that go with this, or even performance-wise, that the public can understand those receiving hospitals, quality of care, what's truly under their control. Thanks.
And I will be. I think we were still discussing the last time I looked, but so I will call out my friend Ray, who can probably speak to that issue better than I can in terms of where we are on that, Ray.
Sorry, Ron, can you regarding, are we still talking about the transfer question?
Yeah, stratification versus risk adjustment, and where I think we were just still talking about the last time we chatted about this.
Yeah, so our folks in the technical expert panel brought up very good arguments, both for and against, right? We don't want to forget about patients, who are being transferred in because who have sepsis, because obviously this is, they deserve, to be counted, just like everyone else. However, folks, so in the risk adjustment model, that we submitted to the MUC list, it includes the patient's transfer status as one of those variables. However, on the other side, we don't, even though it is included in this current risk adjustment model, we don't want to create the perception that a hospital could be penalized for accepting a patient who has sepsis, or even kind of create that potential for that perception. So it is because for a lot of these patients who are going to need transfer for a higher level of care related to their sepsis or septic shock, this may be their last chance to survive. And so I think the right path is, because this population is a little bit different in that they're often much sicker. Sometimes they may have may be kind of more of a mix of patients who have sepsis immediately upon arrival versus a little bit later in the hospitalization, we think it's probably most appropriate to look at these as a stratified population, kind of separate from the from the rest of the folks who stay within the same hospital during their sepsis care.
Great. That would be my tendency without looking at the numbers, and also just even from then, okay, what do you do with the information? How do I improve the care? Seeing a stratified result of where's my opportunity? Is it with the transfer patients or the patients that are native to my institution? Those are different potential strategies, where are my transfer patients going? Are they going directly to the floor? Is there intervention that, needs that versus the ED? So appreciate that. Thanks.
Yeah, thanks for that exchange. That's helpful context, I think. Let me just open the floor to our patient participants to see if folks have any additional. Yeah, go ahead, Rosie.
Well, for me, and I have a story about a young adult who had a community onset sepsis at the same time I had a healthcare acquired sepsis and infection and then sepsis, and he lost his life to the community onset sepsis, and probably because he wasn't diagnosed on site when he entered the hospital, and also because sometimes those community onset sepsis, by the time they get to the hospital door, they already have less of a chance of surviving. But I really am concerned about community onset sepsis and the mortality rate. And so this one is also dear to my heart because I've heard all these stories along the way, and I keep sharing these stories because there's it's different for a community onset sepsis because many times you don't get to the door of the hospital or the ED until it's almost too late. And so this is making sure that, we are looking at sepsis from the point of entry sometimes into the ED. Thank you.
Thank you, Rosie. Any other patient feedback? Okay, hearing none, let's just open the floor to everyone. And Jeff, you were first, so go ahead.
Yeah, I'm trying to understand the validity information a little bit more. And if I understand correctly, it looks like you sort of set out a list of things that you expected this measure to be correlated with, which would provide evidence as to construct validity. But at the end of the day, the measure was really not significantly correlated with those things. And so I would read that as evidence of lack of validity. And so I guess I'm wondering how you got from there to presenting the measure for us.
Thanks, Jeff. Yeah, I think I don't know if is Chana-Ri on board here. I don't know, Chana, if you wanted to speak to this. I think you had an interesting interpretation of the of those results.
Sure. Yeah, I can speak to that. So we reviewed these results with our expert panels, and actually there wasn't a lot of surprise. I think as a lot of people know, the core bundle element SEP1 is quite controversial, and there are several studies showing that when you use robust risk adjustment, that the correlation or the association between bundle compliance and mortality is quite weak. And I think sort of many of us in this space have been arguing for the need for outcome mortality measure to really drive more comprehensive improvements in care across the care continuum. Yes, of course, early recognition and treatment are important, but there are things that are not measured within the sepsis bundles and SEP1 that are probably very important as well, whether it's appropriate and timely source control, choosing the appropriate antibiotics, de-escalating the antibiotics, giving good ICU care, mechanical ventilation care, appropriately preventing other complications and healthcare-associated infections. And so to us and to the panel, it was interesting to see, but nobody was terribly surprised. And again, I think this argues actually for the need for an outcome measure, because if everything was correlated perfectly with SEP1, then that's the only measure we would need. That's the only thing but this speaks to the need beyond that. And I think also to develop more and improve process measures down the line that do better translate into better mortality rates. If I could say one more thing, Ray, that I don't think we included in that, but additional testing, there were some metrics that we looked at that did correlate with better outcomes on this measure, and that included the CMS overall hospital quality star ratings. So hospitals that did better in terms of overall quality were correlated with better performance on this measure. And there was also a weak but significant correlation with the Medicare pneumonia measure. And the reason why we looked at that in terms of Medicare mortality, and the reason we looked at that, of course, is because pneumonia is the most common cause of sepsis.
Okay, yeah, thanks for that. I guess my thought would be that if you think that there is a problem with the SEP1 bundle, then your validation process should probably not include the SEP1 bundle. But here it looks like there's a little bit of, or has the appearance of a little bit of post hoc reasoning going on here, right? Where you specified a validation test and then got low correlation, and then you're like, but we don't like the SEP1 bundle. But I don't think that's helpful in evaluating the construct validity of something like this.
You, Jeff. I just want to be quick. Maybe, Tanya, do you mind responding in the chat? I just want to make sure that we're staying as close to time as we can. But there's been a response from Sandy in the chat that says she's supportive of this measure, but would like to better be able to explore what contributes to poor outcomes, given, Tanya, your feedback on what can change to improve outcomes if SEP1 is predictive of survival before we move this into HBVP. And they wanted to know if you guys had looked at correlation and proposal to drop star rating scores when safety of care measure is in the bottom 25%. So if you could respond to that in the chat, and then I'll turn to Caitlin for her comment.
I think I'll just say I think this is a really important area for ongoing research. I don't have all the answers on that right now about what is the new best process metric or series of process metrics, but I think at least from the team that developed it, like we are very hopeful that this will help to really move that field in the direction of thinking beyond, again, just the initial bundles of care, but thinking more broadly. We hope that this will catalyze more work around innovations in diagnosis and treatment. And I won't speak too much. I'm not proposing necessarily to drop the star rating, but again, just mentioning that was one thing that we did look at that correlated with this.
Yeah, I'm hoping that like some of these more technical kind of questions that we can hash out in the chat, and then I'll summarize it at the end. And Caitlin, go ahead.
Thanks. So wait, I really like the idea of the mortality measure for sepsis, and I think that, and I appreciate the work that CDC and all the HSN folks have done in putting this together. I want to make sure that I'm on record and that CMS sees in the chat that there's a lot of desire to do this the right way. And we know that, the fire resources and the other kind of interoperability and the necessity to have a robust risk adjustment. We know that currently the measure is in testing to make sure that the electronic pipeline is delivering what's expected with the pilot sites. That the reports are working, that everything's working. And we know that likely the idea for the timeline is probably not for proposal to start this measure, in 2027. We're probably looking closer to 2029, 2030. And that's an aggressive, but I think reasonable timeline. I want to make sure that CMS has that same idea that, I know that there's pressure to get rid of the SEP1 bundle, which HA is part of the problem, the pressure to get rid of that bundle. But knowing that there are alternatives, both the core elements measure that we just discussed, as well as this, that, I think do have some promise beyond what SEP1 offers. Let's not rush this. We've had experience with other hybrid type measures, particularly the hybrid hospital-wide mortality and readmissions measures, where we did have some hiccups with the implementation of those and the clinical data elements that are necessary to report those. So let's get this right. Let's not rush the implementation of it. And, CBE endorsement is a great way of getting through that. But obviously, this will take time to get it right because it is such a complex issue. So let's learn from those experiences, as well as some of the other measures that have recently been put into place, like the hypoglycemia measure, the hospital onset bacteremia measure, et cetera. So let's keep, we're looking beyond just the 2026, 2027, 2028 regulatory calendar with, again, I've been saying forward looking quite a bit, but I think that's going to be really important for the accurate implementation of this measure.
And Caitlin, this is Michelle. I will actually confirm that we are looking at a longer time frame. And CDC is really being very, very careful in collecting and testing this and making sure that all of the pieces work.
That's great. Thank you so much, Michelle.
Thanks for that clarification, Michelle. I think this is a good time for me to maybe do some summarizing, because a lot's been happening both aloud and via the chat. So the first thing that I want is just to clarify. We've seen some questions about whether or not this measure is an ECQM. This measure is a hybrid measure. Some data elements are electronic, some are not. And there's a whole exchange in the thread if somebody wants to look at that for more details. But what we are hearing about this measure is that it represents something that is sort of I guess maybe progressive in the sense that it is an advanced measure that is looking at an outcome which we know to be a challenging thing to capture. It's looking at mortality, at hospital-based mortality, and discharge to hospice, which is, again, a different way of thinking about mortality, at least in terms of how it's typically captured in CMS programs. And then we've heard a lot of questions about the actual specifications and the testing and making sure that this performs exactly as intended. We heard feedback from Caitlin Galluli just now that this is crucial, but maybe something that needs a longer time horizon to be ready for the program. And we heard from Michelle Schreiber at CMS that is in alignment with their own plans. And again, we know that this is an important topic. We have heard across the board that sepsis care is of crucial importance. And so I think that's what we're balancing here. And Zahid, I see your hand went up.
Yeah, Brenna, I just want to make sure that I have the terminology right in my head. So I have usually associated the hybrid measures within the CMS mortality measures or readmission measures, where the risk adjustment of the claims measure is done using the core clinical data elements, or the so-called CCDEs. But I think there is not that hybrid definition here. I just want to be sure, right? Because this is an SMR and the data sort of are coming from the EHR, and some of them might also be coded data, and it's sort of not in that sense a hybrid the way CMS has up until now described those hybrid claims risk adjusted measures.
I would ask that folks respond to that one in the chat. Again, I just want to be sensitive to our time here. So if either the measure developer or CMS could just comment on the nature of the hybrid measure, just for Zahid's clarity. But others, after I've summarized this, are there other points that folks feel like we didn't get to or that I didn't mention? Yeah, I think, well, sorry, Jen, we were trying to keep the AG feedback to the chat at this point. Is there?
Oh, sorry.
Sure, yeah. Yeah, Christina, go ahead.
Yeah, thanks, Brenna. Are you able to hear me?
Yes, yeah.
Okay, great. So just because there have been so many questions kind of going back and forth about electronic and hybrid, wanting to provide just a little bit of clarity. So this data, the electronic health data, will be submitted to NHSN, as was mentioned in the chat, from FHIR Resources. This is a hands-free automated way to submit patient-level data. This is new. This is different than how current measures are submitted to NHSN, so wanting to provide that clarity. And then this measure will be augmented as is mentioned, by claims data that is also electronic data submitted electronically to NHSN that we will use to apply some exclusions and some of the risk adjustment. So just wanted to give a bit of that background and clarity.
Thank you for that, Christina. I think at this point, since we've sort of heard, I think most of the commentary and support and the concerns about the measure, and we're starting to kind of circle back around some questions, it's probably time for us to take this one to a vote. So I just want to confirm, Julie and Darlene, you're comfortable with that?
I am, yes.
I am.
All right, let's do it, Elena.
All right. Again, we'll be voting on this one for 2 different programs, so you'll see this first vote pop up for you in just a moment. All right, voting is now open for MUC 2025-45 Adult Community Onset Sepsis Standardized Mortality Ratio. Do you recommend including this measure in the hospital inpatient quality reporting program? You can A, recommend, or B, do not recommend. If you are choosing to not recommend, again, just another reminder to put your rationale in the rationale tab, which you can find at the top of your screen with the little pin icon. I believe we are expecting to see 21 votes, so I see our votes coming through here. Just waiting to see our last vote come through. All right, we have all of our votes here for this question. So in just a moment, we'll go ahead and move on to the next question or the next program. Just a moment. All right, now on your screen, you should now see the voting for MUC 2025-45 for the hospital value-based purchasing program. Again, you can recommend or not recommend for your options here. Looks like we're expecting to see 21 votes again. Just waiting to get all those coming through. All right, looks like we have everybody's votes in, so I will pass it back to you, Brenna.
Okay, fantastic. We are now going to take a 5-minute break. So if everybody could just get some water, stretch your legs, come back at 2:45 sharp, very pleased, so that we can get back on schedule. At that time, hopefully we'll have these votes counted up and we can review them really quickly before we move on to the last few measures. If the votes aren't counted up in time, then we'll just cover them at the end. All right, so see everybody back here at 2:45.
Okay, thank you all so much. And thank you very much for taking a quick break. I know that we had promised 15. We only have 5. As a reminder, take care of yourselves as needed. If you have to step away, please just message us to host and panelists, letting us know. Please take care of yourselves as we continue on in this conversation. So I will move on to the next slide. We are now going to be talking about this dialysis facility discussion of patient life goals, and this is MUC 2511. Next slide, please. So this is the dialysis facility discussion of patient life goals is a patient-reported outcome performance measure. The DPALS Pro-PM is a patient-specific measure that can be used to generate a T-score that is indicative of patient satisfaction with their care team about life goal discussions during treatment planning and ongoing treatment process. The DPALS Pro-PM uses the patient-specific scores, generate a performance-based facility level score. The performance-based measure is the percentage of adult chronic dialysis patients at the given ESRD facility that have a T-score of greater than 40. This is at the facility level of analysis, and the measure was reviewed but not endorsed in the spring 2023 based on concerns that the evidence provided did not show a clear patient desire for this type of measurement, and there was a lack of alignment between patient preferred outcomes. We move on to the next slide. I believe we have. And so it is being proposed for the end-stage renal disease quality incentive program. I'm going to turn it over to Dr. Stephanie Clark to provide the CMS rationale.
Thanks so much, Kate. And I also just want to note that I am joined this afternoon by Golden Horton, who's the program lead. And it's nice to talk to you all again. Thanks for hanging in there as we near the end of the day. We are considering adding the dialysis facility discussion of patient goals, life goals, or the DPALS measure, to the end-stage renal disease quality incentive program as a new clinical quality measure. This measure is back for consideration after exploring facility-level testing as recommended. This patient-reported outcome measure reports patients' satisfaction with how well their care team discussed life goals as part of treatment planning using the Patient Life Goals Survey instruments, and allows facility-level comparison of patient satisfaction around discussion of life goals by generation of a T-score. This measure will fill a gap in the patient and family engagement domain. I want to highlight that this measure encourages the conversation around life goals and allows patients to report if these conversations are happening and if they are satisfied with that aspect of their care. Life goals can take a multitude of forms, from feeling better after their dialysis treatment to pursuing a different treatment modality, such as kidney transplants or a home modality. Although the survey instrument does ask patients to list some of their most important life goals, simply in order to frame the topic, there is no rating of individual life goals or measurement if life goals have been achieved. The survey instrument is short, taking only 2 to 3 minutes to complete, and was developed and refined with significant patient input. We are exploring alternative vehicles to support direct survey administration to patients. And just so that you all have access to it, my colleague Claudia did put the survey instrument in the chat so that you can see the questions. And so I really look forward to your feedback in the discussion.
Thank you very much, Dr. Clark. I appreciate it. And as Dr. Clark noted, this measure was previously submitted and did not during the 2023 cycle and received a consensus not reached. I'm then going to go into some of the public comments that we received, as well as the gaps of care. After that, we're going to open it up to our AG members for questions and considerations for the recommendation group meeting, or the recommendation group members to consider. We have had a lot of rich discussion, as well as a lot of rich text in the chats today. I would like to encourage people to leverage the chat, especially if you have specific questions that the measure developer can answer. We are then going to move to our patient participants and really encourage give the platform for them to share. One of the things that I think we do really well on this is to give space for our patient participants. And for our patient participants, if you would like me to read aloud some of your comments, I am happy to do that. I love reading them. So don't feel pressure to raise your hand, but if you do feel empowered to put something in the chat, I will gladly lift it up. We will then move to our recommendation group discussion and voting. So with that, I'm going to say that we received 29 written public comments and 1 spoken public comment during the listening session. Some of the support comments, a patient organization supported the measure, said historically, dialysis quality is measured through a clinical lens, lab testing and technical adequacy. This measure could address the profound communication gap between medical goals of a facility and life goals of patients. Several commenters agree that this is a high-risk population that could benefit from discussion. And 1 commenter supports the measure, but thinks it could be strengthened if life goal discussions explicitly include transplant evaluation and pursuit as a core option. We did receive, and I want to take a moment here and acknowledge, we received a lot of first-person experience on this measure and the challenges of being on dialysis. I think that there were some really amazing and articulate comments we got about how hard it is to be in dialysis and the reality of being on dialysis, the challenges of a day-to-day experience, and how some days are incredibly challenging. And the goal is to make it through to the next day. So, and how people do not understand how challenging it is to be on dialysis. So I want to take a moment and really thank people for sharing their experience. Many of the patients and patient advocates had concerns around the meaningfulness of this survey. They were concerned that it was not conducive to improving quality of life and adds to the survey burden of renal patients. There were questions about whether or not it should focus on the short term, really thinking about what is needed day to day. Some people had concerns around what the questions themselves were asking. They wanted to see more symptom burden questions. And then there were other concerns of the actionability of this survey. So if we're asking people to share their goals and then there's no direct intervention required, it can be disheartening to some. I will say, we had a couple of people write some suggestions on what would be meaningful to ask patients on dialysis. And I wanted to read some of them here because they were woven through many of the public comments, which is being able to pay bills, not being a burden to their family, owning a reliable car, not relying on public transit, finding a partner or spouse, having safe housing, receiving a transplant, and alleviating depression. So we had a lot of these different people sharing what they would consider to be life goals and would be meaningful to them. We also received numerous comments on the survey burden the people on dialysis receive. There was some concern that there is overlap between this and the in-center hemodialysis caps. Others said that because of the survey burden, that it is not likely that CMS will receive a meaningful number of responses. Several commenters wanted the measure to receive endorsement, and there was a concern about both the high burden to report as well as the workforce needed. And related to a comment earlier, people were concerned that because there was no intervention attached to this, that it could become a check the box measure. Next slide. So some closing gaps of care considerations. Older adults are more likely to have multiple comorbidities and frailty, so dialysis care should be tailored to these needs. Rural patients have fewer dialysis centers, longer travel distances, and less frequent access to nephrologists. Treatment plans for those who are uninsured may differ due to increased cost of care. And patients with limited English proficiency reported poor communication with the dialysis care team. If we move back 2 slides, I'm now going to open it up to members of our advisory group for things that they would like the recommendation group to consider or questions answered. And I'm actually going to start with our patient participants, Sarah and Kristen. So Sarah, if you wouldn't mind opening us up. Oh, and Sarah, I think you're having some issue with the mute.
Sorry. I kind of have a personal story. I was on dialysis back in 2017, and the reason they put me on dialysis is because I had a transplant in the queue, but they didn't want to do a double surgery, because I had complications with my kidney because of my rare disease, and they weren't doing me any good, but they weren't shutting off. They were just dumping. So they wanted to take the kidneys out and then put me on dialysis and then give me the transplant. When I was on dialysis, I had fluid restriction, which fine, it was okay, but I take 40 pills a day and the restriction they were giving me wasn't working. And for the dry weight, they were telling me they were just going to follow the guidelines. But having a rare disease and needing the water to take all those pills, I kept gaining fluid, and the dialysis people wouldn't really listen to me when I said they needed to take more off, because they wanted to continue to follow the guidelines of how much to take off when every person is different. So I basically had so much fluid. I went to my surgeon for the first appointment before my transplant. I told him I was having trouble breathing and sleeping, and he did a chest X-ray, but after he didn't think he really saw anything, he just sloughed it off as weight gain from dialysis. So then the second time I saw him, I bring my partner with, and he told him I was sleeping at a 90-degree angle and I had so much fluid that my skin was like rubber. And then he finally took me seriously and did an EKG and found out I was in heart failure because I had too much fluid buildup. So my day-to-day in dialysis was filled with 4 hours, 3 times a day, or 3 times a week. And I was always exhausted and I always had a migraine. And I just really didn't want to do a whole lot. And then add the complications of heart failure. And then my transplant got pushed back 3 months because they were afraid to give it to me because my mom scared the crap out of them, basically saying if you ruined her chance of getting a transplant, that she'd sue them. So that was my mom sticking up for me when I couldn't really speak. But my dialysis story just, I don't know, I felt like the doctors weren't listening to me and they were just following the guidelines, and I didn't really have energy to do anything. So I guess I'm saying that I don't know if dialysis patients would have the energy or the strength to want to fill out a survey.
Sarah, thank you very much for sharing. And I'm very sorry that you had to experience it. It sounds like it was an incredibly challenging time. What I'm hearing throughout your story is that you did not feel listened to. You did not feel that people were taking your symptom burden management into consideration. And that because in addition to that, as a result of being on dialysis, your energy level was so low that you wonder whether or not people would have the energy to report this measure as it stands. Is that correct?
Yeah, and I mean, mine was special circumstances because I had a rare disease. So in order for them to take me seriously, I had to get my partner involved, and I also had to reach out to my rare disease doctor to tell them it's okay to not follow the guidelines for dry weight and to take more off because I don't fit the normal guidelines. So eventually everything got figured out, but it included a $5 5-day hospital stay, and then I had to be on oxygen for months just to get my breathing and oxygen and my heart back to normal before I could get the transplant.
Thank you, Sarah. I really appreciate you taking the time to share that.
Yeah.
I'm going to move
Thank
on.
you for listening.
Yeah. Kristen.
I also wanted to speak from the patient standpoint of the survey fatigue that does happen within the rare disease space. Because we're being so closely monitored, because we are a smaller subset of individuals who are dealing with those situations, we get surveys for everything. So my question would be, how exactly is this survey going to be administered? Because in my experience, the people who fill out surveys are the ones who are very, very angry about a situation that has occurred, or are very, very happy about a situation that has occurred. And so you kind of miss this huge gap in the center of care for people who are just floating along and kind of wishy-washy, like they're just surviving, right? And so I worry that you're going to end up with, even if you have survey results with enough people are going to be very fatigued and exhausted just even to take the surveys. So I didn't know if, I know in my experience with bleeding disorders, a lot of times they are either through email from the hospital system or they are through phone call. And so you're so tired that a lot of times you just don't even want to think about doing that. So you don't fill out those surveys. So I see I know the potential good that can happen from surveys to help with quality of life in the long term, but I just would worry about the mechanism of actually how the surveys are being done, and then if you're actually going to get accurate data.
Dr. Clark, I see that you went on cameras. Would you like to answer that question?
I sure can. And again, thank you for all the perspectives. And I just want to say, I agree, the survey burden and the survey fatigue is real. And I see that in my patients, and I have seen it in our dialysis unit. So I just want to acknowledge that and all the comments that have been coming in. I think the implementation questions, if this were to be proposed for ESRD QIP, are still sort of up in the air and really would depend on sort of what happens down the line with the program. I will say that we are exploring options where the facility would not have to be the one to send the survey to the patient. So we are exploring those options, that it would be more direct. But I think that, the question about if patients are actually going to be ready and willing to answer the survey when they get it is still up in the air. Certainly we have seen with the TEP and we have seen with some of our focus groups, that the engaged patients we've talked to have thought that this is very worthwhile and it is something that they would take those 2 to 3 minutes to complete. And I also will just take the time to respond to Jan's comment that, I think CAPS is an option and we have thought about that. It's also it's also resources, and we know that the CAPS response rate is not very high, and so we're very sensitive to that as well and trying to think outside the box. And the final thing I just wanted to say in response to some other things in the chat is that, I do in my personal practice think that these conversations make a difference. And so, by having these conversations with someone, if a patient tells me, wow, I started dialysis and now I cannot go to dance class, and we talk about that and they really want to go because they're so exhausted on the days that, that happens, we switched the dialysis day and we made it happen so that it was a day that they were not so exhausted. It wasn't the day that they had dialysis. And so I do think that there are measurable and actionable things that can happen from these conversations, and they don't have to be, huge, but they might be huge to the patient.
Thank you, Dr. Clark. David?
So in my personal practice, in my wife ICU doc practice, these advanced care planning discussions are some of the most important discussions that you can have. And, that conversation, which should be happening well in advance of patients declining, are so important and don't happen as timely as they should right now. I totally agree with all of that. My biggest concern with this one, again, that survey fatigue is real and increasing rapidly right now. And if you look into the supplementary material that was put with this, even during the development of this, about 3/4 of the dialysis centers that they trialed this in had response rates less than 20%. So even in a highly motivated research setting, the response rates were really low for this survey. And so I think that points to the degree of fatigue. And then my favorite subject, it seems like the last couple of days, the endorsement committee, actually, this one did go through the endorsement and was rejected. So that is another piece of evidence showing that maybe this one is not quite ready for prime time. And so I appreciate this one going through endorsement ahead of time here and having the results of that to weigh into this.
Thank you, David. Rosie?
Well, I've only been on my dialysis once in my life. It was after a surgery where I was given too much blood during the surgery, and I ended up on dialysis for several weeks. But I think that the patient's life goals are really important. I mean, people wrote me off. I mean, many people wrote me off. My cardiologist will tell you that when he reached out to my orthopedic surgery and my infectious disease doctor, they told him, just keep her comfortable because she's going to die anyway. And yet he saw something in me to make sure that that my AFib was treated, even though I had an open wound, and how, worked on ways to treat it. And So he saw something in me, and he saw that I had life goals, and I was already doing patient advocacy work, and I was already, wanting to make a difference in the world, because I knew I couldn't change my MRSA world, but I could definitely change that MRSA world for somebody else. And so I think those life goals are really important, and talking about them are important. And when I work with dialysis facilities around infection and hand hygiene and those kind of things with patients, I often talk about, what matters to them. What is important to them? It's, what really matters to them. And I hear some of the things that you, Kate, heard in the public comments, that they really want to make, that they really want to change how they feel and how they react to things.
Rosie, thank you. And I want to acknowledge the emotional burden that you've been carrying today of sharing a lot of your experiences, not just to share, but to help improve care. But I do want to acknowledge that, because this is not an easy thing that we ask you to do. So very appreciative. I do want to open it up to the recommendation group. And as always, feel free to mention things in the chat, but I see our co-chair Julie.
My comment is a question to actually just kick back to our patient members, so absolutely hearing the importance of having end-of-life conversations and being heard, and making sure that your desires are kept at the center of all of this. Do you all want a survey element for this? Do you all, keeping in mind, like, we're going to discuss like the advanced care planning in our next session and everything, is this the format that you want for that, or not? Because for me, this one ultimately lands on what supports the patient.
And so I see Darlene and Rosie, and then we have Sherry wrote something in the chat, another one of our patient participants. So I'll read hers after Darlene and Rosie.
Thank you, Julie, for that. And I've been sitting here thinking about this the entire time, and I thought about it when I was reviewing the measures too. Someone wrote at the beginning in the chat, and I couldn't get back to it quickly enough, that this information is covered and named like 5 or 6 surveys that already exist that patients are already being asked to fill out. So I wondered if they could, apparently they have some experience, which I personally don't. I wondered if they could address that maybe verbally to the entire group. If this information already exists, if there's already 4, 5, 6, 7 surveys that every dialysis patient is being asked to fill out, then no, we don't need to add another one. We just need to look at what's there and make sure that that all the questions maybe don't need to be reviewed, or that the data from those surveys is being shared with the other players as they need to be.
Thank you, Darlene. And if you were the original commenter on that, please let me know. Rosie.
Well, for me, I have to tell you that there was an end-of-life situation where I ended up in a coma for 6 days. And I had never done those end-of-life paperwork because I didn't think they were needed in my life yet, even though they probably were. But I was not a survey taker. I still am not a strong survey taker. But when it comes to end-of-life things, it's real important to be having those discussions. And life goals end up being end-of-life situations many times for many of us patients.
So Rosie, kind of making the connection of the importance of that quality of life goals can sometimes merge into end-of-life conversations and the importance of those. Is that Am I accurately reflecting your?
Yes, yes, and that, you know, basically my husband knew my end of life requirements, but yet wasn't heard by the institution. And, you know, basically, he didn't get much information from that institution, you know, so it became a hassle for him, and it very much led him to, you know, led him and I to making sure we had all those documentations done, because those kind of things are important.
Thank you. I appreciate it. And I think that as we think about the asking of the life goals that this measure is doing, you know, the meaningfulness of it is very important. Just wanted to note that Sherry Michael noted that the need for education and earlier conversations when people are engaging in dialysis because of some of the challenges and burdens that people noted. You know, she said that her nearest dialysis facility is 25 miles away. So that will impact what your goals are. And so I think that those are considerations that people should mention. I will say there is a pretty active discussion happening in the chat around the questions on whether or not they're incorporated in other things. I also did want to highlight Dr. Clark's comment that the measure is not only about end-of-life goals, but also about life goals in general. So just recentering that. But Dr. Clark, I didn't know if you wanted to comment at all about some of the questions that we've had in the chat around whether or not these questions are being covered in other surveys.
Sure. So these specific questions are not being covered in other surveys, and there might be requirements for other parts of regulation, like the conditions of participation that require some surveys, but it's specifically in the ESRD QIP. The only survey measure is the ICH caps. And so that's the only thing that's part of that. So I did just want to put that out there.
Thank you, Dr. Clark. I appreciate it. Nick.
Yeah, hi, I'm Rosie. Thanks for sharing. You know, just to clarify also, this is for dialysis centers, right? Not hospitals. It says at the bottom, dialysis facility, correct? Because like, for example, Rosie's example, she was acutely dialyzed in a hospital, not in a chronic dialysis center, so it may not apply. The other thing is, when I reviewed the references here and looked into PALS, the validity that they tested validity of PALS, not the use of it in these patients, connecting it to improved outcomes. I think that was a question in the chat. I did not see literature that shows application of this survey leads to improved outcomes. We know that such discussions will reduce decisional conflict. That's what shared decision making does. And while that's important, it should be shown specifically in this population around this question, again, before we endorse a performance measure that will require resources, especially with the burden of giving patients another survey.
Thanks, Dick. I appreciate that. So recentering the comment on, is this improving patient outcomes? And is there a connection between the administration of this survey and improved patient outcomes? Jeffrey, before I get to you, Darlene, you did raise your hand. Is it in response to Nick's comment? Yes. So I'm going to go to Darlene and then I'll go to Jeffrey.
Actually, partly Nick's comment. I love that because, you know, we do need to look at, and if anybody doesn't know what PALS is, it's, you know, your end of, I think, Jeffrey, you're referring to pediatric advanced life support or end of life measures and what they want. Is that what you're referring to in PALS? That's where my brain goes when you say PALS.
It's a DPALS, which is the dialysis one.
Oh, okay. Sorry. Thank you. Yeah. I went to pediatric, but hey, it still kind of works. But also I wanted to bring reference to Kristen's comment about it really works better from a hemophilia bleeding disorder standpoint. And my grandchildren are older now, so Danny's 15. So there's been a lot of different doctors that he's been through, and having their current physician that sits down and talks to the kids about their life goals with their bleeding disorder and how active they want to be and what it's going to mean with clotting factor to be able to be that active and to be able to achieve those goals so that they can make informed decisions, or even with the medication change. So if you equate that to in dialysis, not just kids, anybody, from the beginning, I have felt like this should be more the responsibility of the facility. And as a facility, are you asking these questions? Are you having these conversations? And what are your planned outcomes? So I feel like it needs to be on the facility's shoulders.
Thank you, Darlene. Jeffrey.
So a couple of comments. First of all, I think Nick's comments were right on target. There is clearly a survey burden. We know that only about 25 to 30% of dialysis patients answer the ICH CAPS survey, which is a quality of life survey. That's the whole point of that survey, is satisfaction with the care they're receiving in the dialysis center and from the nephrologist. Those surveys are already not worth much because of the low response rate. Secondly, there is no data to support that doing this survey will impact patient outcomes in any way. So it's an additional burden both for the patients and the facilities with no clear outcome to it. So to me, this survey just doesn't make any sense. And it risks taking resources away that would be better spent actually taking care of patients.
Thank you, Jeffrey. And I did see that our developer came online. Claudia,
Yes.
after you speak, I'm probably going to summarize the discussion and move to a vote, but if there was something that you would wanted to address.
Yeah, just a couple, because we're very sensitive to patient burden. We have heard this repeatedly since we started this work in 2017. We interviewed patients asking about what patient-reported outcome measures they felt would be important in terms of a representation of patient-centered dialysis facility care delivery. One of the things we heard repeatedly is the length of the current surveys, one of which is required to be publicly supported. That's the ICH CAPS. That's about a 60-question survey, and it's only administered to patients that are on in-center hemodialysis. So it does not include surveying patients that are on any home dialysis therapy. So it doesn't even target the entire chronic dialysis population. So survey length was a real concern, and that we heard similar concerns around quality of life surveys that are required to be administered annually, but those results are not shared publicly or reported. So patients were very excited that we were able to develop an 8-question survey that takes 2 to 3 minutes to complete. We heard directly from patients during focus groups in 2023 and 24 that one of the strengths and things they appreciated about the DPALs is that it took 2 to 3 minutes to complete, and that they felt that the results of a future facility performance measure would provide important information to patients about the extent to which dialysis facilities are actively discussing life goals with patients and figuring out how to incorporate patients' life goals into modifications to treatment planning. There's no expectation that life goals are achieved. I think patients have understood that throughout the focus group and TEP discussions we've had, but just starting the conversation. And we have heard from many patients that those conversations are not happening, or are not happening in a sincere way, and that they should happen not just once, but annually or even more frequently. So we are definitely aware of patient burden, but the fact that we targeted having a very short survey directly addresses that. As a patient-reported outcome, I want to address the concern that this doesn't improve clinical outcomes.
as a patient-reported outcome, our understanding is that PROs do not have to be used to improve clinical outcomes. I think that would be potentially challenging to find a direct relationship. So the goal here is really for patients to report on their experience of care through their lens as they experience that care. That could that could in some way improve indirectly outcomes, but the intention isn't for this measure to improve clinical outcomes, whether dialysis adequacy or modality. It's to provide information to patients about how their care team working together with them can improve the experience of care and incorporate patients' personal goals into treatment plans so that patients are able to pursue things outside of their dialysis regimen. So I think those are sort of the important points to bear in mind. I know there were several comments that patients don't want this.
Claudia, I really appreciate it. I do know if there are other things that if you wouldn't mind putting in the chat, we are running a little behind, but I really appreciate you taking the time.
I want to counter some misperceptions that patients don't want this, and that is not necessarily true. We've heard from many patients that they appreciate this measure, and I will stop there.
Thank you so much
for the opportunity.
Thank you. And so we are, to kind of summarize our discussion, there's a lot of talk around meaningfulness to patients. We've heard from both sides whether or not these questions are meaningful. We've had a lot of patient experiences being shared. There are significant concerns around survey burden, but also the importance of the questions. People do appreciate the questions being asked, and they are important for people to consider. Being asked about your goals while on dialysis resonated with a lot of patient participants. There are questions about response rates and survey fatigue. So there's a lot of conversation happening. Darlene and Julie, do you think is there anything that you wanted to add on, or are we good to move to a vote?
No, I think we're good.
I think we're good.
Okay, great. So I'll turn it over to you, Elena.
Thank you so much, Kate. All right, everybody. In just one moment, you will see that question pop up. So voting is now open for MUC 2025-11, Dialysis Facility Discussion of Patient Life Goals. Question here is, do you recommend including this measure in the end-stage renal disease quality incentive program? Again, your options are A, recommend, or B, do not recommend. All right, I see we have a good number of votes coming in. We might not have everybody on here, so I will keep an eye on that number. All right, looks like we actually have all 21 votes that we need, so I will hand it back to you, Kate. Thank you, everybody.
So much, Elena. Thank you. Appreciate it. Okay, next slide. So now we're going to be talking about MUC 2564, the facility level percentage of chronic hypophosphatemia in dialysis patients. Next slide, please. So this is an intermediate outcome specified at the facility level of analysis and was endorsed by the CMS CBE in 2024. It is the percentage of adult dialysis patients with a 6-month rolling average phosphorus value greater than or equal to 6.5 milligrams per DL. It is being proposed for the end-stage renal disease quality incentive program. I'm going to turn it over to Dr. Clark to discuss CMS's rationale.
Thank you so much, and thank you all for that rich discussion. I am looking forward to yet another rich discussion. We are considering adding the facility level percentage of chronic hyperphosphatemia in dialysis patients measure to the ESRD-QIP as a new clinical quality measure. Chronic hyperphosphatemia is a common issue in patients with end-stage kidney disease, and management of hyperphosphatemia is a routine part of care for patients on dialysis. The purpose of this measure is to focus quality efforts on those patients with significant chronic elevations in phosphorus who would benefit from additional intervention, as improvement in chronic hyperphosphatemia can improve cardiovascular complications, fracture, hospitalizations, and mortality. If proposed for the ESRD-QIP, the intent would be to replace the current hypercalcemia reporting measure with this new measure while maintaining compliance with statutory requirements to include a bone and mineral metabolism measure in the ESRD QUIP measure set. And I will turn it back to you. Kate, I think you're on mute.
I was going to do it once, and this is apparently my one time. Thank you, Dr. Clark. I appreciate it. So we received 10 written public comments. We did not receive any spoken public comments. Overall, the public comments were supportive of this measure. Several commenters expressed strong support, noting the broad and skilled perspective of the measure's TEP. Poor clinical outcomes associated with hyperphosphatemia include increased mortality, hospitalization, and vascular calcification, cardiovascular events, and bone fracture. Yet treatment has significantly declined, so they believe that this measure can help address that. Many commenters said that hyperphosphatemia is a common complication and that appropriate phosphorus levels can be an indicator of healthy outcomes for dialysis patients. Actually, we had a commenter who preemptively responded to some anticipated concerns around the measure, which is that some may be concerned that any measure dealing with hyperphosphatemia is dependent on patient adherence, patient choices, timing with meals, tolerability, and dietary behavior, and that these factors are often out of the control of the dialysis facility. They also recognize that these strict targets may not be appropriate for all patients. That being said, they did say that the risk of not properly managing hyperphosphatemia, in their opinion, which outweighs these concerns. And a commenter also supported the measure and agrees that among mineral metabolism measures, this approach is preferable to alternatives such as hypercalcemia. They noted that setting the threshold at a higher phosphorus level of greater than or equal to 6.5 helps mitigate some concerns related to overtreatment and aligns better with the clinical realities in the dialysis population. For concern themes, one commenter noted that it will be challenging to hold the facility accountable for this when some of the impacts are affected by patient behavior. Another commenter had a concern about the unintended consequences. They noted that the proposed measure relies on observational data and expert opinion with regards to serum phosphorus level thresholds, rather than robust clinical trial evidence. They were concerned that there are no published trials that have definitively shown that pharmacological lowering of serum phosphate to below the proposed threshold leads to improved clinical outcomes in patients. Next slide. We can go to the closing gaps in care slide. Okay, it looks like my screen might be frozen. I don't know if it's a me problem, but let me get to the gaps in consideration. Older adults are more likely to have multiple comorbidities and frailty. Rural patients have fewer dialysis centers. Treatment for those who are uninsured may differ due to increased cost of care, and patients with limited English proficiency reported poor communication. So with that, I'm going to open it up to our advisory group members. See, I have a comment in the chat from David Basil, appreciating that this measure is endorsed. Are there any other comments from the advisory group that you think the recommendation group should consider? Jan Orton saying that her organization supports it. Thank you. So Virginia, you are welcome to come off mute if you would like to share your comment. I note that you are a nephrologist, so I think it might be helpful if you're able to verbally say it.
Hi, Kate. Thank you for giving me a chance to speak. I was a voting member for QUIP in 23 when we did this. So I do understand that there needs to be a measure for calcium, phosphorus, bone mineral management within QUIP. I think the previous conversations prior to why calcium was picked was because of how hard it is to really manage phosphorus in dialysis, because it is so patient-centered, diet-centered, compliance with medications. 2025, now binders fall under the bundle for payment, and they must be dispensed from the dialysis clinic. So you see some of the more expensive binders that do a better job not being prescribed because the cost is now attributed to the dialysis clinic. So again, I think that this has been a rough year for phosphorus because patients weren't getting their binders. Everything wasn't understood in 2025. Trying to get the pharmacy set up, the measure didn't get approved till like last November, December 2024, and then in January everybody was supposed to pick up and have these binders available and all the processes in place, and it really didn't happen well. 3 to 4 months in, people were still without binders. I just have a problem with the phosphorus as being the measure. I understand why there needs to be a measure for calcium phosphorus bone management, but I think this is why we fell to calcium historically, because it is something we have more easy control of in the dialysis world, by changing, calcium baths, by changing certain binders. Phosphorus is just really hard. Dialysis does not remove phosphorus.
Thank you, Virginia. I really appreciate that. And thank you also for highlighting that this measure addresses a statutorily required area. Mineral and bone metabolism are a statutorily required area of quality measurement in the ESRD QIP. So thank you for bringing that up, as well as the considerations that you had. Are there any other AG? I'm going to open it up to our patient participants.
Can I just ask real quick, Dr. Irwin Scott, out of that conversation, are you saying that because of these limitations, you would favor including a phosphorus measure, or are you saying that because of those limitations, it might not be best suited?
I would favor keeping the calcium measure as is right now.
Okay.
Thank you. And thank you for that clarifying question. Any considerations or comments from our patient participants? And also, if it's similar to the previous measure, if you have kind of similar comments, feel free to put those in.
I have a clarifying question. So this would substitute for the calcium measure, like you'd get rid of the calcium measure, and that's what's being proposed?
I'm going to turn it over to Dr. Clark to address that.
Absolutely. Thanks for the question, Terry. If this would be proposed in the ESRD QIP, yes, that would be the intent. That simultaneously this measure would be put in and the calcium measure, which is topped out and is now just a reporting measure, would be removed.
Oh, I got it. So the calcium measure's been, will come off because it's topped out. Okay.
It is, and it's actually, I believe it has also, and our developer can confirm this, but I believe it's also lost endorsement, the calcium measure.
Okay. Very helpful. Thank you.
Okay. And Sandy, I do see your hand is raised. I just wanted to look through to make sure I hadn't missed any patient participant comments, and I am not seeing anything. So I'm going to open it up to oh wait, Marty.
Just a question. If last year was a tough year for phosphorus, is this year projected to be better? Have we gotten past that hurdle?
Well, some of the issues have been dealt with in terms of pharmacies and things like that. But it's going to remain tough as dialysis providers adjust to medications. Nobody knows what CMS is going to do in terms of paying for phosphate binders when they're rolled into the bundle next year. So dialysis facilities are being very hesitant in determining which ones to administer. So it remains a very difficult issue.
Thank you.
So another clarifying question. So Jeffrey mentioned that there's no consensus about the level of phosphorus, but this measure was endorsed. So what was the discussion around that and the evidence for what an appropriate phosphorus level is in somebody on dialysis? Am I asking the right question?
So I can turn it up Dr. Clark if you wanted to address that, or the measure developers.
Yep, I'm happy to
John.
to dive in and take that one.
I think you're asking an excellent question in terms of the evidence base that supports the measure. And there were a couple studies that looked at exactly this scenario: chronic dialysis patients with a 6-month rolling average with a phosphorus greater than 6.5. And those patients had the highest risk of adverse events, particularly cardiovascular morbidity and mortality. So the 6.5 is not necessarily we're not trying to promulgate a specific phosphorus target. Most dialysis facilities aim to have their patients' phosphorus less than 5.5, would be sort of a community practice standard. 6.5 comes from the literature, which suggests that these patients have the highest risk of poor outcome. And it was a phosphorus level that our technical expert panel could largely endorse as being high enough that there was general agreement that phosphorus should be less than that mark.
Thank you.
Yep. Okay. And then, Jonathan, while I have you on, there's another question in the chat asking if the measure is risk adjusted so that it might address Dr. Irwin Scott's concerns about patient compliance.
Right. And we had discussion about risk adjustment for the measure, and our technical expert panel advised us that after doing some preliminary analyses that this measure was best off not being risk adjusted. So we did consult with our group of experts in that development process. And we very much understand that controlling phosphorus takes a village, right? It's not just it's the prescribing physician and their binders, it's the dietitian, it's the whole team trying to work together to help people lower their phosphorus values and try and make the best food choices they can. So it's not really just all about patient compliance. There's a lot more that's at play here.
Thank you. I appreciate it. And so, so I've heard a couple of things. One I've heard, and I think that the developer addressed it well, which is the 6.5 threshold and the rationale behind that. Also heard some concerns around the challenges. As Dr. Irwin Scott said, it's been a tough year for phosphorus. But that some of those challenges have been mitigated. Dr. Clark noted that the intent, if this measure is included, would be to remove the calcium measure because it is extremely topped out. And I think I captured it. Is there anything I didn't add that would impact people's vote?
Kate, I just added in there just so people understand when you're talking about phosphorus and the medications that we use for phosphorus, it's upwards of 2 to 4 pills every single meal, every single snack. If you put food in your mouth, you need to put a phosphate binder in there. And that's what makes it so hard to get patient buy-in, to get them to understand why we're begging them, I mean, pleading with them to take these meds because we know the long-term effects of cardiovascular, trust me, it is a village. It is the dietitian, the social worker, the charge nurse, the tech, the doctor on rounds week after week after week. Take your phosphate binders, take your phosphate binders, showing the pictures, showing what calciflaxis looks like. We are all engaged in this. I wish there was one magic pill once a day that would make this better, but there isn't. So I just, again, it is just not something that's easily solved, and I just want to make sure everybody understands that.
And thank you. I really appreciate that important context. Marty, I see that you have come off mute.
No, I have nothing more.
Okay. Like I said, people, if you come off mute, I'm going to find you. I'll make sure that I didn't miss anything. So Darlene and Julie, do you think we have what we need to move to a vote on this one?
Let's do it.
I think so.
Elena, then I'm going to hand it over to you.
All right, everybody. Voting is now open for MUC 2025-64 facility level percentage of chronic hyperphosphatemia in dialysis patients. Do you recommend including this measure in the end-stage renal disease quality incentive program? You should see that vote now, and I do see our votes coming in. And if you don't see that vote pop up automatically, you might need to just refresh your screen. All right. Just waiting on the last couple of votes here. Yeah, I think, all right, that is everybody. So I'll give it back to you, Kate.
Thank you so much, and thank you all. I am going to turn over to my colleague, Meredith.
Great. Thanks so much, Kate. So we're going to press ahead to our next measure. As Kate mentioned before she started her measures, please do take care of yourselves. It's a long afternoon. If you need to step away, just please let us know in the chat so we can ensure that we're maintaining quorum. So our next measure is MUC 2025-023. It is Collaborate Shared Decision-Making Tool for Ambulatory or Outpatient Surgery Patients, or the Surgical Collaborate OASPM for short. And we can move ahead to the next slide. So this measure assesses facility-level compliance with administration of the Collaborate Shared Decision-Making tool to patients undergoing outpatient or ambulatory surgery. To be compliant, facilities must offer 95% of patients the option to complete the survey following the shared decision-making conversation. Collaborate has been administered as a paper handout via mail, electronic mail, computer or web interface, voice-recorded telephone interviews, SMS text messages, and through MyChart EHR integration. It is available in 11 different languages, as well as for use in pediatrics and patients with special considerations, such as those with proxies or who are unable to speak for themselves. So this is a measure stewarded by the American College of Surgeons. It is a PRO-PM, or patient experience of care measure at the facility level. It is endorsed in 2019 and slated for pursuit of maintenance endorsement in spring of 2026. We can move to the next slide. Great. This measure is being considered for the Ambulatory Surgical Center Quality Reporting Program and the Hospital Outpatient Quality Reporting Program. And with that overview, I will turn it over to Dr. Dan Green from CMS.
Thanks, Meredith. Good afternoon, everyone. Excuse me. Thanks for hanging in there. I know it's been a long day for everybody. So I'll be presenting an overview of this measure, but real quick, let me just introduce myself again. Dan Green, as Meredith mentioned, I'm a medical officer working in the QMVIG group, working under Michelle Schreiber and Ron Klein. I'm an OBGYN by training. So let's talk about this measure. So this measure assesses facility level compliance with administration of the Collaborate Shared Decision-Making tool, which is given to patients undergoing outpatient or ambulatory surgery. For folks to be compliant with this, the facility has to offer 95% of patients the option to complete this survey tool prior to their ambulatory or outpatient surgical procedure. The Collaborate tool, for those who don't know, is a very short and easy to fill out tool. It's fast. It consists of 3 questions. It's freely available in the public domain under a Creative Commons license. And as Meredith mentioned, it is available in multiple different languages. CMS thinks that shared decision-making is important in engaging patients' treatment decisions and supports shared decision-making in elective outpatient surgeries. Use of the survey tool has proven to improve patient satisfaction as well as health outcomes. Excuse me. Shared decision-making is an integral component of the high-quality patient-centered surgical care, and it can be readily evaluated, again, excuse me, using the Collaborate measure. Tools that assess shared decision-making capture meaningful differences in care quality from the patient perspective, such as whether patients felt understood and whether their surgical decisions align with their personal goals. Research has shown that shared decision-making is associated with better patient satisfaction, improved outcomes, reduced unnecessary healthcare use. And importantly, patients who experienced complications have reported lower quality decision-making conversations, underscoring the link between communication and outcomes. Excuse me. So as I mentioned, it is a brief 3-question survey. It can be administered at any point after the shared decision-making conversation, but before the surgical procedure takes place. It could be administered in the doctor's office. It could be administered in the pre-op holding area. It does allow flexibility in how facilities decide to incorporate the survey and the opportunity to collaborate with surgeons to ensure the completion of the survey. It can be administered via, this is the survey that is, can be administered either through a paper handout, could be done via mail, email, computer or web interface. It could be a voice recorded telephone interview, an SMS message, or even part of an EHR or through EHR integration. Meredith, I think I'll stop there and pass it back to you. Thank you.
Great. Thank you so much. I'm going to summarize some public comments. We did receive 24 written public comments on this measure and received 10 spoken public comments at the listening session. One of the written public comments we received was from the developer, and I think echoes a lot of the points that Dr. Green raised. One thing that I think hasn't specifically been called out yet that the developer indicated is that current measures in the ASCQR and OQR often rely on adverse event and complication-based measures as the primary metrics for quality of care, and that is despite the fact that patients in hospital outpatient departments and ASCs are often lower risk with lower frequencies of adverse events, and that this can lead to sort of lower variation in outcomes and the inability to distinguish quality of care. So capturing meaningful differences in care quality from the patient perspective is one way to help patients differentiate between facilities and can help the surgical team organize around patients' goals. The developer noted some of the feasibility bonuses of this measure that Dr. Green noted, that it's a brief survey, 3 questions. It is administered only pre-operatively instead of a pre-post follow-up administration. And they envision that the Collaborate tool will be the first step towards more widespread adoption, allowing facilities to incorporate the tool into their workflow before implementation and pay for performance. Other public comments express support for encouraging and increasing shared decision-making as something that is both important to patients and supports best health outcomes. One comment further noted that shared decision-making is also associated with lower medical expenditures, reduction in healthcare utilization gaps, and reduced post-treatment regret. There were some concerns raised in public comment about this measure. One was that this measure appears to be a burden on the facility where the procedure will be performed, whereas the shared decision-making process is usually conducted in the physician office, not in the surgical center. The surgery center therefore becomes responsible for assessing the patient's thoughts on the process at a time when they're entering the operating room, and this could delay care and reduce inefficiencies. This comment recommends that the tool be implemented at the site of decision making. Public comments also expressed some concern about limited information about implementation and testing, particularly validity testing. Some concerns that the measure is a checkbox measure because it measures the administration of the tool, not necessarily incentivizing providers to make the process meaningful. Some of the concerns that came up in the discussion of DPALs are echoed in other public comments about harmonizing this tool with existing patient-reported surveys such as CAPS, THA, TKA, ProPMs, the information transfer ProPM, et cetera, to make sure that the potential burden on patients is reduced, as well as the burden on reporting entities. As I mentioned in an earlier concern, there was concern that the preoperative process more commonly occurs in outpatient clinics, and there was some concern expressed that this might be a better suited to the surgeon level or to MIPS rather than a facility level accountability. And comments also noted that small rural and medically underserved communities, hospitals do not employ their providers, and so they shouldn't be held accountable for that. And lastly, one commenter encouraged CMS to consider flexibility in implementation by allowing for the use of other shared decision-making questionnaires that have the same intent and rigorous development as this particular tool. We can move to the next slide, and I'll briefly summarize closing gaps of care. So our literature review found that elderly patients or those with disabilities may require proxy support to complete surveys, and that urban facilities may be more likely to have the robust technological structure to administer the Collaborate survey electronically. And just in terms of language and literacy, as Dr. Green noted, this tool is available in 11 different languages. So we have a lot of hands up to get us started. So we can go ahead and start with comments from our advisory group. What are the key issues you think need to be discussed about this measure? So Maya, you're up first.
So Premier is a huge fan and supporter of shared decision-making tools. We think it's valuable, especially if it's in helping to ensure that patients receive the type of care they want. We see the value of shared decision-making, possibly avoiding surgery that perhaps will not end with the results that the patient sought in the first place. That said, we're very concerned about this measure. We question how effective it will be in actually achieving shared decision-making. It does read as a process measure and one that is easily administered prior to the day of surgery. Speaking from my personal experience, having seen these types of surveys and specifically shared decision-making tools piloted in other facilities and organizations, it just ends up being paperwork that's included in the patient's preoperative documentation. So it does not actually achieve the intended result of having a meaningful discussion about the pros and cons. The decision has already been made, and then this simply becomes okay, make sure you fill out this paper, please, so that we're not dinged for not administering it.
Thank you, Samaya. I'm going to turn to Jennifer Lundblad next.
Great, thanks, Meredith. I was so excited to see a shared decision-making measure come forward in the MUC list this year. Shared decision-making is an important part of what we do at Stratus Health in our health improvement work, and we facilitate a shared decision-making collaborative. So I was kind of spreading it widely and encouraging people to make comments. And as excited as I am, I share some of the concerns that you just reported from the public comment period and some of the things that were just shared. So I'll try to be brief. 3 things. We'd like to better understand what seems like a small sample size in the pilot and testing for a small population. And we're unsure of whether the testing of the tool really best reflects the utilization of the tool. So can we extrapolate realistically to be this measure? Secondly, the measure measures whether the survey was offered to patients, which seems pretty tepid and doesn't really measure shared decision-making. And then third, as was noted before, patients already have to do a couple of other surveys, PRO and the CAPS. Is it feasible even to ask for 3 additional questions to be done? So just wanted to put those 3 things on the table for recommendation group discussion.
Thank you, Jennifer. And before I turn to you, Jan, just wanted to make a couple of notes. I see this already happening, but folks, we are running up towards the end of the day. And so I encourage you to use the chat to express your agreement with statements that have been made, just so we avoid, repeating. And the other thing I wanted to see is if CMS or the measure developer could address some of the questions that have come up via the chat about the difference between the measure that's being discussed now versus the one that was endorsed in 2019, just sort of catch us up on what has changed since that initial endorsement. Jan.
So very quickly, I agree with all the comments that have been made. From looking at this, the specifications from a purely technical standpoint, the physician-patient conversation does occur in the office. It can occur up to 30 days before when a CMS allows a history and physical to be dictated. And the only record the hospital has about anything is they get scheduled on the OR. So to complete this measurement within a week of the shared decision-making is not possible from a hospital perspective because that conversation is not documented. We don't know about it. We don't know when it occurred. I would agree that it belongs in more of a MIPS program than to be given to a patient right before they go into the OR when they're stressed.
Thank you, Jan. Kathy.
Thank you. I won't repeat the other comments that have been made for the recommendation group to consider, but I just want to also point out from the ASC perspective that this could be yet another expense for an external vendor to administer a survey, and the expenses are really ramping up for that. Thank you.
Great. So I think we've heard some priorities from the advisory group. Let's turn to our patient committee members. Oh, Cliff, did you want to respond to some of the questions that have come up from the developer's perspective?
Yeah, I would figured I would hear everything and try to sum it up rather than a piecemeal thing. Is that okay?
Sure, and please also feel free to use the chat to respond as well. But I'm going to just check with our patient committee members to see if they would like to weigh in on this measure. Marty.
I'm glad Cliff is here because my question was going to be, why put this measure into this program? Cliff, I was on the public comment phone call, and you just heard this reiterated over and over again. Wrong setting, wrong setting, wrong setting. But I figured there must be a reason that ASC would put this into, ACS would put this into this program. Because overall, I like the idea of this measure. It's short. It can be administered in a lot of ways. It appeals to a lot of different kinds of patients. So all those things I really like, but the opposition has been pretty strong.
Yeah. Thank you.
Any other questions or comments from our patient committee members? Okay, Rosie.
Well, I think this is an important measure, and shared decision making is sometimes overlooked in the ambulatory or outpatient setting, especially in some of the standalone ambulatory settings. And so I think that it should begin with the clinician, but it sometimes doesn't, and then it gets overlooked in the ambulatory surgical centers or in the outpatient surgery center, outpatient surgery areas of healthcare hospitals. So I think that it's an important shared decision making is so important to surgeries and the outcomes of surgeries, and yet many times it's very quickly overlooked or doesn't happen at all. Or, I've been handed multiple times in ambulatory surgery, sign here so we can get this done with. And, that has been my experience in ambulatory surgery more than ever in the hospital surgeries. But in ambulatory surgery, because it's sometimes often things that are not that, and at least in my situation, it was not the high risk surgeries that I was having, but now there's lots of surgeries happening in ambulatory surgery that were used to be in hospitals. And so I think this is important, and it might need to be in this area, in both areas, maybe.
Yeah, thank you, Rosie. And I think some of your comments echo what we've heard from advisory group members about support for the concept of shared decision making and the importance of shared decision making in surgery. Darlene.
Okay, maybe I'm the crazy person that actually knows how to advocate, but it's so crazy to me that we even need this measure. So as a patient, why in the world would you agree to a surgery that you haven't addressed these questions, that you haven't made sure that there's a clear understanding of what the issue is, therefore why the surgery needs to be performed, and what the outcome or the proposed outcome from the surgery, plus the pros and cons. Like I'm baffled that this is even needed. But I'm probably the one-off. So there's a lot of doctors on here. Please inform me.
And Darlene, you and I are, and many of us on this call are the exception, not the rule of many people having surgeries.
Yeah, thank you, Darlene, for posing such a common sense question for all of us. I did want to just call in attention to the chat. Jeff put a comment in at 4:02 to answer the question about what's changed since endorsement, just to sort of clarify sort of what's different about the current iteration of the measure versus what was endorsed. I mean, just wanted to lift up another comment from Sherry that, she's echoing Julie's previous comment about employing surgeons, which critical access hospitals often don't employ the surgeons who do surgery at the facility, and so they don't have much influence on their practice before a patient comes in. So I think we can open up to all of our advisory group members to weigh, all of our recommendation group members to weigh in. Please, folks, if you haven't had a chance to express your thoughts on this measure, now would be a great time.
So Meredith, is this a good time for me to kind of answer as the measure?
Absolutely, yes.
Submitter?
Please go ahead.
So I tried to take notes. And so first of all, Rosie and Darlene couldn't agree more that shared decision making is really important. And I won't use my own examples. I'll use the data that we had and to answer some of the other people. So this collaborate, in addition to the work by the original measure developers who got it through NQF in 2019, we took that measure and put it into 80 different sites and over 30,000 ambulatory surgeries. 30,000. It wasn't just where I work or my patients, it was 30,000. All types of surgeries, general surgery, urology, ENT, just anything that's run-of-the-mill in an ambulatory center. And I thought that, yeah, everyone's going to be perfect on the score because it's only 3 questions. The 3 questions are, did you as the patient feel like your voice was heard? Number 2, did the doctor talk to you or the provider talk to you? Number 3, did you take what you said and what the provider said and do shared decision making? Just 3. And the results showed that 1/3 felt they did not have, the scores showed that 1/3 did not have adequate shared decision making. One of those 3 questions was not good. And so if this were 99%, we wouldn't need this measure, as Darlene had said, but the data shows from a pretty large sample of patients that it is needed. And this is not just, it was done in academic teaching places or non-teaching places or whatnot. It was all sorts, all places, rural, critical access. There were in big cities and so forth. And so we felt that we needed this, and really it gets down to one of the questions that somebody asked, and I think that a lot of public comment was like, well, who's responsible for this? Should it be the surgeon and this be in MIPS? Should it be, I don't know, sometimes anesthesia does their talks too. Should we have another one for anesthesia? Put that in MIPS, or should this be a facility? We really wanted to keep this outpatient because when we try to look at outpatient surgery, and I think everyone on the call knows that ambulatory surgery, the numbers are increasing. They're not, they're increasing. And we do not have good metrics in the ambulatory site. In the inpatient site, you know, we can look at we can look at a whole bunch of things. We do not have the data infrastructure, nor do those same complications occur in the outpatient setting. So we need some good quality metrics to make sure that the quality of surgery in the outpatient setting is being done well. This is a very low burden, 3 items. It takes 30 seconds to fill out, piece to do. And when people say, well, this should be done individual versus the facility, you know, if I had my druthers, I would say both. And the reason I say both is that ultimately, when we look at the quality of surgery, it's done as a team. And when the team doesn't work and it gets fragmented is when care falls apart. That's why we need all the handoffs we have. That's why we need all the communication we have. That's why when Joint Commission looks at all the root cause analyses, the number one problem is communication. If the communication isn't there, which is from fragmented, isolated care in silos, that's when quality decreases. By putting it on both the facility and the individual, we are showing that the care is really that team. The point about
Sorry, Cliff, if you wouldn't mind starting to wrap up because we are short on time. Thank you.
Okay. As far as let me go kind of about having this not be an outcome measure, but a process measure. There are certain metrics and certain topics that cannot be outcome measures because it can't be measured. For example, in VTE, we cannot measure VTE because of surveillance bias. So we measure process. Sometimes the outcome is it leads to unintended consequences like mortality. Then patients who are high risk don't get operated on because the providers don't want a high mortality. And sometimes outcomes will pale in comparison to the importance of the process. The importance of the process here is shared decision making. It's 3 item, 30 seconds. And there are already measures in the ASC list where it is outside the facility, like they're responsible for admissions to hospitals after colonoscopy, after urology, after ortho. So this idea of just the teamness is already in place, and this is just a small addition to that. So I'll stop here, Meredith. Thanks.
Thank you so much. Thank you. Julie, you have your hand up.
So Cliff, I'm curious about, so talking about the shared responsibility between the facility and the physician, what are your thoughts on MIPS versus hospital outpatient? And again, I will speak, I can't imagine surgeons not being collaborative or good communicators, but where is the individual surgeon accountability by being in this program?
By doing it in both there, everyone is responsible. It's the whole team. So the thing about MIPS is that it's voluntary. The thing about the facility is that just the way an inpatient facility ensures that the surgeon's credentialed and privileged, the facilities can ensure that these patients are getting the shared decision making from the surgeons who are operating at that facility.
Jeff, did you have a comment to add to Cliff's response?
Thank you, Dr. Coate. I just had one addition to make to that comment, which is that when we tested this as well, it was nearly twice as reliable when we measured it at the facility level compared to when we measured it at the provider level. And the citation for that is shared in the chat.
Thank you for sharing that.
Oh,
Okay.
and sorry, Meredith, one more. Somebody had mentioned, can we use something else? And when we did this study, we also looked at, there's another instrument called the SDM9 shared decision making, and it 9 items, which when you look at it, seems to make more sense, but it did not test as well as the Collaborate. So, which is good because Collaborate's shorter. So I wanted to add that.
Thank you. Just seeing some questions in the chat about the testing of this measure. Was it tested on Epic Cerner or a shared EMR, and then another question about how would ASCs get information to complete this measure if the surgeon completes this in their office. So again, I think there's an ongoing concern about
Meredith,
the accountability piece. Yes.
Cliff, I'm sorry, I'll take one of those. I don't know about the testing in terms of the EHRs, but it could be that just like we fax or transmit pre-op information, including consents, labs, history and physical, to the surgery center before the case. Usually it's a week before the case, could be even a little shorter. This could just be one of the requirements that the hospital has as part of the pre-op.
I was just going to say that.
Oh my gosh, I had a great thought like Cliff. I'm impressed.
Great. Thank you for that. Okay. So I think we've heard a lot about sort of the brevity of this survey, the ease with which it can be administered, but some ongoing concerns about accountability and attribution of the measure to the facility versus the individual surgeon, and kind of where the responsibility lies. I know Cliff would say it's shared, just like I think there's great consensus that shared decision making is important. So I think the committee really needs to sort of weigh whether this measure sort of is the benefits, if it confers the benefits of the shared decision-making process without overburdening patients to provide a response or attributing the process to the wrong entity. So Julie and Darlene, did you want to add anything to that recap?
No, you do a great job.
Yep, we're good.
Julie? Okay. Why don't we take this, Julie and Darlene, if you agree. I think we can move to a vote on this one. So Elena, over to you.
Coming off mute would help, I suppose. Okay, everybody, voting is now open for MUC 2025-23 Collaborate Shared Decision-Making Tool for Ambulatory or Outpatient Surgery Patients at the Ambulatory Surgical Center Quality Reporting Program. Again, your votes are to recommend or not recommend. Okay. I believe we are expecting to see 19 votes come through the system here, so you may need to refresh your page if you don't see anything automatically pop up for you. We are just missing one more. Thank you, everybody, for your participation here and keeping us moving. All right, that is everybody for that vote. So in just a moment, you will see this next vote come up. All right, voting is now open for the same measure for the Hospital Outpatient Quality Reporting Program. So same deal here. If you do vote to do not recommend, please go ahead and include your rationale in the rationale tab. All right, nearly everybody, just waiting on 3 or 4 more votes here. We are at 16. I believe we're expecting to see 19 here, so just waiting on those last couple people. Again, if you're not seeing that vote pop up, go ahead and try refreshing your page or letting us know if you're having any trouble. I think we're expecting to see 2 more votes come through right now. We're still waiting on those last two votes again. We are voting on another program level here, so if you don't see that vote, refresh on your page. Go ahead and let us know or send me your vote directly in the chat.
Elena, I'm wondering if we'll keep the vote open, but we can do outreach. So please pay attention to your DMs if we do contact you to get your vote.
Absolutely.
Yeah. Thank you, Elena. I really appreciate it. So I did want to note that we have about 40 minutes left, and we have 2 more measures to discuss. Oh, sorry, did we finish voting for Collaborate, Elena, or am I moving us forward?
No, we're done. Thank you.
Thanks. So we are running up on time. I did want to ask if our recommendation group members are able to stay past 5, maybe to 5:15 or 5:30. If you're able to say so in the chat, we want to ensure that we're able to maintain discussion quorum, even though we wouldn't necessarily be able to achieve voting quorum. And so I'm going to ask, thank you, recommendation group members, so much. And so I'm going to ask my colleagues to count that while I move on to our next measure. Okay, malnutrition care score. Next slide, please. So this is MUC 2565 malnutrition care score. It is a composite. The measure assesses the percentage of eligible encounters of adults aged 18 or older at the start of the eligible encounter during the measurement period with a length of stay greater or equal to 24 hours, who received optimal malnutrition care, where care performed and was appropriate at the patient's level of malnutrition risk and severity. Malnutrition care best practices recommend that for each eligible encounter, adult inpatients are screened for malnutrition and for a dietitian referral order to be placed. Assessed by a registered dietitian or registered dietitian nutritionist to confirm the findings of the malnutrition risk. Receive a moderate or severe malnutrition diagnosis by a physician or eligible clinician, and then have a current nutrition care plan formed by a RD/RDN. This is an intermediate outcome specified at the facility level of analysis. It was endorsed with conditions in 2024, and I'm going to ask my colleagues to put those conditions in for time's sake. And this is currently in use in in a couple of CMS programs, but is undergoing some changes. I am going to turn it over to CMS and Dr. Marcia Smith for CMS's rationale.
Hi, thank you, Kate. I'm Marcia Smith. I'm a medical officer in the Quality Measurement Evaluation Incentive Group. I'm a pediatrician by training, and I just wanted to make a correction. I believe that this measure is not undergoing any changes. It's submitted to the MUP list because it's being added to a program. It's being added to the PPS exempt cancer hospitals. It's already in IQR. It is endorsed and it is being used in the program and reported. The malnutrition care score measure was adopted in fiscal year 2023. Final rule for IPPS LTCH, long-term care hospital, for the hospital inpatient quality reporting program and Medicare promoting interoperability program for patients 65 and older. The measure was expanded to include patients 18 and older, and that was finalized in fiscal year 2025 final rule, beginning with the 2026 data submission. The 18 plus measure version was endorsed with conditions during the spring 2024 endorsement cycle, and it is a ECQM. The endorsement committee recommended to study implementation data to include the patients 18 and older that examines whether the measure is associated with improved nutritional status or related clinical endpoint when returning to the endorsement and maintenance, when returning for endorsement maintenance. This was finalized, as previously stated, during the 2025 final rule, beginning with the 2026 data submission. We are now considering this measure to be added to PPS exempt cancer hospital quality reporting program. This is already endorsed measure, and it is in IQR, as I said. And we're just proposing to expand it to other inpatient settings, particularly PCH in the upcoming rulemaking cycle. This measure assesses the percentage of eligible encounters for adults age 18 years and older at the start of the measurement period with a length of stay greater than 24 hours who received optimal nutrition care during their hospitalization when care performed was appropriate to the patient's level of malnutrition risk and or severity. Malnutrition care best practices recommend that each hospitalization, adult inpatients are screened for malnutrition risk or have a dietitian referral order placed, are assessed to confirm findings of malnutrition risk or a dietitian referral order. And if identified with moderate or severe malnutrition status, receive a current moderate or severe malnutrition diagnosis by a physician or eligible clinician and have current nutrition care plan performed. Clinical and empirical evidence show malnutrition affects many hospitalized adults and may lead to worse outcomes. Yet gaps in malnutrition screening, documentation, and communication persist across all hospitals. CMS is considering adding this measure to PCH quality reporting program because we believe extending adoption to another program will promote better nutrition, an important component for American health, and enable better quality comparison across hospitals in the inpatient prospective payment system. Identification and remediation of malnutrition risk prompted by this measure promotes a shift away from sick care by helping identify at-risk patients, encouraging continuity of care, reducing risk of future readmissions, and improving quality of life. Thank you.
Thank you so much, Dr. Smith, and thank you for the clarification. So we did receive 10 written public comments and 9 spoken public comments on this measure. And it's a lot of the comments that we got were specific to the care setting, the prospective payment system at cancer exempt hospitals. So many commenters expressed strong support. Several noted that the oncology population is particularly vulnerable to malnutrition, with commenters giving the prevalence of malnutrition or risk anywhere between 25 to 80% of oncology patients. They also noted that nutrition is a component of best practice cancer care, and poor nutrition has a profound impact on cancer treatment and survivorship. Another said that malnutrition is a patient safety risk and has been shown to be an independent predictor of negative patient outcomes, including mortality, length of hospital stay, readmission, and hospital costs. Malnourished patients are more likely to develop pressure ulcers, infections, post-operative complications, and experience falls. One commenter said because it's already in use in other CMS programs, they see it as an easy addition to this. There were some concerns around the feasibility of this measure within rural settings, especially around staffing of registered dietitians. The challenge being that they do not necessarily have 24 access to them, and there was a request for a grace period for evenings and weekends. The commenter supported the exclusion of people who opt for hospice care, but said there are some patients who are frail and debilitated who may not make that choice, yet will not benefit from malnutrition efforts. So they recommend excluding patients with end-stage illnesses who are being seen by palliative care for having poor prognosis or function. Talk about a couple of gaps. So we go on to the next slide. Malnutrition is more common in older adults. As the public commenters noted, it's highly linked to morbidity and mortality. As also noted in the public comments, urban healthcare facilities are more likely to staff dietitian and nutritionists. Medicare and most other insurers use a payment model based on medical diagnosis, including malnutrition, to reimburse hospitals for a patient's stay. And an insurer may issue denial for any diagnostic code if they believe that the medical record documentation submitted with the claim is insufficient to support. As far as language and literacy go, patients have differing understanding, interpretation of, and identification with malnutrition risk and malnutrition terminology. And so I did want to, as we go back one, I want to open it for public or for comment. And I think I'm going to do it a little different this go round, which is that I'm going to ask our patient participants to open it up, and then I'll do a bit of AG-RG. So if you are an AG member who's used to asking questions or comments, please do so during that time. But just trying to do a little bit of efficiency. So any of our patient participants who want to say anything. And I did want to note in the chat, there's a question from Kristen, if someone from CMS could address it. It's asking if there are any digital dietitian programs that could be utilized to address the issue in rural areas. Marty.
It's endorsed. It's already used in a program. This is expanding it to a similar program I would support.
Okay. Thank you, Marty. Any other notes? And one of the things that we really want to discuss, it's not necessarily the merits of this measure. It's already in use in many programs. It's appropriateness for the exempt cancer hospitals. So just wanted to point that out, that it's not necessarily, the measure's appropriateness for this program. And Rosie is agreeing with Marty. And Rosie.
Well, this is probably the area where it really needs to be looked at, because cancer patients definitely often slip into malnutrition, and this is really important for them to be connected to the cancer center I go to monthly, and even at this point weekly. I'm seeing a dietitian meet with every cancer patient. I'm there for hematology reasons, but every patient that's a cancer patient, I see the dietitian come in and meet with them even on a weekly basis. So, that there's a real strong need for this in cancer patients. Thank you.
Thank you, Rosie. I really appreciate it. And I do want to note in the chat that the steward replied that the solution the facility decides on promoting will be based on facility resources, policies, as well as state, local, and federal regulations. And that was in response to Kristen's question. For our advisory group and recommendation, one moment. I just want to say, for our advisory group and our recommendation group, is there anything that you need to know in order to cast a vote you feel confident in? Are there any outstanding questions or concerns that you would like addressed? And then I'll turn over to the developer in one moment, but I do want to ask our AG and RG members if there's anything critical that they need to know in order to cast a vote. And then there was developer, if you wanted to unmute, and I think you wanted to provide a comment.
Hey, I was just gonna call attention to another comment that's in the chat that Tamara Ojeda from the Academy put as well, that aligns with the comment that you mentioned, that there are rural acute care hospitals that are moving toward developing remote and hybrid positions for RD coverage. So from a dietitian perspective, I've worked in rural and urban facilities, and I do find that most have access to a registered dietitian. And one of the great things about this measure is the measure observations are not time specific. So as long as it happens within the encounter period, then it's counted toward the measure observation. So I think that does leave a little room for the rural hospitals where, they're not going to have a dietitian 7 days a week. It kind of alleviates that concern somewhat.
Thank you, Angela. I really appreciate it.
Mm-hmm. Sure.
Are there any other questions for the developer before we move to voting? Okay, thank you all so much. And Elena, I'm going to turn it over to you.
All right, the vote is now open for MUC 2025-65 malnutrition care score. This time you are voting on the recommendation for it to be included in the prospective payment system exempt cancer hospital quality reporting program. Right. See some votes coming in. Okay, just waiting on the last couple here. I believe we're expecting to see 18 and I see 16. So again, you may need to refresh your page if you're not seeing that vote pop up.
Elena, are we waiting for anyone else or?
Yes, but I can leave the vote open and follow up with those two that we're missing from.
Oh, absolutely wonderful. Thank you, Elena. And thank you all so much. I am going to turn it over to my colleague, Brenna Rabel.
Yes, we are on our last measure of the day. Deep breaths, everybody. We're getting there. So this is related to the advanced care planning measure. We do have a quick update on this one. So you may have noticed initially that we were going to be voting for this measure across a bunch of different programs. We're going to be voting on fewer of them. So I guess, Ron, would you like to talk about that now before I introduce the measure? Or would you prefer that I introduce the measure and then give you an opportunity to give that update?
I mean, I'll just keep it really simple. This is advanced care planning measure. I'll let you introduce it. The measure is currently specified really only for inpatient settings. So even though we listed it for outpatient settings, it's not specified for that. We still think it's an important conversation to have broadly across all programs, but in terms of votes, it'll only be for the inpatient programs. And I hope I said that all right. Please correct me if I didn't.
That's the latest as far as I'm aware of it. So you'll see when we get to the vote, we'll specify which programs that you're voting on. I know that this conversation will probably take us right up until 5 o'clock, which is our scheduled stop time. Some folks have already said they're going to stay over. I would ask that anybody who has a hard stop at 5, who's on the recommendation group, just message us with your votes so that we get those before you leave. But with that, let's just jump on to the next slide here. This is MUC 2025-020, Advanced Care Planning, and this is the percentage of patients 18 and older who at the start of the measurement period with one or more inpatient encounters have an advanced care planning document or documentation of an advanced care planning discussion, resulting in a documented decision in the EHR by the time of hospital discharge for at least one hospital encounter during the measurement period. It's a process measure at the facility level and it is not endorsed. And Ron, if you wanted to give a quick intro with the rationale on that, that would be great.
Sure. So I'm going to start with the most important thing that was said about this measure today, and that was from Rosie when we were talking about the ESRD measures. And she said she didn't have an advanced care plan because she didn't think she was going to need it. And all of a sudden she found out she might. So that sort of preemptively addressing the issue of, why are we doing advanced care plans for people who aren't sick? And the answer is because you never know when you are going to be sick. And if you are in a hospital for whatever reason, by definition, you are in a high risk group than the normal person walking around on the street. And so that's why we think this is a very, very important measure. It's for ages 18 and over. So all adults over, because I think the goal here is not to say, well, if you're over 50 or over 60, over 65, over 70, you should have it. It's to sort of normalize the idea that every adult in a hospital who's an inpatient in a hospital should have an advanced care plan. The other thing I want to say is that, and because I was on the TAP that was involved in working on this measure to hopefully make it easier for folks. There are sort of all these BOLST and PULST and various different kinds of advanced care planning documents. And where the TEP got hung up, and I think we all got hung up, was, I don't know, there's so many different medical things that could occur. I don't know what I would want, chest compressions, resuscitation, meds, no meds, intubation, no intubation. How do you expect me to make that decision? And sort of the breakthrough aha moment we had was, we said it satisfies the numerator to basically designate a healthcare proxy. And so by that, I would say that even though and even medical people, even if you can't say, well, I wouldn't know exactly what I'd want in various different clinical scenarios, hopefully most of us have in our lives a person who we trust to act in our best interest, who, if we couldn't make that decision, would make that in our best interest. And so if you designate a healthcare proxy, that satisfies a numerator for this measure. The only other thing in this measure that I think is different than perhaps some other measures you may have heard about, where there's a CMS code for advanced care planning discussions, is we have specified to meet the numerator in this measure that you have some action results from that conversation, even if the decision is continue everything, don't change anything, that has to be documented. And the reason we thought that was so important at CMS is because, unfortunately, it's just so easy to check the box, say, I had this conversation, nothing comes of it, and who can verify whether you ever had the conversation or not. So for the purposes of this measure, it's all adults. If you're an inpatient, and it is designated a healthcare proxy is sufficient, and there has to be some action that stems from that. That even if it just means continue to do everything. And I think I was going to say one other important thing, and it just slipped right out of my mind. Yes, just that's important for everyone. Anything can happen at any time. I leave it at that. And the thing I was thinking of, I'm sure will come back to me in a second, but in the meantime, I'll let other people go ahead and continue this. Oh, I know. I'm sorry. The most important thing. I almost forgot the most important thing. This is not CMS saying we want everybody to say, do not resuscitate me so CMS can save money. That is absolutely, unequivocally underscored, not that. All we're saying is CMS, the healthcare system, wants you to tell us what you want. Express your thoughts so that you're not sitting there in a situation where you can't express your thoughts and having people wonder what you want. And perhaps one of the side benefits of this measure, right, is even if just the process of designating a healthcare proxy forces you to have a conversation with a loved one that says, hey, what would you want if this happened? Then we've already achieved our goal. So it's 4:40. We can all hold hands virtually, sing Kumbaya, and vote yes on this measure and go home 20 minutes early, or we can continue to discuss. So anyway, I look forward to discussion.
Let me just go ahead and say, I will note, we got 100 different public comments on this measure.
Oh,
it was
good. Okay.
Enormously high engagement with the public. As you said, we are at 4:40. I'm not going to go through 100 comments, but there's enough here that I do want to make sure everybody hears the feedback that we got on this one. So in terms of the support themes, I think we heard any opportunity to interact and assess patients' end-of-life wishes should be encouraged prior to a surgical procedure. Healthcare providers should be confident in the event of an unexpected poor outcome. Others have said this measure appears reasonable and aligns with ongoing efforts to reduce hospital-acquired infections to improve care quality and patient safety. People feel that this supports patient-centered care. Folks have said that it's a critically important tool for helping individuals articulate and document their values and preferences as they age to ensure that the care that they receive, including end-of-life care, is aligned with what matters to them. This measure reinforces accountability for integrated, skilled clinical communication and responsive documentation processes that capture patient preferences and priorities as essential aspects of quality of care delivery. It's applicable early and frequently over the course of care. Support for this measure, we've heard that there are lots of supports for this measure as a starting point Folks feel like it's imperative that hospitals around the country and the world improve their documentation of patient wishes. This helps ensure that patients get the care they need and that their caregivers don't have to make urgent decisions for them. And it's a relatively inexpensive way to improve healthcare in the country. Folks say that advanced care planning is essential not only to save patient and facility resources, but more importantly, to avoid inflicting unnecessary and futile pain and discomfort at the end of life. And again, we've heard personal stories, one of which is that from a doctor who says, throughout my career, I've witnessed countless distressing and preventable situations that arise when advanced care directives are not in place. We did have a few notes of concern. I want to just point those out. So some of those were just needing some clarification on like what a documented decision is. So the measure specifies that the measure has to include a documented decision, but what in practice does that look like? Some folks say that there's a risk of overuse and patient burden where, basically advanced care planning is addressed excessively during inpatient stays, which may lead to patient fatigue or confusion. And that would be exacerbated at EHR systems that are not interoperable, where hospitals may not have a good sense for whether something like this is already on the patient's record. And then there were considerations for some of the other programs, specifically ESRD, inpatient rehab, OQR and ASCQR, as well as MIPS. I won't read all of those since we're no longer voting on those programs, but should somebody want to hear about that later, I'll bring it up. But in the meantime, let's just go to the next slide very quickly. I just don't want to ignore these care gaps. Again, age, geography, dual Medicare and Medicaid eligibility. As we've seen with all of the measures that we've looked at over the last couple of days, there are clear known gaps in care by each of these criteria. And let's go to the next slide. I think there was one more. Yep. Same with insurance status and language and literacy. I'm happy to go back to these slides throughout the discussion, but in the name of time, I'd like to just go back to the descriptor and let Jen give her thoughts.
Did you say me?
Yeah.
Oh, sorry. 3 very quick questions. Can somebody like a registration clerk answer the question about who is your advocate? Number 1, or does it have to be a clinical person? Number 2, there is no refusal documented in the specs, and some people refuse to answer these, and I think that should be allowed, especially in the case if they're in an inpatient admission related to substance abuse. So they do have the opportunity, and rules and regs allow them not to have an advocate. And how does CMS expect the conversations of physicians where they might be doing the clarification to occur when their notes are not structured? Thank you.
Okay, so Maya, you go ahead, and Mary, and then Ron, I'll get back over to you so you can reply.
So I just want to say that, Premier is very supportive of an advanced care planning measure. My one caution is this measure is being proposed for all of the quality programs, and I'm seriously worried about survey fatigue and patients not taking this discussion seriously because they're like, oh, I already had that with my doctor, or I already had that with my, nephrologist, and so on and so forth. So I think, I'd love to advise like caution and discernment in the implementation of this measure because it is so valuable. And hopefully, as we get closer to, actual interoperability, that, this information will be shared across different systems, different facilities and facility types so that, to avoid the need to constantly redo this, the advanced care plan.
So Maya, that's an important consideration. I will note, I think that's what Ron was getting at earlier, that we're not voting on a lot of the outpatient programs because it's not ready for those programs at this time. So it's actually just being proposed for the ones that are listed on I think it's on the prior slide. Let's just go there so everybody can see. Yeah, so hospital inpatient, hospital VBP, promoting interoperability, and then PPS exempt cancer hospital. So those are the only 3 programs that we're voting on that this is being proposed for right now. Go ahead, Mary.
Just one notation. I don't see a limitation on the length of stay. And if we have a patient that comes in critically ill, maybe unresponsive, maybe no family members present and passes away the next day, I don't see an out for that, meaning that, you're not going to be able to have that discussion. You may not be able to have it with anybody, and that patient may pass before we get a hold of any other any other people and work through those legalities. But I think a length of stay limitation should be there if somebody is just here one day.
Thanks. Yeah, it's a good suggestion. Okay, Ron, there were lots of questions that came up. I think, do you want to start with Jan's about how it's operationalized?
Yeah, just a couple quick questions. So I think that that whole issue of refusal to answer a question is a really hard one. And it seems simple and it's really hard. And please forgive my cynicism. The problem is when you put a patient refusal there, then that becomes an easy out for somebody who didn't ask the question to just click the box and say they refused, and then you get out of answering it. So I think it's an intellectually, theoretically valid question, and I agree with it. And the problem is how do we prevent that from being an easy out for people? That's I guess one thing. As I mentioned before, I'm an oncologist, and these are hard conversations to have. And I am not sympathetic, is perhaps the nicest way I can put that, to having a length of stay limitation. Because if someone comes into your hospital, your ER, and they are on death's door, or they are soon to be unresponsive, that should be the first thing you do, or the third thing you do. So I really saying, well, we can't get it done in a day. I guess I'm not. Maybe if I misheard it, I would just say I really think that needs to be a priority in what you do. That would be the second thing I would say. And I think that was those are the main questions. But in terms of who's able to answer who's able to do this, I think the intent was that it be a clinician who does it, whether who enters this into medical records. But I'm not 100% certain on that. And yes, to your point about survey fatigue, yes, we had the same issue come up before with other issues we've dealt with, where we think they're very important issues and we want to put them across multiple programs. And yes, we do need to figure out a way so that we're not always asking the same question repeatedly. And in some interoperable world of the future, that problem will be solved.
Thank you. Julie, go ahead.
Sorry, had too many windows up. So I think when we with my AAFP colleagues, we kind of deep dove into this one, and one of the satisfying codes for kind of criteria number 2 of documenting a conversation has been had is a CPT2 code 1124F that says that you had the conversation and the patient either did not or was not able to identify somebody. And so when we were thinking about how to operationalize this, we kind of identified that code as an opportunity for those kind of more difficult cases that you're not able to identify it. And then I guess my only other concern is that there is no exclusion criteria for just not having capacity, and that particularly in the inpatient setting, if the patient doesn't have capacity, either due to acute illness or chronic issues, the ship has sailed. You can't do advanced care planning at that point.
I think that's a fair point.
And so all the more reason to make sure you do it when they do have capacity. But if there was any exclusion criteria that I'd like to see, it would be around the issue of determining capacity. But otherwise, I actually really like this and think that it is possible to operationalize and is a pretty cheap way of preventing a whole lot of healthcare badness.
Thanks, Julie. Rosie, go ahead.
Well, Ron pointed out that I didn't have a proxy, and yet as I was being intubated that night, or any time, especially that time when I was 6 days in a coma, as I was being intubated, they could have asked me, they asked me, did I want to live? But they didn't ask me, did I have a proxy? Or did I want someone to speak for me? As I was being intubated. I mean, there could have been a chance. And this measure would have helped my husband deal with the situation a whole lot easier. Thank you, Ron, for bringing this forward.
Thank you, Rosie, again. I never cease to be amazed by the things that you've gotten through, and I really appreciate it. There's been some questions in the chat, and Ron and others, thank you for responding. We're kind of at the end of the day here, and I invite anybody to correct me if I'm wrong, but it sounds like we're sort of achieving a little bit of a consensus on this one. So let me, Nick, before you chime in, let me just summarize here just to make sure that I've said what I think everybody else is saying. So first is we've sort of heard from CMS and also in the chat that this measure it's straightforward, it's very feasible to implement widely. It's widely agreed upon to be very much near the center of patient-centered care, and it's something that should be happening already, but since it isn't, this is a good step. And that so far the biggest unintended consequence that I've heard here is that it might get a little bit frustrating for patients to have to answer these questions over and over again whenever they're like in an inpatient stay. So I want to just make sure, does that feel consistent with what everybody has heard so far? Just like thumbs up or quick nods. That's good. And then, okay. And then Nick, go ahead.
Yeah, so this is a great idea, and it would make life in the hospital so much easier if everyone had their advanced care planning when they entered. You know, over 80%, almost 90% of hospitals in this country now have hospital medicine programs. When you layer on top of that intensivists, intensive care docs, we've created what Bob Wachter refers to as a purposeful discontinuity in medicine. And I say this through the eyes of both a hospitalist, which I am now, and a community practicing internal medicine doc, which I was for 15 years. When I was in practice, I knew my patients, I could have this discussion with any one of them the minute they walk through the doors of a hospital. Now, with this purposeful discontinuity, it can create a very awkward situation that almost becomes confrontational at times. And while this is absolutely necessary, one of my concerns is operationalizing this in the hospital setting. And what I would love to see is if we adopt this, but we say for those with a length of stay, just even greater than 2 days, 3 days. And the reason is if we make them do it on admission, and we're doing it right now, it becomes rote. It's just like what happened with the Patient Self-Determination Act in the 1990s. It becomes a rote process. And to insist that a doc meeting a patient for the first time have this conversation, it's very easy if someone comes in as sick as Rosie's been, right? That's easy, or end-stage cancer. Think about your 18-year-old son or daughter who comes in with appendicitis, and I'm now having this conversation with you, right? It could really cause discord between the treating team and the patient and the family. So while I love this and it's absolutely necessary, we should build something in there that doesn't foist upon a doc meeting a patient for the first time who may only be taking care of them for less than 24 to 48 hours to have this conversation. And I get it. How do we then operationalize that and take care of that? You know, if it's the first 24 hours and you're critically ill, I got no problem having that because it's obvious to everyone. But there are many others that this would be awkward at best.
Thank you, Nick. And I saw in the chat, we got a similar comments from Sandy as we got on some of the other measures, which was some concern about including this in HBBP until hospitals have had an opportunity to experience reporting and understanding reporting and implementation challenges across multiple EMRs in rural settings. So strong support for putting in IQR, for example, but less support for tying it to payment. And I wonder, Nick, just given the concerns that you raised and that Julie seemed to agree with in the chat, would a solution like that feel appropriate as a way to give time to figure out what refinements might look like? I mean, just given that we have to vote on the measure as it is today.
It may. And I'll tell you, we're doing this in my hospital. We're measuring this. We insist this is happening and we're measuring it. And what's happened is it's become a rote process. It's not a real conversation. If we let it wait, if we let it marinate, to the same doc with the patient for 2 days in a row, then it becomes, there's some connectivity there that can make it a more organic process.
Okay. Thank you. All right, really quick, we're at 4:57. I know there are folks that have a hard stop. Those folks should send us their votes before they leave to help us out with our asynchronous voting. While you're doing that, Ron.
I'm going to do is talk as quickly as I can. Nick, there's no reason that you can't have two conversations. You can have one on day one, and you can have one on day 2 or 3. The only thing I would say is about the awkwardness when you first meet a patient. And I said this in the chat, I'll just say it verbally. I think we need to normalize this, that you're going in for an appendectomy and you tell the patient, look, we have no expectations of anything going wrong. We ask everyone this question, can you do it? And I think if we create a world where it's just a normal part of going into the hospital that we ask you that question, then it ceases to become that awkward moment. You know, sort of some of the awkward conversations we're taught as physicians to have with patients that we're still told to say that's just normal part of being a doctor. I think we can make this a normal part of that as well.
Thank you. I think that's a good note for us to land on. So don't worry, we're not going to like turn into pumpkins at 5. We'll still be here for the folks that can stick around, and we'll share what results we can. We'll send things to folks via email after for those that aren't, but I do just want to make sure that we get a vote here while we can. I see, Melissa, did you have any clarifying points that you wanted to raise before we take this one to a vote? Sorry, Melissa, was that an accidental hand raise or did you have a comment?
Oh, I apologize. It was an accident. Thank you.
Okay.
Clarifying,
Okay.
which programs are we voting for? I just want to know.
Go back onto the last slide, tell folks. Sorry, that way you can see. You'll see it on the voting screen, but let's just go on the slide before this one. Yeah. So it's for these 4. So it's going to be hospital inpatient quality reporting program, value-based purchasing, promoting interoperability, and the PPS exempt cancer hospital quality reporting. So I'm going to turn it to Elena to get this rolling. And I just encourage folks to weigh all of the different things you heard today about this measure, weighing the benefits versus the potential downsides. And again, vote for each program independently. So Elena, go ahead.
Okay, thank you, Brenna. And again, if you have a hard stop, please do go ahead and DM us in the chat your vote if you can't submit it via the software. For everybody else, voting is now open for advanced care planning measure in the hospital inpatient quality reporting program. That is the first one we are voting on here. So I see our votes coming in.
And I can't change my vote once I hit.
You can DM me in the chat your vote if you submitted something incorrectly via the software, and we'll make sure it's reflected if you just go ahead and send it to me via the chat.
Oops.
All right, I think for this program, we are A-okay. So I'm going to go ahead and move us on to the next question. Again, if you weren't able to submit via the software, you can go ahead and DM that vote to me in the Zoom chat. Thank you for sticking with us here. All right. Okay. Next vote we have here is for the hospital value-based purchasing program. Oops, if you could, yeah, thank you so much. A little bit of a slide discrepancy there. We will be voting on all 4 though, don't worry. But the question open right now is for the hospital value-based purchasing program. All right, looks like we are good to go here. You'll be seeing the next one come up in just a moment. Okay, next we are voting on the Promoting Interoperability Program. So that is the one that you should see open right now. Again, advanced care planning for the Medicare Promoting Interoperability Program. See our responses coming in, just waiting on a couple more before we move on to our last one here. Okay. Thank you everybody for sticking with us here. In just a moment, you will see this last vote open up. All right, our last vote is open. Again, this is for advanced care planning in the Prospective Payment System Exempt Cancer Hospital Quality Reporting Program. Waiting on the last couple here, almost done. All right. Just waiting on one last one, but we can go ahead and leave that vote open if we need to move forward for time.
Great.
Oh, we got it. So we are
Oh.
good to go. Thank you, everybody.
Perfect. Amazing work, everyone. Thank you so much for hanging in there with us today. We had so many rich discussions. We really appreciate your sticking with us and contributing all day long. It's been fantastic. If you're able to stay on, we are going to share the results of votes that took place today up until the last two measures. So we can move over to that slide. Perfect. So these are results from way back earlier in the day for MUC 2025-067 hospital harm post-operative VTE. Consensus was not reached, but the majority of the committee expressed some concern about the use of the measure in the HIQR program. For the Promoting Interoperability Program, consensus was not reached, but the majority of the committee expressed some concern about the use of the measure in the PI program. Next to the Hospital-Acquired Condition Reporting Program, consensus was not reached, but the majority of the committee expressed some concern about the use of the measure in the Hospital-Acquired Condition Reporting Program. Moving on to our next measure, the ECAT measure. Consensus was not reached, but the majority of the committee expressed some support for use of the measure in the hospital IQR program. And we can move to the next slide. For ECAT in Hospital Value-Based Purchasing Program, the committee did not reach agreement on use of the measure in that program. For the Medicare Promoting Interoperability Program in the ECAT measure, consensus was not reached, but the majority of the committee expressed some support for use of the measure in the PI program. For MUC 2025-055, the Hospital 30-Day All-Cause Risk Standardized Readmission Rate Following Sepsis Hospitalization measure, the committee reached consensus agreement to recommend the measure for use in the Hospital Inpatient Quality Reporting Program. For the Hospital Readmissions Reduction Program, consensus was not reached, but the majority of the committee expressed some support for use of the measure in that program. We can move on to the next slide. So we're now talking about MUC 2025-047, the Hospital Sepsis Program Core Element Score. The committee reached consensus agreement to recommend the measure for use in the Hospital Inpatient Quality Reporting Program. For MUC 2025-045, Adult Community Onset sepsis standardized mortality ratio, the committee reached consensus agreement to recommend the measure for the use in the hospital inpatient quality reporting program. But the committee did not reach consensus on the use of this measure in the hospital value-based purchasing program. Moving on to our dialysis measures. For MUC 2025-011, dialysis facility discussion of patient life goals. Consensus was not reached, but the majority of the committee expressed some concern about the use of the measure in the end-stage renal disease quality incentive program. We can move to the next slide. Voting results for MUC 2025-064, facility level percentage of chronic hyperphosphatemia in dialysis patients. The committee reached consensus agreement to recommend the measure for use in the ambulatory surgical center quality reporting program. And I believe this is the last measure we have results to share for today. This is MUC 2025-023, Collaborate Shared Decision-Making Tool for Ambulatory or Outpatient Surgery Patients. The committee did not reach agreement on the use of the measure in the Ambulatory Surgical Center Quality Reporting Program. And also the committee did not reach agreement on use of the measure in the Hospital Outpatient Quality Reporting Program. So that's where we landed today. We will share the results on the remaining two measures as soon as we can. I will also say that part of the benefit of having these meetings is that we get to hear all of the rationales that we've collected. We've collected your considerations. All of that will be analyzed and included in our reporting. So in addition to these voting results, we also very much value, and I know CMS also values your qualitative feedback that came up through this discussion.
Hey, Meredith, it's Michelle. I'm sorry. I think there's an error on the chronic hyperphosphatemia. You have it recommended for use in ambulatory surgery center. That should be ESRD.
Oh, thank you so much. Yes, good catch, Michelle. Thank you for saying that. Yep.
Thank you.
Perfect.
Hey, Meredith, you were masterful these last 2 days at shepherding us through this process. So congratulations and thank you. Do you know what's tomorrow on my calendar? It says something about the Primer Cross Committee Roundtable, Administrative Priorities for Quality Measurement. Anyone know what that is? What is that?
Yes. We will be discussing but not voting on a group of measures that were in the MUC list overview document. So they're measure concepts, measures that are used in some programs that CMS is looking for cross-committee input on tomorrow. So there's no voting, but if you can participate in that discussion, that would be wonderful.
Got it. All right. Thank you.
Yeah. So Kate, I'm going to turn it over to you to talk us through next steps.
Thank you so much. And Nick, thank you for shepherding us through to the end, which is that we do have that roundtable for administrative priorities on quality measurement. That is unfortunately early, but we do hope that you all can join us. All committees are encouraged to attend. It's from 9 a.m. to 11:30 p.m. or 9:30 to 9 to 11:30 a.m. Eastern time tomorrow. And so really hope that you're able to join us for that. We will be posting your recommendations in a spreadsheet available on our website on, and if we could just go back one more slide, sorry, on January 30th. I did want to note that we have a lot of voting results, and there are a couple that we are still waiting to capture. We're going to be sending the slides that we shared to everyone who attended because we know that some people had to hop off. So just FYI, we will be sending those to you all as soon as we can. And so once we have our recommendation spreadsheet up on the 30th, we will be opening for a second public comment. So if we go back, thank you. So the public comment is February 2nd through 16th. And this is one where it doesn't change the recommendation group voting recommendations, but it really is important. It helps CMS get even additional data points as they continue on through rulemaking. We have We have a long history of getting really great comments for this as well. So we know that we will continue that on. Then we will have our final report. And that is going to be February 25th, towards the end of next month. You'll notice there was an incredible amount of nuance and detail in the conversation. In that recommendation report, we get into that as well as some themes across the discussion. If you are feeling the need to to relive this or get a little more detail on things, our meeting summary document, as well as our recording, will be published earlier than the recommendation report. So that will be on the 11th of February. So I did want to thank all of you so much. This is an incredible amount of work we did in 2 days. Really, really impressive. I want to thank our co-chairs so much. I want to thank all of our committee members, our advisory group members who joined the call, even though due to a compressed timeline, they didn't have their own meeting. You all still showed up and provided comments and considerations. So thank you. Thank you to our patient voices and really helping center our discussion. CMS and developers, thank you so much. We really appreciate the incredibly detailed responses and context to all of this. And so I want to thank everyone so much. I also want to note that we are a continuous improvement organization. So we'll be sending a survey out to everyone following this meeting, asking for comments on what went well, what we could do better next time. And so do be on the lookout for that. And Dr. Schreiber, I did want to turn over to you. I know you put something in the chat, but if you wanted to say anything on behalf of CMS.
No, thank you. I know we're all feeling a little tired at the end of the day, but on behalf of CMS from us to all of you, thank you very much to Patel and for really to CMS and our contractors, but most importantly to the co-chairs and everybody who participated in this meeting, the advisory group, the recommending group, the patient voice. It has truly been a spectacular 2 days filled with great dialogue, great conversation, and will greatly influence CMS actually in its deliberations about bringing forward very good policies to improve the healthcare for all Americans. Thank you.
Thank you.
Thanks all. Have a wonderful evening.
Yes, thank
Get
you.
some rest.
Oh, Rosie.
I guess I want to say that having the advisory group, this was, because of this was a shutdown situation, and that's why you had the advisory group with us. But this was a great way to include the advisory group. I really loved the way this worked with the advisory group, and especially because they brought forth many, many things that even as a patient, I didn't think about. So this was a much better use of the advisory group than I've seen in the past. So I really want to say that this has really been an experience, a happy experience for me.
That's really good to know, Rosie. Thank you for that.
Thank you.
And now I have to run because I have another meeting.
Oh my goodness. Thank you, Rosie.
Oh my gosh, Rosie.
Yeah. Bye-bye.
Bye.
Good night, all.